come across when we encounter diabetes during pregnancy, and we have a lot of confusions regarding pregnancy-induced diabetes. First thing is we need to understand what is gestational diabetes, what is pre-gestational diabetes, what is diabetes in pregnancy, what is hyperglycemia in pregnancy. Lot of terminologies are there which are quite confusing. There are few things which books still mention about over diabetes in pregnancy. So we need to be crystal clear about what is gestational diabetes and what is pre-gestational diabetes. So I think that we need to define what is GDM. I request Dr. Sureka to take up this question.
Thank you, sir. When we talk about hyperglycemia and pregnancy, we need to understand that it is one of the most common medical complications of pregnancy, and it is categorized into two different types. Excuse me. The first one is pre-gestational diabetes, which includes pre-existing type 1 or type 2 diabetes. The second one is gestational diabetes. As we understand, as of now, gestational diabetes is the most common form of hyperglycemia in pregnancy, and by definition, it is carbohydrate intolerance leading to hyperglycemia of varying severity with onset or first recognition during pregnancy. The two important factors here to be noted is onset or first recognition during pregnancy. It obviously means that we have only identified it during pregnancy. It may actually have preceded the pregnancy, whether the insulin is used to treat the disease or whether it persists after pregnancy. We still use the terminology gestational diabetes.
So if I am right, gestational diabetes refers to any amount of carbohydrate intolerance which occurs which is recognized during pregnancy, and whatever is existing prior pregnancy and patient continues to have diabetes during pregnancy is often described as pre-gestational diabetes.
Exactly.
Right. Okay. Now, or in other words, we have this wherein hyperglycemia in pregnancy is divided into pre-gestational diabetes and hyperglycemia in pregnancy. Pre-gestational includes type 1, type 2 and other variants, and hyperglycemia in pregnancy has two elements. One is diabetes in pregnancy, and the other one is GDM, which is recognized as early GDM and standard GDM. And this is the famous classification we are all aware of, classified by Dr. Priscilla White. Okay, it's often described as White's classification, which was modified, which again is classified to A1 and A2. Now, Madam Dr. Mamta, why is it so important to recognize pregnancy early, recognize GDM, diabetes in pregnancy early?
So we all know that pregnancy itself is a slight hyperglycemic with a low insulin resistance, increased insulin resistance during pregnancy, just to facilitate a good growth of the fetus. But anything which is more than physiological levels of hyperglycemia definitely is going to pose a great risk to the mother as well as to the growing fetus, not just during pregnancy, even for a long-term effects also. So early recognition will definitely give us a early start of management, treatment options, and also we can prevent most of the complications during pregnancy. So early recognition of this hyperglycemia is of course very much helpful in reducing the perinatal, maternal as well as morbidity and mortality also.
So it's important to recognize, one, to prevent damages to the mother, to prevent damages to the fetus which can occur, and three, to prevent damages to diabetes secondary to pregnancy. I think all the three can occur. I rightly agree with you. And it is all known that maternal hyperglycemia can lead to a whole lot of complications which we often see, including ARD, respiratory distress syndrome, polyhydramnias, fetal macrosomia, birth defects, etc. So it's important to recognize GDM early. And Dr. Sureka, what causes GDM? What is the pathophysiology behind why the patient will have GDM?
Gestational diabetes could actually be considered as one of the forms of type 2 diabetes. It's a complex interaction of genetic, environmental, maternal and fetoplacental factors. In fact, it is said that pregnancy is a diabetogenic state, and the pre-existing metabolic disturbances are unmasked by the increasing demands during pregnancy. There is already a background of chronic insulin resistance, and during pregnancy, the increased load to provide fetal nutrition and growth, there is increased burden on the beta cell. If the beta cell is unable to match this increased requirement, then there is hyperglycemia. like the pathophysiology of type 2 diabetes, there are several organs involved. The first three being insulin resistance in the liver, fat, and the muscle cell. Along with that, the pancreatic beta cell dysfunction adds to it, and the several other organs which are similarly involved in type 2 could also contribute. But one of the important differentiating factors here is the fetoplacental unit. The placental secretion of various hormones to maintain the pregnancy contributes to the increasing insulin resistance and beta cell dysfunction.
So it is clear that it's a combination of beta cell dysfunction combined with insulin resistance, which is contributed by the fetoplacental unit, which contributes to this one. And there are various mechanisms, various one which can be involved in the development of diabetes. Now, Dr. Mamta, what are the risk factors for the development of GDM, and what's the prevalence of GDM now?
So as Dr. Surekha just now mentioned, that it is mainly the fetoplacental unit which triggers the hyperglycemia event, whatever was physiological earlier. So along with that, we have got other risk factors like advancing maternal age, more than 35 years, ethnicity, especially South Asians, Indian Asians, and of course, previous diabetes, family history of diabetes in the first degree relatives, like mother being a diabetic, father being diabetic, the lady becomes pregnant, she carries a high risk of developing GDM. And previous GDM in the past pregnancy. If she had a GDM in the past pregnancy, there is a high chance of recurrence in the present pregnancy. And previous history of stillbirths, polyhydramnias, all these things, and few drugs also do cause a risk factor for GDM and prevalence. Coming to prevalence, we all know that diabetes as such is on rise in younger generation, and pregnancy is more common nowadays among elder people. So advanced maternal age and increase in diabetes in the younger age group, that is causing more of prevalence. So prevalence as per recent data in 2021 it's around 14% among pregnant women.
In India or world?
In India.
Worldwide, the figures may vary, but India definitely.
It is on rise.
Okay, it's on the rise. Dr. Mohan also emphasized on that. The factor says that it's around between 4 to 21%, as different as in different states. So we are around approximately around 14%. We have.
Among South Indians, it is still higher.
Still higher, right? Okay. Now, what is the importance of whether universal screening is needed or selective screening? You told that there is a set of patients who developed the GDM. Is it wise to do universal screening?
Most of the Western countries, they go by risk screening methods. That is, they have their own criteria. They categorize the pregnant woman into moderate risk and high risk. Based on 1 or 2 risk factors, they were screening earlier. Earlier, I think even we were doing this, following the same things. But now when we speak about 14% prevalence of diabetes among our population, I think universal screening is better, because will not be able to miss anybody over there. Because as we all know, GDM during pregnancy, of course, is totally asymptomatic. Only when some of the complications, like you have a congenital anomaly, polyhydramnias, or a stillbirth happens, then they used to screen earlier. Previous GDM, previous stillbirth, they used to do screening for diabetes in the next pregnancy at an earlier age. But now, since we know all the prevalence of diabetes is so high and the complications are so many, so I think universal screening still holds good, so that we'll not be able to miss anybody, will not miss anyone with diabetes.
Very much right. So though there are selective population which need the selective screening, but by and large, the number of pregnancies occurring before 25, low BMI is not a common factor which we tend to see now. It's wiser we go ahead with what is called as universal screening, which is better. And how early to screen is another issue which need to be considered.
Screening in the first visit is recommended nowadays. Earlier it was like between screen and the first visit between 24 to 28 weeks.
Right.
So, but there were few cases where we used to have cases which is what is an entity called early onset gestational
We'll discuss about that.
Yeah, we'll discuss later. But I think first visit screening is always better, and repeat it again around 24 to 28 weeks.
Dr. Surekha, which screening method is preferred? Now, this is a tough question to answer. Which screening method is really preferred? Because we have a lot of screening methods. Now, we have different guidelines coming up. We have DIPSI, we have ADA guidelines, we have IDPC HGO guidelines, we have HAPO guidelines. Lot of methods are there. Which screening method which is really important to be followed for screening?
I think this is one of the unanswered questions till now. As you mentioned, Dr. Priscilla White described categorization of diabetes in pregnancy in 1930s. And in 2023, we still have no uniform method of screening. There have been so many consensus, there have been so many meetings. Still, nobody has been able to come to a conclusion as to a uniform screening methodology. And this is important because what I do in my clinic might be different from what she does in her clinic. And so when we try to accumulate the data, there is no uniformity. The reason why we are finding so much of difference in the prevalence rates in different population is possibly because the criteria used are different. So I think it is important for us to arrive at a consensus, possibly not just national, international, worldwide consensus, to be able to have a uniform criteria. Now, if you look at the diagnostic dilemmas of GDM, we still don't know whether we should do a universal screening or a selective screening. We should do it early or late. We should use WHO, ADA, DIPSI or IAD, PSB. We should do 1 step or 2 step. We should use 75 grams or 100 grams, or we should do it 1 hour or 2 hour. I'm sure all of you will agree with that. We still don't know the answers, but let me try to simplify it. If you ask me whether 75 grams of glucose should be used or 100 grams, the difference is what were they looking at. The researchers, if they were looking at long-term maternal outcomes as to predict the future risk of type 2 diabetes in the mother, they were using the 75 grams glucose methodology. On the other hand, if you're trying to look at fetal or pregnancy outcomes, then 100 grams glucose criteria would be better. And whether it is 1 step or 2 step, possibly it is to describe the comfort of the mothers who are visiting the clinics. So one of the most important methodologies used is a glucose challenge test, where you can do a non-fasting 50-gram oral glucose test followed by plasma glucose to be tested after 1 hour. The problem with this is that there is no uniform criteria being used worldwide, whether it should be 50 grams or 75 grams, whether it should be 1 hour or 2 hour. But of course, we know the number at least is 140. So if any number more than 140 should be further tested for confirming the diagnosis of GDM is what we understand. So in India, DIPSI criteria is what is being recommended and followed in many of the outreach clinics, because any woman walking into the ANC clinic, whether at the evening also can undergo this easily, but it comes with certain drawbacks. But ADA has tried to clarify this, but they also confuse a little bit, where they say you can use either 1 step or 2 step methodology. The 1 step is 75 grams OGTT, where after 8 hours of overnight fasting, the patient has to give fasting plasma glucose, followed by 75 grams glucose load, and the postprandials are checked 1 hour and 2 hours later. The 2-step methodology is where the patient undergoes glucose load test, and if the number is more than 140, then they have to undergo the confirmatory test, which is with 100 grams glucose, and the fasting 1 hour, 2 hour, and 3 hour postprandials are checked, and the criteria are used as 95, 180, 155, and 143.
Right, madam.
Which one would you use? I would like to just say that stick to one criteria. If you are following up your patients, stick to one criteria. At least you have an uniformity, and follow-up screening method also should be the same.
Dr. Nadgo, sir, what is your experience? Which criteria you used to follow, and what is the thing which you read?
I think to simplify things, and if the patients are following up with you, I think DIPSI criteria is much better.
DIPSI is universally, now it is almost accepted.
As far as we Indians are concerned, I think there's nothing short of DIPSI.
Right, sir. So,
as an obstetrician, sir, I feel for pregnant women, especially DIPSI criteria, glucose challenge test is ideal. But maybe wherever we have a borderline, less 20 to either 130 to 140, or anybody between 140 and 149, I think we can again reconfirm with a 100-gram glucose test.
So as Dr. Nadgowda sir rightly said, DIPSI criteria is one thing which is widely accepted, followed. Anything more than 200 is often labeled as diabetes mellitus. 2 hours more than 140 in pregnancy is considered GDM. In outside pregnancy is often considered as IGT. And we have an entity what is often described as 2 hours, if it's more than 120, is often described as decreased gestational glucose tolerance, as it is called as DGGT. This is the DIPSI criteria, which is accepted almost by many of the obstetricians. Thank you, sir.
Having said DIPSI, it doesn't stop there. We have to follow up the patient. That is more important.
That's true.
Monthly follow-up is very essential.
Yes.
Otherwise, you would like to miss some things here and there.
So, madam, you told about right time to screen is between 24 to 28 weeks or at the earliest. So, which is the right way? Or is there an entity called early GDM, or are we missing out this entity also often discussed as early GDM?
Earlier we used to start screen them only around 24 to 28 weeks. That was what was being followed. But later we came across some patients who had hyperglycemia before 24 weeks also, even before 16 weeks. So we used to miss those cases, but there used to be a lot of confusion between pre-gestational diabetes overlapping this. We were not able to differentiate whether they were pre-gestational diabetics or they were early onset diabetics. So there is a new entity what has come now as early gestational diabetes mellitus, where there is a intermediate hypoglycemia in the early weeks of gestation, where the lab values may show that it is conventional GDM, it may accept, but still they fall short for the over diabetes. So then we cannot classify them as over diabetic also. At the same time, we cannot blame them, label them as gestational diabetes also. But these patients, the problem here is they tend to develop gestational diabetes more than the people who had normal hypoglycemia in that period. And also a lot of complications during pregnancy as well as fetal complications were more among them. So what is that is nowadays we don't have much of research in this field. So maybe we need to take up more of such patients and we start screening them early and follow them up throughout pregnancy as well as long term to know this.
Very much true.
Yes.
Very much true. Dr. Sheshaya, as father of this one, has given some information about the prevalence of gestational diabetes, which is detected quite earlier during the early pregnancy. And we have several wherein there are few meta-analyses where they have shown that GDM can be seen much earlier. So it's always wiser we screen the patient at the first visit of her antenatal checkup. That will be the right way of looking for this one, and each subsequent visit need to be monitored for or need to be screened for GDM. I think you agree with that. Thank you.
I would also like to add here, sir.
Yeah.
Blood sugar monitoring is not an expensive tool.
Yeah.
It's a simple test that would just cost 40 rupees. So there is no harm in screening for diabetes at the first ANC visit so that we know what are the future risks also, so that we can at least recommend them the nutritional advice to maintain normal body weight and also healthy food habits.
Now, Dr. Sureka, now we have labeled that patient is a gestational diabetic. Now, how often we need to screen and what are the targets? What are the glycemic targets we need to achieve when we have a patient with gestational diabetics? We need to be monitored, and we need to monitor how frequently we need to monitor and what are the targets which are required.
In a patient who has been labeled as gestational diabetes by the criteria, we recommend them initially nutritional therapy and exercise. Following that, we ask them to do a self-monitoring of blood glucose, and the targets are defined as fasting plasma glucose less than 95 and 1 hour postprandial less than 140 and 2 hour postprandial less than 120.
Right.
If you see here, the fasting plasma glucose 95 is very easy to achieve. The postprandial, usually we ask our patients to do the 2 hour postprandial, but when we are seeing macrosomia on the screening that they do, the fetal scans, then I think we should target the 1 hour postprandial also. What is the frequency of doing the test? Since it is self-monitoring of blood glucose, initially if the sugars are quite high and we need to decide whether we need a pharmacotherapy, at least alternate days, 4 readings per day is recommended. And if the readings are within the normal range, you can bring down the frequency of monitoring and at least weekly. And the lab and the hospital visits, 15 days to once in a month should be recommended for the follow-up.
Okay. Now these are the targets you universally agree about 1 hour less than 140 and postprandial should be less than 120 and fasting should be less than 95 as per the SOG guidelines. And these are the different guidelines which again tell you that what are the targets which are recommended. And now thing is, we have a lot of CGM devices. Many people ask for it, and we are using it regularly in type 2 diabetics. Now, what is the role of CGM in gestational diabetics?
Yes, as you mentioned, continuous glucose monitoring has been found to improve the outcomes both for maternal and fetal in pre-existing type 1 diabetes more so, and also in type 2 diabetes on insulin. When coming to GDM, the role of CGM has not yet been established. By the guidelines, if you look at it, the role for CGM is as an add-on to self-monitoring of blood glucose. But looking at the current data, there have been several studies that have looked at CGM derived biomarkers, especially time in range, area under curve, mean blood glucose, and daytime mean blood glucose, and MACE, which have been associated with large for gestational age children. And that is why now the guidelines say that you could use it to improve the fetal outcomes as an add-on to self-monitoring of blood glucose.
And that will be much more convenient for the patient. The patient doesn't need several pricks, and the patient can conveniently monitor during this, at least for the initial glycemic control.
Absolutely. Multiple pricks per day can be avoided.
Yeah. Now, now once we have labeled that patient is diabetic, and what is the next line of therapy? What are the nutritional and exercise recommendations for
Once we
gestational
label them
diabetes?
as gestational diabetes, I think the first thing we advise our patients is
MNT.
nutrition, MNT, that is medical nutrition therapy. So the main thing about medical nutrition therapy is like you need to have a carbohydrate controlled balanced diet. You cannot just tell her any pregnant woman, first of all, we are worried about the calorie requirement also for the fetal growth. So we cannot, like in non-pregnant patients, diabetes, how we manage, we cannot go with a strict diet over here because the calorie requirement for the growth of the fetus is very much essential over here. So probably we need to calculate take the BMI into consideration, the period of gestation, the kind of lifestyle what the patient has, either whether it is sedentary or whether she is a physically hard-working lady, and also the nutritional requirement. Based on that, we give that. So the basis of any MNT diet advised is 50% of the carbohydrates and 25% from fat and 30 to 40% from fat. Of course, nowadays all this more of fiber-rich diet is also advised. So I think here, of course, all the obstetricians, they'll take the help of a nutritionist who will advise them, because every diet for every patient, it is tailor-made.
Right.
We need to know the type of diet, the type of work, the other comorbid conditions, what she has got, like preeclampsia, obesity, and those things, and we'll give them. Definitely, MNT has been successful in bringing down the complications in GDM alone.
Yeah.
But not all patients, and of course, those who we put on MNT definitely needs to be monitored very strictly and regularly, so that any time of we know that diet is not able to control the sugars, maybe we need to switch over to the pharmacotherapy. So it needs a monitor.
So diet is definitely
Diet is
essential.
definitely the
and
first
the
line,
next line will be exercise, which is
yes,
almost pivotal.
The simple exercise, what I advise my patients is 15 minutes of walk after every meal. I think that is the best thing which anybody can, whether she's working, whether she's a homemaker or whatever it is, 15 minutes of walk after every meal, they can strictly do it, and it definitely helps them. And of course, other exercises like
Now the emphasis is on
and
yoga.
Yoga, yes, of course, they are all helpful. But 15 minutes of simple walking, whether it is workplace or anywhere, she can easily follow it up and they can do it. So lifestyle modification, diet and exercise will definitely be able to control the sugars to some extent, but needs regular monitoring, because we don't know when they can definitely go out of control also.
Thank you. Now, when to initiate treatment, Dr. Surekha? When to initiate treatment if not controlled with diet and exercise? Diet and exercise has been tried for, usually we try for 2 weeks. If not well under control, how do you initiate, and how do we initiate that treatment?
It's important to understand that medical nutrition therapy and physical activity can control gestational diabetes in at least 75% of our patients. The rest of the 25% will require pharmacotherapy. When do we initiate, and what are the cutoffs that we need to initiate? This is something that still needs a lot of guidelines and inputs. There have been several studies that have done, and from as low as 15% to almost as high as 50% cutoffs, if they are high, then therapy has been recommended. But it would suffice to say that pharmacotherapy needs to be considered in women with GDM when, despite of adequate diet and exercise, more than 20% of the blood glucose values are above the target of fasting 90 milligrams and 2-hour postprandial more than 120 over the next 1 to 2 weeks. So that means to say we need to be in touch with our patient where they report their blood glucose values to us, and if more than 20% of the values are above the targets, we need to initiate pharmacotherapy for them.
Now, once we say that pharmacotherapy, these are the cutoffs we usually stick on, and what is the choice of insulin? You will be the right person to answer. What is the choice of insulin? We have a lot of things. We have basal, regular, NPH analogs, analogs which are approved, which one we can use, which are recommended during pregnancy, and what's the choice of insulin which we use?
Yes. Insulin is the first line therapy for management of hyperglycemia in pregnancy, and rightly so, because it is the one that is considered as safe, effective, and time tested. And it doesn't cross the placental unit, and hence the use of insulin during pregnancy is considered as safe. And in comparison with oral drugs, the data for insulin has been there for a long time. And when you use what type of insulin, what are the regimens used, this is something that is variable as we see in our clinical practice. The regimens used could be use of pre-mixed insulin using intermediate acting insulin and a short acting insulin given twice daily, 30 minutes before breakfast and dinner, or as we use now multi-dose insulin where 3 injections of rapid acting insulin given with each meal and an intermediate acting insulin given at bedtime. This regimen gives us more flexibility where we can adjust the individual doses to target both the fasting and the post-meal readings better. Now, what is the starting dosage that we can use? The typical dosage would be 0.7 to 1 unit per kg per day, split it between each meals and also the basal insulin, and then take it forward.
So it's preferable to start with insulin. Then which insulin to prefer? Which one is the right one? Usually you prefer to use regular insulin, the basal bolus regimen, or which one is the thing which is often used? Or the premix?
Any insulin can bring down blood glucose levels.
Right.
Now, when you compare the human insulin and analog insulin, both have been found to be efficacious in bringing down the blood sugar levels. But what is the difference? Compared to human insulin, analog insulin brings down the postprandial blood glucose much more faster.
Aspart.
Especially the 1 hour hyperglycemia is targeted better with analog insulin. And the second is the risk of hypoglycemias is lesser with analog insulin. And that is why the current recommendation is to use analogs over human insulin. And coming to FDA approval, we all know that human insulins are approved for use in pregnancy. Short-acting analogs, if you look at, Lispro and Aspart are category B, and coming to long-acting insulins, the Detimir is category B, while Glargine is category C. So, taking that into consideration, Lispro and Aspart are the most common analogs used during pregnancy. For the long-acting insulin, it is the NPH that is used, but nowadays Detimir has also been used.
Can we have a word from Dr. Nadgov, sir?
Yes, I think 1 or 2 comments to be made regarding the time period after starting insulin injection. For 1 to 2 weeks, you are supposed to wait. My question is, or rather my suggestion is, when you know that hyperglycemia is toxic, both to the fetus and to the mother, why not start insulin straight away once you know that the patient is hyperglycemic, provided you take care of the hypoglycemia. That's number 1. Number 2 is, I usually prefer a basal bolus insulin rather than multiple insulins as far as we Indians are concerned. If they are not stable with those things, then I think you go in for 8-hour insulin or 6-hour insulin with a rapid acting, maybe glulisine or maybe aspart or maybe fiasp also for that matter.
Very much right, sir. But we have seen that 75% of the GDMs get controlled with just MNT itself.
This is more of Western statistics than our Indian statistics.
Even Indian statistics say that most of the diabetics...
But I personally believe that you once you know that hyperglycemia is toxic, why do you wait for 2 weeks if they don't come to you for a follow-up?
Dr. Mamta can
Sir, on a lighter note, I think definitely what you said is most of them will require insulin at a later date, maybe after 4 weeks. But to sensitize our pregnant women, because first and foremost, when we tell them that, oh, you have developed diabetes, they really is not accept it most of the time. So at least to sensitize will take some time. So I think 2 weeks, we can give them a trial with MNT and exercise. Slowly they will realize and ask them to monitor blood glucose levels at home. Once we show them after 2 weeks, see this is your values, at least it is not getting. So probably then we can definitely.
Madam, I've been in this field for the last 45 years. For the last 45 years, I think there's no problem, or rather, there's nothing bad to tell them that you have got hyperglycemia and you need insulin therapy at this stage, because you have to take care of your child and yourself also. If not the wife, the husband at least understands, or the mother-in-law will understand.
Right, sir. Thank you. So this is the dosing which we often follow, 0.7 to 1 unit per kg per day in divided doses. And about the oral drugs, Dr. Surekha, what is the role of metformin? And Western books still mention about the use of glyburide or glibenclamide. What is the role of oral drugs in the management of?
I think if you look at the history of GDM, there have been several anecdotal mention of use of oral drugs during gestational diabetes without much issues. And again, looking at the evidence, there have been comparison between oral hypoglycemic drugs and insulin, and they have looked at maternal and fetal outcomes, and that is where the difference lies. The insulin, we know that when used appropriately in the right doses and the HbA1c, the blood sugars are controlled and achieve target, the fetal and maternal outcomes have been the best. But when you look at the data for glibenclamide, if you can see that, glibenclamide has been commonly used drug during pregnancy, especially in the Western countries like United States. And unfortunately, what we note that once we put them on glibenclamide, at least 20% of the patients will still require insulin. So they might spend some time with hyperglycemia, and as Nadgowda sir said, that can add to the fetal outcomes. So there has been a study which looked at efficacy of glibenclamide versus insulin, and they found no differences in the maternal glucose levels or the fetal outcomes. But unfortunately, the meta-analysis done said that glibenclamide was associated with higher risk of neonatal hypoglycemia. That might be a fact, and also macrosomia. So we are still waiting for long-term safety data before we can confidently use glibenclamide as an alternative to insulin. So as of now, glibenclamide is still not recommended as a first-line therapy for gestational diabetes.
Regarding the role of metformin,
Yes.
because many patients will be on PCOS, on metformin, they conceive and become pregnant. And what is the role of continuing that metformin during pregnancy?
Yes, if you look at the pathophysiology of gestational diabetes, it is all about insulin resistance. So metformin, being an insulin sensitizer, should have been the first-line therapy for use in gestational diabetes. Again, the recommendation is based on outcomes, maternal and fetal. So if you look at the fetal outcomes, usage of metformin has been studied in a big study called as Metformin in Gestational Diabetes study, and they found that usage of metformin was well accepted and was associated with lower birth weight and was associated with similar outcomes. But the long-term study showed that fetal waist circumference could be still higher with metformin, and hence has not yet become the first-line therapy. Coming to usage of metformin in PCOS, the recommendation still says that you need to stop metformin at the end of first trimester.
So glyburide definitely has a higher risk of NICU admissions, hypoglycemia, respiratory distress, birth injury, and abnormal gestational age. So glyburide usually we don't recommend. But metformin, you say it can still be used if patient has PCOS. But again, what is more important is the biggest limitation is the failure to achieve the optimal control of getting euglycemia during pregnancy, which may not happen in toto.
Yes.
Which we may need that we have to switch over to insulin.
If the hyperglycemia is mild and we initiate them on metformin or glibenclamide and the sugars are under control, it's fine. But if the sugars are still higher, the daily titration that we can do with insulin is not happening,
Cannot happen with
achieved with the OHS. That's the biggest difference I find when we initiate a patient on OHA or insulin. If we educate the patient how to titrate the insulin dosage, they can do it on their own on a daily basis and achieve the glycemic control faster with insulin.
Thank you, madam. Now, Dr. Mamta, what are the maternal and maternal complications usually anticipated during pregnancy and after pregnancy with GDM?
Maternal complications and neonatal complications, a lot to say in this there. Maternal complication, the first and foremost thing is preeclampsia, pregnancy-induced hypertension, preterm birth, then polyhydramnios leading to respiratory distress, and excessive weight gain, obesity, and then going in for infections, lot of maternal infections, they're prone for it. And during labor, lot of instrumental deliveries chances increase, and increased risk of cesarean deliveries is more. And prolonged labor, of course, and ketoacidosis, both in early pregnancy as well as during labor, they're prone for ketoacidosis unless not well controlled. And postnatal period, definitely, sometimes, most of the times, immediate postpartum period, definitely the sugars will be low. They may not require insulin also for first 48 to 72 hours. But of course, they need a regular follow-up because as we know, the recurrence is also there in the next pregnancies, and they have a risk of continuing to become over-diabetes in the long run. So I think these are all the maternal complications during pregnancy. So
Now, how do we manage during labor? This is the thing which you need to.
yes, definitely, sir. Of course, we do take the help of physician. That is there. So gestational diabetes ladies, I think when to deliver, that was the big question, challenge for obstetricians, because we know that early, if you deliver 1 week earlier, will bring a lot of respiratory distress, NICU admission will go up. And if you deliver late, chances of stillbirth and IUD. So of course, the right decision to deliver at the right time is a big challenge to the obstetricians even today. But when we definitely, most of the time, GDM well controlled on insulin, we can deliver them at least by 39 weeks. That is when they complete 9 months by their dates. So induction of labor, of course, has to be done at 39 weeks if they don't go into labor. And if they get into labor spontaneously, we can allow them for vaginal delivery. It is not that cesarean section is the choice of delivery, route of delivery. And if they're on insulin, they need to skip the dose of insulin, and sugar monitoring throughout labor every second hourly is advocated, and see that they don't get into ketone bodies. And based on the sugar levels, probably we may have to start them on an insulin drip also if the sugars are more than 120 to 200. And delivering, of course, they need a prolonged labor will be there. So epidural analgesia is definitely advised for them. And intrapartum, instrumental deliveries, and if at all, if you are suspecting there is a macrosomia or shoulder dystocia, a decision for cesarean sections may also need to be taken. So these are the problems.
Now, what is the role of postpartum monitoring?
Postpartum, of course, monitoring is definitely required. The first assets, we can monitor them immediate postpartum period, 6th hourly or 8th hourly CBG monitoring. Based on the sugar levels, insulin may be advised or may not be required. And majority of the patients, well-controlled GDM, post-delivery, definitely the sugars will come down. Most of the patients don't require insulin during the first 48 hours. So what we follow is, we usually 6 hours in the first 24 to 48 hours, then 6 weeks follow-up, then again at 6 months, and then 1 year, and every year till they plan for the next pregnancy, especially preconceptional counseling and evaluation before the next pregnancy.
But you say that it is right to, at the time of discharge once,
Yes, sir.
and 6 to 12 weeks
Yes.
postpartum,
6
definitely
weeks, 6 months, and 1 year.
it's
till for the
needed
next
to
3 years,
monitor
3 to
for
5 years monitoring. Is
during the postpartum period. Now, what is the incidence of GDM converting into diabetes? Dr. Surekha,
Post-delivery, most of the
2
women are
minutes, we
so
are
busy in child care that they forget that they have a risk of converting into type 2 diabetes later, and hence it is important for both obstetrician and the diabetologist to inform the patient that they come with higher risk of progression to type 2 diabetes. The statistics suggest that the risk of developing type 2 diabetes later in the age is almost 10-fold higher. And at least 50% of the women with GDM develop type 2 diabetes later over the next 10 to 15 years of follow-up. And this risk increases with higher BMI, Asian ethnicity, increased maternal age, and the duration of follow-up. And if you look at the statistics, the risk of developing type 2 diabetes at 10 years follow-up is 20%, and by 40 years follow-up, it is increased to almost 50%.
so there is a 50% chance of getting GDM. And what are the long-term effects of GDM? This is the last question. What are the long-term effects of GDM which you can consider?
Yes, gestational diabetes comes
To
with
the offspring
long-term
and to
risk
the mother.
for both mother and the child. And the epidemiological studies have shown that there is increased risk of cardiometabolic sequelae for the offsprings with women with diabetes. So this, one of the studies that looked at this very in detail was Danish population-based cohort study, and it showed almost 19% increased risk of early onset cardiovascular disease in children born to mothers with gestational diabetes. And there was this UK study that looked at GDM, it was associated with alteration in fetal cardiac function and structure, reduced systolic and diastolic ventricular function persisting in infancy. And what does HAPO follow-up study tell us? Maternal hypoglycemia in pregnancy was associated with higher risk of IGT in childhood, and also childhood obesity.
And to the mother.
Yes, for mother, the increased metabolic risk remains, increased risk of type 2 diabetes, cardiovascular risk, and also malignancies. So we need to monitor these women for their lifetime to look at these risks.
Thank you for the panel. So to conclude, so gestational diabetes is a carbohydrate intolerance resulting in hyperglycemia of variable severity with the onset or first recognition during pregnancy. Both beta cell impairment and tissue insulin resistance represent critical components in the pathophysiology of GDM. It's always recommended. Universal screening appears to be the optimum approach, especially in Indian women. Right time to screen, though it's 24-28 weeks, it's always preferable during the first antenatal visit, which is definitely the right one. Diagnosis is preferable done by one-step method, the DIPSY criteria which is to be followed. MNT forms mainstay of therapy, and if not controlled, to be immediately started with insulin. Metformin tends to be an alternative option in obese, borderline, or GDM with PCOS, but again, optimal control may not be totally achieved with that. Proper management of labor definitely is vital. All GDMs need to be followed up regularly for the development of type 2 diabetes in future and long-term complications. Thank you. Dr. Nadgoda sir's comment at the end.
Before I make any comments, I have one question. Is there any time for one question?
Yes, sir. Yes, sir.
A question to maybe our diabetologist or our obstetrician can answer this. Suppose what we face as physicians is patients are diabetic. Most of them are on OHs. They come to you when they are pregnant. What are you going to do?
At their first visit, when they come to us, we'll see at what period of gestation they have come, sir. If they come to us in the first trimester.
They come to me first.
Yes.
When I come to them, they are pregnant, then I send to you. They're already on OHs, maybe 1 month, 2 months, or 3 months. Then when they come to you, what are you going to do?
Definitely, we are going to evaluate with the blood sugar levels, see their HbA1c levels and the sugar levels. If they are well controlled, of course, we can still continue the pregnancy first, sir. It is not an indication for medical termination of pregnancy, even though they are on OHSs or even though HbA1c is more than 7 also. So they can continue, and we start them on insulin, switch over to insulin, and continue to monitor them, treat them, and manage pregnancy. But we have to educate them that and tell them the risks of complications, like especially the anomalies. Because euglycemia, especially periconceptional euglycemia, is the main thing which is responsible for the avoiding of congenital anomalies. So if we don't have euglycemia around periconceptional, that is somewhere around 15th day of ovulation to by the time pregnancy is confirmed, around 4 to 5 weeks. That is the main period where the organogenesis and this embryopathy sets in. So if they have high chances of going in for early abortions and anembryonic gestations. They have a lot of congenital anomalies. So we have to scan them and do all the tests which are required to do the anomalies, rule out anomalies.
So you want to scan them, do the blood test to see the anomalies, then you want to continue the pregnancy?
No, sir. Continuing pregnancy with due risk of anomalies. They need to know that, of course, there is a risk of anomalies. If anomalies are detected, anyway, we need to terminate. Otherwise, if everything is fine with them, then we can.
So if they are on insulin, there's no problem at all?
No problem at all.
If they are only on OHs, they are going to do all these things?
Even on insulin, if it is not well controlled, then we need to explain it. So
Thank you.
uncontrolled
Thank
sugars, hyperglycemia.
Yeah, Dr. Pradeep, one more question.
The latest guidelines that we have as far as Professor Shishya is concerned is early diagnosis at 8th week of pregnancy with the 2-RPP of more than 110 is the ideal time for us to start an intervention if at all we need to make sure that we are able to address this in a more effective manner. So the guidelines that he had suggested recently in our RSSJ conference was that 8th week you do a 2-RPPBS. If it is more than 110, wait for 2 weeks. If it settles down, that's well and good. In the 10th week onwards, if it's still persisting to be high, then you start off treatment with metformin. So this is the latest guidelines that we have. Any comments from the expert panel here sitting here?
That's what, sir. We had a discussion over this. That is the new entity, what is called as early onset gestational diabetes mellitus, which is definitely not belongs to the conventional gestational diabetes by definition, nor it goes to the over diabetes also. So it is a transient intermediate hyperglycemic state in the early pregnancy, which can be confused either with over diabetes as well as they can develop gestational diabetes at a later date. So these are the women who require again rescreening around 24 to 28 weeks and put them on metformin if required, as we know that metformin is a safe drug, and advise them about nutrition and exercise and lifestyle modifications from 8th week itself. so that we can avoid complications. Our development of GDM, going into GDM, can be lesser with that.
Last, Dr. Anil sir. comment.
So, does metformin usage at that time, whenever we have identified hyperglycemia at the 10th week, using metformin to continue till 16 to 18 weeks to make sure that there is no more fluctuations, and then if it increases, then you can switch over into insulin. Is that an acceptable practice?
I think in this intermediate hyperglycemia, where the blood sugar is more than 110 but not has reached 140, is identification of a high risk category. The initial advice would be definitely nutritional therapy and physical activity. If the patient is a high risk category where the possibility of progressing to diabetes would be higher than metformin. I don't think the first line would be initiating metformin. It's still nutritional therapy and exercises.
Hello. This question is both to Dr. Sureka and the gynecologist. Whether usage of metformin during first trimester, how many patients have you seen in your clinical practice? What's your experience?
I think a significant amount of patients come with metformin during the first trimester of pregnancy, and they still do well. But as you said, the insulin resistance increases during the second trimester and peaks during the third trimester. And that's when they need the add-ons. So metformin during pregnancy, first trimester of pregnancy, I think we see a lot of patients.
But as you said, the anomalies were almost similar. But there is one pulmonary valve atresia was more common in patients who have used metformin during first trimester.
Yes.
So that I think we should
There's
look into.
studies.
So some of our patients, maybe we have to stop metformin and start insulin when they come to us in first trimester.
What happens when we stop metformin and initiate insulin
may
is that
go up. But
Sir?
we have to, as per the studies, if the pulmonary valve atresia is more, we have to explain to them. When we explain, definitely the patient will not agree with it.
Absolutely, sir.
Thank.
Especially transitioning to insulin is a phase where they can end up with hyperglycemia and becomes difficult to manage without metformin.
Thank you. We are running short of time, so we'll have a photograph and quick photograph and we'll pay. Sir, Nadguru sir, please.
With the permission of the speaker and the chairpersons, we have a little shuffle happening here. Instead of intermittent fasting in diabetes, the evidence, we are going to talk now on limb salvage in diabetic foot, Indian experience. And to speak on this, we have with us Dr. Vijay Vishwanathan. And to chair the session, we could request Dr. Amit Jain and Dr. Vijay Kumar. I would request Dr. Ravi Kumar sir to chair the session because Dr. Vijay Kumar is not here.
Good morning, everybody. I know each one of us today are in a phase of having a knowledge that's widespread. And one topic today we are looking is we are not looking up. Probably we are going to go look little down because that is something which is more important. And we think we have one of the right person talking. We all know Dr. Vijay Vishwanathan. To introduce him little, he is one of the pioneers in diabetic foot because a lot of work on prevention has been done, just not at national level. He's very well known at international level also. And recently, sir was also a president of D-Foot International, one of the largest bodies. And sir has extensive work both in diabetic foot and diabetic kidney disease. His passion in diabetic foot is very well known, and we can think the whole work what he's gonna show it now in his presentation, sir.
So
The ice is yours.
Chairman Dr. Amit Jain, my good friend, and Dr. Ravi Kumar. And my talk is only for 10 minutes. And I would like to thank Dr. Bijay Patni for exchanging food for foot. Food for foot. Yours is about food and mine is about foot. So in the next 10 minutes, this is going to be the flow. How do we make an early diagnosis of high-risk feet? We have to follow the principles of wound healing. If you want any wound to heal well in the foot or wherever, this is Mike Edmonds showed in 1986. We need a multidisciplinary team. And lastly, education. So I'm going to show you proof for all of these points. The first point is, actually it's the last point. We showed in 1999 that patients in India, particularly those with a lower level of education, socioeconomic status, do not possess knowledge about diabetic foot. So if you have people coming from rural areas, spend little more time with them and educate them. And we have shown and published in Diabetes Care in 2005 that if you educate people, especially those with the lower level of socio-economic status and so on, it pays well to prevent amputation. We have shown it in Diabetes Care. So social cultural practices are very important. Loss of sensation is very important, and so the socio-cultural practices. This is a slide not from me, but from Mike Edmonds and Ali Foster from King's College, London. And we as physicians sitting in this room, I think the pointer is not working. We need to concentrate on normal foot and high-risk feet. Once we go to stage 3, 4, 5, 6, we need Amit Jain's help as a podiatrist, as a surgeon, and it becomes expensive. So we physicians, we should examine the feet of people. Heart failure is important. I'm not saying it's not important. I'm not saying kidney is not important. But it's equally important to remove the footwear. If you don't want to do it, don't do it. You have people to do it. But high-risk feet and normal feet, you should distinguish. About 70% of people with diabetes are having normal foot, and stage 2 is where you have high-risk feet, where you have loss of sensation, deformities, or whatever. So you have loss of muscle power. So stage 2 is very, very important. This is a scenario we want to avoid. Take this lady who came to us a few years ago. She lost one leg due to diabetic foot infection, and the surgeon wanted to do below-knee amputation on the other side also, on the left leg also, which I said no. She's got an eschar in the heel, which will heal. So heel is difficult to heal, we know that. But so that brings me to the first point: how do you make an early diagnosis? So neuropathy, I had this good fortune of writing this editorial on neuropathy, along with neurologists from United Kingdom and United States, in the Nature Reviews in 2019. And diabetes, 70% of diabetic foot lesions are due to diabetic neuropathy, loss of sensation. And we know that diabetes causes demyelination and axonal degeneration. Now these changes occur even during pre-diabetes. We have published it in the Indian Journal of Neurology, which is the official journal of the neurologists. About 19.7% of people have neuropathy even at the stage of pre-diabetes. So we shouldn't wait longer. And in this study, which we did cross-country from Germany and Italy and Germany, Africa and India, we found that the most important factor, whether it was Germany or India or in Tanzania, we found that it was neuropathy again. So neuropathy is a very important risk factor. The first fiber to be involved in diabetes is the small fiber. This is not my study, the Dan Ziegler studies from Dusseldorf. So the A-alpha, the A-beta fibers are involved, and you have the best test which you can do is the temperature sensation. You have the corneal confocal microscopy done, which is advocated by Riaz Malik from Pakistan. But that's not possible. It's 25 lakhs for the machine. So you can't look at the corneal confocal microscopy. It is the best test for small fiber neuropathy. But you need a 25 lakhs machine for it. Where do we go for it? So temperature is good enough, and you test temperature. The large fiber you can test with biotismeter or with monofilament. In the RSSDI Save the Feet, we just used monofilament, a 3-minute foot examination, and we are about to publish that. Rakesh, I'm going to publish it before your diabetes, India, diabetes, defeat diabetes, yeah, it's going to come before that. So monofilament test was used in Save the Feet project of RSDI, National RSDI, and we can test the large fiber with it. Vibration perception is also a large fiber testing. Don't forget that about 30% of people have peripheral artery disease. So this is a machine which you can get from Huntley. It costs 30,000 rupees. And you should look at you can feel the posterior tibial pulse and dorsalis pedis. But if you have swelling, what do you do? So you have to use and document for medical legal purposes that the patient has peripheral artery disease. You can also do ABI. About 80% of people do not have calcification, so ABI is quite good. And once you have an ulcer, the principles of wound healing, I'll finish in another 5 minutes, Amit, and then you can take questions. What?
You have 10 more minutes, and no issues.
Yeah, but I'll finish in 5 minutes. We have mechanical control. You have to offload the pressure. You have wound control. You have microbiological control, vascular control, metabolic control, education control. 6 controls, again, not given by me, but my colleagues at King's College London, Mike Edmonds and Ali Foster. In their book, it's written. It's a multidisciplinary. If you follow these 6 guidelines, any ulcer in the foot will heal. If you don't do any of these 6, you will end up in an amputation. So I'm going to show you in the next 5 minutes 2 examples of how a multidisciplinary team. This patient did not have blood flow in the leg and was advised below-knee amputation. So this is my main topic, limb salvage. So we did a wound debridement, and after wound debridement, we did this is not shown here. She had less of blood supply, so we did a bypass. And then we stabilized her left ankle joint with an external fixator. And you see at the last slide, we have healed it. We have achieved limb salvage. We have saved the leg of this person. Let us send people we all will go one day to the graveyard or to the cemetery. But let us send these people with 2 legs, not with 1 leg. So that's the dictum which we have to follow. We have to prevent amputation at any cost. And that's why they're coming to you. So you should prevent an amputation at any cost. That's our duty. So this, if you don't have, follow the fast track pathway. You refer. If you don't find pulsation, you refer. Don't treat patients whom you can't treat. So you refer them to the higher centers. This was another patient. I'll show you the pictures. The pictures are little. So this patient also was advised below-knee amputation. Heel ulcers are very difficult. It's ischemic, necrotic, calcaneum. And what we did was we did an angioplasty, and we found narrowing of the distal. So we do the DSA, digital subtraction angiography. And we found that there was a block in the distal superficial femoral artery. We put a stent. India has progressed very well, and we have fantastic interventional radiologists now. Vascular surgeons are there, but interventional radiologists do a much better job. And they put a stent into the femoral artery, and you can see in the next picture In this picture, the plantar vessels have opened up. And this lady had perfect healing, and we did not amputate. So limb salvage is very important. I would like to end in the last 2 minutes with the IWGDF guideline. And I was fortunate enough to be in the midst of Sikobus, David Armstrong, and Catherine, and Gustav, and Carlo, and Peter Lazzarini, writing up the IWGDF guideline 2023, which was released in Holland about 4-5 months ago. So the IWGDF guideline is the truly international guideline, and all of you should read the IWGDFguideline.org, IWGDFguidelines.org. People like this who have deformities in the feet, like Charcot foot, TCC is a very important tool to save the feet, to reduce the pressure, principles of wound healing, if you follow. And we have made a Crow Charcot restrained orthotic walker for 2,000 rupees for offloading Charcot foot also. If you have Charcot foot without ulcer, it's fine. But if you have an ulcer like this is with courtesy to my friend Sharad Pense from Nagpur. And lastly, I think we should teach everybody the art of self-examination. It's not very difficult. Just as you tell people to take the blood pressure at home with a home blood glucose monitoring, or home blood pressure monitoring, home blood glucose monitoring, self-examination of the feet, please teach them. Please teach them the art of self-examination of the feet, and they will examine the feet by themselves, or if they can't reach out to the sole of the foot, they will ask their son or daughter or spouse to do it. So I'd like to thank you, Amit, for this opportunity to talk, and also Ravi Kumar and Manohar for asking me to talk this afternoon.
Thank you, sir, for the wonderful, short and sweet presentation. Any questions from the audience? Sir is there.
Questions will come only in pregnancy, not about Ravi Kumar will get all the questions.
Yes, sir.
Not in diabetes foot. I know a tough question is coming. 2 tough questions are coming.
I know the vessels are all sclerosed in diabetes, but is there any role for vasodilators in a diabetic foot?
So vasodilators are useful only in established peripheral arterial disease, and it is only for claudication. It is not to heal a foot ulcer. So if people think silostazol is good for healing a wound ulcer, you are mistaken. You can remove the claudication pain. You can't heal a foot ulcer with silostazol. You can give it. If you don't give it for somebody with peripheral arterial disease, the court can ask you, why didn't you give silostazol? But not for healing a foot ulcer. You have to revascularize. Pradeep, ask a simple question.
So, kudos to the kind of work that you've been doing, showing us how our limbs can be salvaged, where we have given up certain situations where things were written off, and then those are the kind of cases that you've salvaged. What we as treating physicians should probably be taught about is the exact point at which they should probably transfer the case to the right person, whether it is a foot surgeon or a vascular surgeon. If that kind of a knowledge is passed on to us as treating physicians, that would probably be the take-home message.
Pradeep, if you, as the president of D-Foot International till June, we wrote up this fast-track pathway. It was a study from Italy by my predecessor, Louis Martinez, and Jose Luis Martinez. And he showed in Italy the fast-track pathway. It categorizes those people whom you can keep in Bengaluru, those whom you refer to some higher center, and salvage a limb. ABC is there. So it's called a fast-track pathway. Please follow that. It's written by D-Foot. It's officially a D-Foot international property. It's there, the fast-track pathway. Fast-track pathway is published by Jose Luis Martinez and his colleagues, Marco and so on from Italy. But it's a D-Foot paper.
The role of
Yes,
hyperbaric oxygen.
Hyperbaric oxygen is good after revascularization. Again, some people think hyperbaric oxygen is a phenomenon which can heal ulcers. No, it cannot heal ulcers. I was also a part of the wound healing, I didn't mention that. Wound healing, we have given only a conditional recommendation for hyperbaric oxygen and topical oxygen. We're not given a strong recommendation, it's only a conditional recommendation. After revascularization, if you want to open up the collaterals, you can use hyperbaric oxygen. Vijay Patni is waiting to talk about food. Vijay,
one small
last question.
Yes, sir. Sir, regarding you spoke about the Charcot foot with the hind foot ulcers. So regarding the offloading, when we see early cases with just the hind foot ulcers, we have a lot of anterior rockers for the forefoot offloading. Any specific, because sometimes I've seen the posterior rocker, which is very difficult to walk. So any options we have for an early?
There is an option from Camillo, I shouldn't be telling his name, from Podatis in Italy, where he has patented. It's not yet, you can't use it, you can't copy his patented product. He's got a Terra heel, where the heel portion is offloaded. And you can use it in fractures of the calcaneum. You can use it in cases like this. So Terra heel is the name. We are importing it from Italy, from Camillo, and it costs $14,000 after customs duty. It's a little difficult, but the patient can walk in spite of a heel ulcer.
Otherwise, still, up till now, we have only complete offloading.
Yeah, complete offloading, but you tell somebody not to walk, it's very difficult. So if people want to walk to the bathroom, to take water, they don't want to depend on their son, daughter, spouse to get water or to pee 5 times a day.
Thank you, sir.
So offloading is difficult.
It is indeed, but you wouldn't believe, don't mind is there, because recently written article, a lot of Western people will not like it, but sir, probably you will love an Indian. Don't believe that the whole offloading system, right from 1928 to 2023, it's Indians who have given the highest number of offloading. You can read one of the articles which we have given, that actually we have given one of the highest innovations in offloading. And latestly we have written and we have requested all the Indian authors also to re-look into it. We have sent to a lot of professors that the TCC which came from the origin where you have studied and come out should be recalled as Indian TCC because it was first designed and done in India and various modifications have taken place in that.
But if you have an ulcer, I mean, you can't offload with a TCC. How will you change the dressing every day?
What has happened now is these two schools of thought. One was done in St. John's with one of the prosthetics orthotic department that if you have a heel ulcer, various modality, they have gone back creating a window in TCC and giving a baller iron. That is published. And that also was actually started in, again, late 1940s in Tamil Nadu only. And again, the only paper in last 5 years with the randomized study has been that. But in practice, as you said, sir, will the patient accept that or not is the issue you will be facing it.
But TCC is also to be worn for 6 to 8 weeks.
Is also,
but
again, yet
Terra heel is a removable device, and the IWGDF does not permit removable offloading devices. Non-removable like TCC is more recommended. Dr. Patni, about food, waiting to hear you. About food, intermittent fasting. You won't lose weight. No food, huh? But you allow food twice a day, no?
In that case, thank you, sir. We'll be closing this session, and thank you for a wonderful presentation. We'll come to have one snap here, sir. Thank you, ladies and gentlemen.
Thank you so much, sir. Apart from being a pioneer in diabetic food, it was wonderful to have you have so much of discussion with the audience. I request the chairperson and the speaker to collect their memento from the faculty lounge. Thank you so much, sir. Moving on to the next session, it is intermittent fasting in diabetes, the evidence. And to have the talk, we have with us Dr. Vijay Patni. And to chair the session, we would request Mrs. Mala Gurappa and Dr. Praveen Gangadhar on the dais, please.
morning, everyone. After an interesting talk on the food, we have the food as told by Vijay sir. Very interesting topic, at least in Bangalore. I mean across, but more so in Bangalore, with intermittent fasting and diabetes, 2 meal, 3 meal, 4 meal, whichever, you have all sort of patterns available and fat food. So to throw some light on this, we have Dr. Bijay Patani, consultant physician and diabetologist from Kolkata. Sir would be focusing on this, and I hope at the end of the session, we would be all enlightened on this very interesting topic. Thank you.
Good morning, and thank you, chairpersons. So at the outset, I would like to thank the team Krssdi for inviting me, and Dr. Manohar in particular. So the talk obviously is intermittent fasting and diabetes, and we all are aware of the fact that it actually evokes lots of response as well as the interest, but still remains controversial. So actually, what is intermittent fasting? We do try to put it into the fad diets, but actually it's not a diet pattern. It's more an eating pattern. So it's an interventional strategy where individuals are subject to varying periods of fasting. So it doesn't specify what you need to eat. What it specifies is when to eat. So that is very important. And that is why you need to use your rationale, because when you have a topic like intermittent fasting and diabetes, whether if you eat anything, even though it is time restricted, will it really work in diabetes? That's always a question. But now we do have evidence. Recently, there's a lot of interest in it, so obviously we have certain evidence which I'm going to share with you. So intermittent fasting, as we said, it's an eating pattern that cycles between period of fasting and eating, and it's supposed to be a very, very popular as far among the health and fitness fatigues. So it's not a diet, definitely, and it's an eating pattern. And the commonest which we have seen is the 16-hour fast, or sometimes the fasting for 24 hours or twice a week. So fasting has always been there since evolution, basically. We all are aware of the fact that the cave age, probably soon after sunset, there was a fasting period till the next sunrise. So the fasting was always there, and humans have evolved to be able to function without food. Now, that is what intermittent fasting is. So it's more natural that you fast rather than eating the whole day. But the scenario has changed. We probably are eating at most of the times and fasting a little less. But fasting is almost an integral part of almost all the religious entities which we have in India, be it is in Islam or Christianity, Jainism, Buddhism, wherever you have some kind of fasting periods. So all this can be classified as intermittent fasting. So not from the point of view of that they need a weight loss, or it was more a religious belief which has been practiced. So that is what we say, it's more natural than eating the whole day. Now, there are various varieties of intermittent fasting, and these are the various, the mechanism which one can undertake intermittent fasting. It could be alternate day fasting, where 75% restriction on day 1 and 25% surplus on day 2. Every other day fasting, when eat only every day, every other day, 36 hours fast from dinner on day 1 until breakfast on day 3. Then you have fasting on 2 non-consecutive days per week. Then you have the modified fasting regimens. Then the warrior diet. This is another one, very interesting one, where probably you have 1 large meal per day and you skip both the breakfast and the lunch. And this could again be a controversy, because we always recommend a small diet as far as in patients with metabolic syndrome and diabetes is concerned. And then you can have variation of all the different varieties. The most important fact which we need to underline is that almost 36 to 48 hours before you see any significant amount of protein which starts getting breakdown. So at least for 2 days, a fasting is not going to create lots and lots of problem as far as your metabolism is concerned. and as far as the protein breakdown is concerned, which can be evaluated in this particular slide. Now you can see the different phases of fasting, and then when actually the switch takes place from carbohydrate energy to the fat energy. Now let's look into the most popular method. As I suggested initially, that 16/8 method probably is the most acceptable method as far as intermittent fasting is concerned. But what we actually see when we do fasting, probably we try to compensate by overeating the next few days. And that's not going to work if you really want to address two major issues, whether it's weight loss or to address the metabolic conditions or metabolic syndromes. But this 16/8 method, which is known as the lean gains protocol, where you skip the breakfast and then you have an 8-hour period of eating. That's from 1 to 9 p.m. and then you fast for 16 hours. And this is the most acceptable one. Probably people do practice this. And the other mechanism, eat, stop, eat, that involves fasting for 24 hours once or twice a week. And then 5:2 diet. With this method, you consume only 500 to 600 calories on 2 non-consecutive days of the week, but eat normally the other 5 days. So most of them do go for the simplest measure, that 16/8 method. Now, this is where obviously intermittent fasting works. Basically, when you eat, there is increased insulin secretion, and that means you are in a state of hyperinsulinemia, and where you store the sugars in the liver and produce fat in the liver. That reverses when you fast. And insulin definitely stimulates the fat formation. So whenever you're eating, you're having hyperinsulinemia or increased insulin secretion, that will stimulate the fat formulation, which is very well depicted here. But whenever you have a restricted diet, whenever you're fasting, probably that will lead to fat loss because of decreased insulin secretion. Now, how do they really work? Because as I suggested, it's a switch from what you have, the carbohydrate fuel, to the ketone fuel. And that, along with that, if you have a reasonable fasting, rather than overcompensation with the time of eating, then you will have little bit of calorie restriction as well. That actually increases your antioxidants, as well as lessens the reactive oxygen species. So that's what is recommended. Do avoid eating several hours before you're going to the sleep. Now, why do we recommend that? That's extremely important. We are all aware about the circadian rhythm of our body, and what does it really specify? That which are the periods when most of the hormones interchange or have their role maximally. And secondly, as per the evolution, what we have realized that we need to cut down on our eating post-sunset, right? So if you really want to have a best of the outcomes as far as metabolism is concerned, then obviously it has to be early supper, which should be taken into consideration when we are trying to plan out an intermittent fasting. Along with that, you have autophagy, where you can remove the damaged cells and mitochondria, and that is how it works. Probably intermittent fasting has been recommended also in cancer patients, because they have an impact on the immune system and also reduce the cancer recurrence and mortality rates. So most important is that it does affect the cells and the hormones, particularly if you look at the growth hormones. The level of the growth hormones skyrocket, increases as much as 5-fold, and this can be a benefit for fat loss and muscle gain. Insulin sensitivity increase, that's why the requirement of insulin drops, and cellular repairs happens, as we said, autophagy is involved, and then a change in the gene expression, as well as a change in the gut microbiota. So that which is a very influential kind of pathogenesis in most of the metabolic syndrome. So these changes in the hormone levels cell functions and the gene expressions, they are responsible whatever we see as far as health benefits in intermittent fasting is concerned. Now, obviously, what we know is the disbalance between leptin and ghrelin. So whenever you have increased ghrelin, you're going to have more of hunger, more of eating, and more of obesity. So this imbalance is created by the way we eat or the timing when we eat. So if you are fasting, probably you are able to address the leptin resistance as well as the insulin resistance, and thereby actually can tackle this particular disbalance between the leptin and ghrelin. So intermittent fasting definitely eliminates the hunger and cravings, and they also reduces or normalizes ghrelin, so obviously you will have less of appetite, and that can work in the favor of decreased eating and obviously weight loss. So again, extremely important is what is recommended is whenever we ask someone to practice a dietary, proper dietary pattern, then we always advise them to take a lot of salads before actually going to the main course, or you should take protein consumption before carbs. Now, as far as intermittent fasting and diabetes is concerned, if you are all aware of the fact that prior to 2015, what we have are little rodent studies, which did tell us that yes, intermittent fasting can have some beneficial effect as far as the glycemic control or metabolic control is concerned. But a lot of interest has been generated in recent past, and from 2020 onwards, you'll see few, though small, there are a lot of evidences which supports intermittent fasting as far as diabetes management is concerned. Now just look at this a particular paper which was in nutrition, obesity and exercise. This was JAMA Open Network paper, and here they tried to look into the effect of time-restricted eating on weight loss in adults with type 2 diabetes, and it was an RCT. Now, they wanted to look whether it had an effect on weight reduction as well as the control of HbA1c. And what they concluded was that even though there has a reasonable kind of impact on the weight loss, but there was still a controversy as far as the HbA1c reduction was concerned. So still a controversy remained whether a glycemic control can be achieved with the time-restricted eating. And though it was always a small kind of a study involving only 75 adults, but it did give a conclusive proof that it can be, that this particular intermittent fasting can be utilized for in diabetic population to get a better outcome. Now, if you look at this review article, particularly where they probably searched PubMed, then they'll search the Medline and the Google Scholar, and thereafter they were reviewed, and they wanted to look whether there is a role in the treatment of diabetes. And they wanted to give a guide for the primary care physicians. But yes, it really suggested certain guidelines for the physicians that intermittent fasting is an effective, non-medicinal treatment options for type 2 diabetes. But let me tell you that this was a very small study, and more research is needed in order to come to some kind of conclusion and to give proper guidance to every physician. So physicians should consider educating themselves regarding the benefits of intermittent fasting before propagating this message to their patients. But definitely, along with the mechanism or the way of going for intermittent fasting, what will be more important is to incorporate calorie restriction as well. So if you have intermittent fasting, that is time-restricted pattern, along with some kind of calorie restriction, it might work in diabetics. Again, this is a third paper which was in Nature, where they try to look into the patients who are at risk of type 2 diabetes. So this was a restricted eating versus calorie restriction and standard care in adults at risk of type 2 diabetes. There was 3 arms in that. It was again a randomized controlled trial, and they try to look at whether it can basically help patients who are at risk of type 2 diabetes. So they concluded that if you incorporate advice for time restricted meal or meal timing with prolonged fasting, that definitely lead to greater improvement in the postprandial glucose metabolism in adults at increased risk of developing type 2 diabetes. So this was one paper which at least gave some kind of semblance to the fact that if you advocate that in patients who are either pre-diabetic or are at risk, probably we can actually help them to avoid progression to type 2 diabetes. Now this was another paper, RCT, the InterFast study, where they tried to look into the people with insulin-treated type 2 diabetes. Now, they wanted to look whether this intermittent fasting is efficacious and safe as well. So what they concluded, that definitely intermittent fasting is safe and feasible dietary options to ameliorate the glycemic control while reducing the total daily insulin dosage. So this is what they could actually conclude, that you can reduce the daily insulin dose as well. There was a substantial weight reduction in this group of population as well. So these are few kind of, there are a whole lot of evidences now basically, but they are very small kind of population which have been taken into consideration. Some of the papers have come with only 3 such patients where they try to incorporate this intermittent fasting. So in order to have actual guidance regarding intermittent fasting in diabetic population, which ADA has not even interfered in, you have to have a long and a big study as well. So whatever we might say, what we can say reasonably and rationally, that if you have a fasting along with calorie restriction, that will have definitely a positive impact in diabetic populations. Along with that, there are a lot of physical benefits of fasting. You have an improved mental clarity and concentration. You have definitely a weight and body fat loss. There is a reduction in inflammation. There are papers on that as well, where you have reduced inflammatory markers, and you have lowered blood insulin and sugar levels. And at times, I think the one paper was there recently by Dr. Mohan, where he tried to look into this, and he did come with the concept of reversal of type 2 diabetes or remission of type 2 diabetes with the intermittent fasting. There is increased energy, increased fat burning, and so activation of the cellular cleaning, which is the what I would say the baseline. If you have such a potential benefits of intermittent fasting, that will definitely go a long way in probably addressing the majority of the issues which are dealt with metabolic syndrome. Now, as I suggested that there are a whole lot of mechanism, and the best way obviously is what we suggested, there are 16 to 8 methods which can work well in most of the cases, and this is what has been practiced and has been very well accepted. But what is more important is, whenever you advise any kind of fasting to any individual with type 2 diabetes, one thing you should be aware of, how to really modify the medication medication which are given to the patient. This is extremely important, and I'm not going to details of each and every medicine, but what is extremely important, one need to educate the patient whenever they're trying to fast, whether it is religious fast or you are trying it as a modality or the management tool for in diabetic population. You should be aware that all the medicine which have been is there in the management tool of that individual need to be modified. So to conclude, I would say eating healthy is simple, but is incredibly hard to maintain. One of the main obstacles is all the work required to plan for and cook healthy meals. But intermittent fasting can make things easier, as you know, don't need to plan, cook, or clean up after many meals as before. It improves your health while simplifying your life at the same time. And one of the major benefits of intermittent fasting is to make the healthy eating simpler. So fasting definitely offers lots and lots of important, unique advantages. Fasting, where diet complicates life, fasting simplifies. Where diets are expensive, fasting is free. When diet can take time, fasting saves time. Where diets are limited, fasting is available anywhere. And where diet has a variable efficacy, fasting has unquestioned efficacy. This is no more powerful method for lowering insulin as well as decreasing body weight. Thank you.
Thank you, sir. Thank you for such a lucid presentation and shedding the light there. I think you quoted a paper on the Mohan sir regarding the remission part. I think what they looked at was in the INDIAB group, they looked at slight reduction in the carbohydrate and replacing with protein and slight with the healthy fat. At least the onset and the conversion of pre to post was much lesser. In an Indian scenario, the challenge is the main challenge we see with intermittent fasting is at the end of the day, it's the amount of carbohydrate restriction and the calorie restriction what matters more than the time restricted pattern. Whether somebody is comfortable with a 2 meal or a 3 meal depends on their comfort zone. They try to eat 2 meals but 4 snacks. So these are the...
That is what I can tell you about one particular religious belief, that is what we do in Ramzan. So if you see, most of our diabetic population don't do very well in Ramzan time. You know, you are aware of the fact, though they are actually going for intermittent fasting for almost 16 hours. Because once you are post-fast, probably the amount of calorie which they consume is quite high. So it never really works in those cases. All we do is modifying the management, the medical management. But end of the day, whether it's going to have a substantial benefit as far as the diabetes is concerned or the glycemic control, it really doesn't work. But if you have intermittent fasting along with calorie restriction, that should theoretically work in diabetic population.
I would just like to add on, sir. So I have 2 points to say. One is that we can categorize diet into 3 categories. Like one is therapeutic, one is maintenance, and the other one is experimental diet. So we can easily accept this as an experimental diet, but not therapeutic diet. And again, intermittent fasting has a lot of limitations. I cannot give it for a patient who has a BMI less than 18%. So obviously, lean diabetic has to be taken care when he's on intermittent fasting. And again, coming to the evidence-based studies, there are 2 studies which are controversial. One says like, yes, intermittent fasting increases the level of testosterone. And again, the study done during Ramadan said that the inference was the testosterone level decreased. So it's still in experimental phase, and we need a lot of meta-analysis to say whether it is really therapeutic diet or not.
Yeah, absolutely. It's not a diet pattern, actually. It's an eating pattern. And if you add this eating pattern to the dietary pattern, then only probably it's going to work. Otherwise, presently the studies are scarce. Not big trials are there. We need to have bigger trials with particularly intermittent fasting, that is time-restricted eating pattern, and then we can really come to some kind of conclusion, or we can actually have some guidance. Thank you.
The concept of breakfast is recent. It was introduced by the British about 200 years ago. Otherwise, people had only 2 diets, once in the morning and once in the evening. The Britishers, they had huge cereal factories, and they wanted to market their cereal all over the world. So they took the help of the medical scientists and doctors, and not only they convinced the world to have 1 meal in the morning, they made that meal into the most important meal of the day. Otherwise, it was 2 meals per day, and these 2 meals, it corresponds to the circadian rhythm.
Absolutely.
And in the fasting of Muslims, it doesn't conform to the circadian rhythm. Probably that is one reason why it doesn't help much there. And like what you said, in intermittent fasting, when the fasting period is long, there is a metabolic switch from carbohydrate metabolism to fat metabolism, and there is a role of glucagon which starts acting in a fasting state and encourages ketosis, and there is a breakdown of the fat which helps in significant weight loss.
Right. Points well taken.
Thank you, sir. Thank you. Thank you.
Just one question. Nice talk. The problem is Indians and most of us probably eat around 9:30, 10 at night, and thereafter we go to bed around 11 o'clock, say. So is it practical for us to eat at 6 o'clock?
It's very much practical. I do practice as well most of the times.
No, I'm talking about the whole of the
But the thing is, as we
country.
blame the British for the breakfast, I think we can credit them for the early supper as well, right? The Caucasian population, most of them do go for early supper. They don't take dinner as such. So that's one thing which we can always change. We always used to do that, but now we have shifted gears. So I agree with you, most of us, we do not practice, and we have seen this in conferences as well. So we do consume until till the last meal probably finishes. So that's a fact. But I think, as far as Sir said, we need to think about our biological clock as well. See, the circadian clock which we have, whether it's a central clock or the peripheral clock, they do work in a very specific way. Now, we are going for a dysynchrony of that clock. So whenever you have a circadian dysynchrony, then you will end up with the metabolic disorder which we all are aware of. Everything knowing, even we are not practicing. So preaching and practicing, there is a hell of a difference. So I will not probably comment on that at present. Thank you.
Thank you.
So the other thing is the validity of the diet, sir. How long can we practice intermittent fasting? That is the main question, and convincing patients really to switch over from normal, regular eating to intermittent fasting is a challenge.
Thank you so much, sir, for highlighting the need to adapt. I now request the chairpersons and the speaker to join for a photograph, please. And I also request the chairperson and speaker to collect their memento from the faculty lounge. Thank you once again. Moving on to the next session, we have this talk on future therapy in diabetes, twin cretins. And the speaker is Dr. Ajay Tiwari. To share the session, I would request Dr. Ravi Kirti sir and Dr. Ravish on the stage, please.
Good morning, everyone. Twin cretins is a very important topic where twin cretins have a role in cardiometabolic benefits, and they have a role in decreasing weight also. So they have a role in weight reduction also. So here we have Ajay Tiwari, who's Director, Jai Clinic and Diabetic Center, founder and patron, HDA Foundation, National Executive Member of Indian Podiatric Association, to talk about twin cretins. Over to Dr. Ajay Tiwari.
Thank you, Chairpersons. And at the onset, I'd like to thank the Karnataka RSSDI for giving me this opportunity to talk on a very interesting topic, that is the twin cretins, and they are the future of diabetes, and they are the blockbuster molecules in United States of America. So we have a lot of unmet needs in the glycemic therapy in diabetes. So in clinical trials, more than 30% of the patients fail to reach glycemic targets. And in trials of intensive weight loss, long-term weight loss is generally less than 5%. And anti-hyperglycemic agents have variable effects on weight, but even the weight-favorable agents rarely achieve less than 5% weight loss. So we have got twin problems, the problem of obesity and diabetes, that we call as diabetes. And most of the agents, when we are using them, they are not able to achieve the euglycemic status, that is the A1C of less than 5.7%, without going for hypoglycemias. So I'll be discussing this topic, and I will be sharing with you some very interesting new trials where they have tried to reach to A1C's levels below 5.7 with these two incretins also. So these molecules are not yet available in India, but they are likely to come. They are very costly, but they are the blockbuster molecules. And we must understand them because they very soon we'll be getting these molecules in our country also. So a bit about what is this GLP-GIP partnership in metabolism. So the GIP, it has got it increases the lipoprotein lipase activity, increases adipose tissue accretion, and it decreases bone reabsorption. The GLP-1, we are much more familiar. It has got an increased enzyme secretion. It increases the insulin levels, increases natriuresis, diuresis, decreases gastric emptying, and increases cardiac protection. So now coming to what are the contributions of the various gut-derived factors in the postprandial insulin secretion. Then you will understand why this chemistry or the meeting of the grounds of these two molecules is important. So if you see glucose, it contributes around 26% to the postprandial insulin secretion. The GIP, which has been included in this particular molecule, it contributes around 45%, and the GLP around 29%. So this combination of these two, GLP and GIP, that's why they are a potent molecule as regards to the insulin secretion in the postprandial state, as well as for the weight molecule. So now I will be listing a few of the molecules which are the co-agonists which are in the pipeline. So some of them were started, some of them are already in the market. The most important is the tirzepatide. It's already in the market. So some of them have already been discontinued. And some of them like RG7597, CPD86, TAG094, and ZP198, they are in the process of preclinical evaluation. So we have the tirzepatide in the molecule. And now we have got triple co-agonist also. So they have started including the glucagon also. Glucagon receptor agonist plus GLP and GIP. So that retatrutide is also in the phase 2 trials now. And we have got very encouraging results with that molecule also. So basically, in the first part, I'll be telling you some basics about this molecule, what are the doses, what are the side effects, and what are the potential benefits of this. And then I'll be taking you through some of the interesting studies as regards to the HbA1c control as well as the weight control with these molecules. Why they are blockbuster molecules and flying off from the shelves in the US market. So what is the concept of dual agonist? So if we only have one drug, that is the GIP receptor, we have improved insulin secretion and increased adiposity. And when we are combining these two, we have enhanced hormone activity, increased beta cell mass, improved insulin secretion, improved glucose homeostasis, and the GLP-1 modulation may suppress glucagon secretion and reduce body weight. So this is the concept. Then when we are combining these two, we are getting 4 times the benefits as regards to this. So the tirzepatide is the molecule which is now available, and it is a multifunctional peptide based on the native GIP peptide sequence modified to bind to GIP or GLP receptors both. Tirzepatide is a 39 amino acid linear peptide, includes C20 fatty diacid moiety. Tirzepatide has a mean half-life of 5 days, enabling once weekly dosing, and it is already the trials have come, the surprise trial at the Surmount group of trials. So this is how it acts. It acts at both the GLP-1 receptor and GIP receptor, and by the activation of PKA and influx of calcium, it releases the insulin from the vesicles. So how it is given? It is given by a subcutaneous injection. The starting dose is 2.5 milligram once weekly, and it has to be built over every 4 weeks, and the maximum dose is 15 milligram once weekly. So the common side effects are dyspepsia, abdominal pain, loss of appetite, nausea, constipation, and rashes. Then hypersensitivity reactions, urticaria, eczema, and angioedema. Then there is a potential, because we have GLP-1 analogs, so there is a potential for thyroid cell carcinoma, and is to be avoided in those cases, gastroparesis, cholelithiasis, and diabetic retinopathy, and hypoglycemia when combined with other agents. So now coming to the trial part. So the first group of trials were the SURPASS trials. So these were in this they recruited patients with type 2 diabetes, A1C of more than 7% to 9.5%. the BMI of more than 23 kilogram per meter square, stable background on medications, and EGFR of more than 30, no type 1 diabetes, no history of pancreatitis. So the dictum was like this: tirzepatide 5 milligram once weekly, and gradually every 4 weeks they build the dose and they have comparisons. And the primary endpoint was superiority, placebo-controlled studies, or non-inferiority for active comparator trials of tirzepatide for mean change of A1C at week 40. So these were the trials, and these were the background. So basically, in the SURPASS 1, they had a comparison with the placebo. For SURPASS 2, they had a comparison with the semaglutide in the background of metformin therapy. In SURPASS 3, the comparison was with the degludec, and the background therapy was metformin and SGLT2 inhibitors. For SURPASS 4, that was with glargine, and for SURPASS 5, with the placebo and the background of glargine and metformin, and the SURPASS CVOT trial, which is planned, they have a comparison with the dulaglutide. So these were the results. So if you see in the SURPASS 1, where we had a comparison with the placebo, so we have a A1C reduction with a 15 milligram. The dark blue is for 15 milligram dose of tirzepatide. It was a 2.07 HbA1c reduction, and the baseline A1C was 7.9. For SURPASS 2, it was 2.46 when there was a background of metformin. With SURPASS 3, with the background of metformin or metformin with SGLT2 inhibitors, the A1C reduction was to the tune of around 2.37. 4, it was 2.58 with the maximum dose of 15 milligram. And for 5, it was SURPASS 5 with insulin, glargine, with or without metformin, it was 2.59. So we have a substantial more than 2% A1C reduction in these set of patients. And the A1C, the baseline A1C ranged from, was somewhere around 8 to 8.5 in these trials. Then coming to the weight reduction, which is the most important thing and why this is such a potent molecule. So in SURPASS 1, when it was compared with the placebo, the weight reduction was 9.5 kg, and the baseline weight was 85.9 kg. So that was a very substantial weight reduction. And in SURPASS 2, it was around 12.4 kg. In SURPASS 3, 12.9, and in SURPASS 4, it was around 11.7 with the maximum dose of 15 milligram, and in SURPASS 5, it was 10.9. So around plus 10 kg weight reduction with this particular molecule in these SURPASS group of trials. So none of the molecules, I will be giving you a comparative analysis of the other molecules that are being used for anti-obesity medications. So you will see what is the reason for this, and this is the safety profile of these molecules, more or less safe except for the gastrointestinal side effects. Then CVOT trial, SURPASS CVOT trial is already planned, and it is a comparison with the dulaglutide, and the results will be coming in the late 2023. So in all these trials, what we have seen that we have around plus 2% A1C reduction and more than 10 kg weight reduction with this particular molecule. And then now coming to a very interesting aspect, and this was presented in just 2023 only in Diabetes Care. So they said that in these SURPASS group of trials, they tried to analyze the SURPASS 1 to 4 trials, and they wanted to see that how many number of patients were able to achieve an A1C reduction of more than 5.7%, were able to go below 5.7%. So in these trials, around 44% of the patients were able to achieve an A1C reduction of 5.7%. So that was normal glycemia. So usually we are always afraid of using an agent to that levels, and all the guidelines say 6.5 or 7%. So here it was possible to have an A1C reduction of less than 5.7% without lot of hypoglycemia. So you see 98.5% of patients did so without level 2 or 3 hypoglycemia, 91% did so without level 1 hypoglycemia. So that is the beauty of this molecule, that you are going to achieve an A1C reduction of less than 5.7% in 44% of the patients without overt hypoglycemia. And if you are going to an A1C reduction of less than 5.7%, or they have shown cardiometabolic benefits, they are very obvious that there will be a reduction in systolic blood pressure, it will be in the weight, in the fasting blood glucose, and the triglyceride levels. So now coming to the second group of trials. And these trials were meant for the weight reduction part of the tirzepatide. So we have SURMOUNT 1 to SURMOUNT 4, and here we have people with obesity or BMI, without diabetes, 2 with diabetes, 3 with, I'll be giving you that after the lifestyle modifications, when this particular molecule was out, could we get better benefits with that? And in SURMOUNT 4, we have a trial to show when this molecule is withdrawn after giving 36 weeks, what do the benefits stay or the weight reverts back? So that was the question, because every time this question is asked when the molecule is withdrawn, do we get those benefits are sustained or they revert back? So phase 3 SURMOUNT trials, tirzepatide for weight loss, SURMOUNT. So this is 1 and 2, people with type 2 diabetes with obesity or BMI more than 27. And 3 and 4 are only for obesity. So this is the original paper from the NEMJ. And in the SURMOUNT 1 trial, they found that with 15 milligram of tirzepatide, the weight reduction was to the tune of 20.9%. As compared to the placebo, it was 3.1%. So this is something very important, and this is the reason why FDA has approved this molecule for weight loss late in November this year. Then SURMOUNT 2 trial, a multicentric randomized trial, double-blind parallel placebo-controlled trial comparing the efficacy and safety of tirzepatide 10 milligram and 15 milligram to placebo as an adjunct to reduced caloric diet and increased physical activity. So this was a multinational trial, and as regards to the results of this, so the results were 41.4 10 milligram and 51.8 15 milligram people taking tirzepatide achieved at least 15% body weight reduction compared to 2.6 for those taking placebo. And the reduction in A1C compared to placebo was similar to the SURPASS trials in adults with type 2 diabetes mellitus. So we are getting a 10 plus kg weight reduction in all these particular molecules, around 20% reduction. So that is not heard of any molecule that we know till date as regards to this. So this is the efficacy estimate. So the average weight reduction was 13.4 with tirzepatide 10 milligram, and with 15 milligram it was 15.7, and placebo it was 3.3. And the percent of the patients who achieved more than 5%, that is a category for accepting any medication as an anti-obesity medication, it was 81.6 with 10 milligram, 86.4 with 15 milligram, and with placebo it was just 30%. So adverse events, we all know about that. SURMOUNT 3, that is also very interesting trial. They said that we will continue with 12-week intensive lifestyle intensification, and then we will use tirzepatide or placebo once weekly for 72 weeks. So on the background of a lifestyle management, do we get further reduction in weight after this lifestyle management? So this was the particular thing. So they started with a low-calorie diet of 1,200 kilocalories for women and 1,500 kilocalories for men. And thereafter, they had two groups, one with tirzepatide, 10 or 15 milligram, or injectable placebo. And they said, and what they found that even after these interventions, when we introduce tirzepatide, we have further reduction in the weight in the tirzepatide group. So that is the SURMOUNT 3 trial. So they commented that around 18.4% with tirzepatide and 2.5% with the placebo. So further on, if we add this to lifestyle modifications, we are going to have further benefits as regards to this molecule. Then this is the most recent, and it is recently published in JAMA. So this was, because this question will obviously come, if we, will the weight come back or not? So does once weekly subcutaneous tirzepatide with diet and physical activity affect maintenance of body weight reduction versus placebo in individuals with obesity or overweight? So they continued for 36 weeks with tirzepatide, and then they stopped tirzepatide in one group, and for the other they continued tirzepatide. So in the findings were that in tirzepatide group they had a 5.5% reduction, and the placebo group it started rising and went to 14%. So it was something like this, that the initial weight at the start at 36 weeks was around 105 kg. So they, with this tirzepatide, it came down to around 90 to 87. And further, after this particular, when this continued with tirzepatide, it came down to 79. But in the group which was where the tirzepatide was stopped, it went to 97. So it started going up, but gradually. So now coming, because we are talking about anti-obesity medications, the other important thing is semaglutide, that is given by the name of Wegovy. So how do we compare between these two? The actual weight loss was 17.8% with tirzepatide, and with Wegovy it was 12.5%. And then this is the comparison of the various anti-obesity medications that we have, and where do we have tirzepatide. So it is around 20.9% with tirzepatide, and now we are inching towards the benefits that we can get with bariatric surgery. We are getting potent medications that could replicate the effects that we get with the bariatric surgery. So these findings have forced the ADA Standards of Care 2024 to incorporate these points into their directions, and this has already come in the most recent 2024 Standards of Care, that in people with diabetes and overweight or obesity, the preferred pharmacotherapy should be a glucagon-like peptide 1 receptor agonist, or dual glucose-dependent insulinotropic polypeptide and glucagon-like peptide 1 receptor agonist. So this is already the part of the most recent ADA 2024 Standards of Care. And then this was preceded in the ACE guidelines, and in the category, this was the morbidity-based guideline of the ACE guidelines, and there they said that in patients with overweight or obesity, you should prefer GLP-1 analogs or a combination of GIP or GLP-1 analogs or SGLT2 inhibitors. And in patients with severe hyperglycemia, again, this category of GLP and GIP-1 analogs has been incorporated. So finishing my talk, so all of us must be thinking why this, the technical name for this or the trade name for this molecule is Mounjaro. So I had been thinking why this word Mounjaro has come from. So climbing Mount Kilimanjaro is sometimes used as a metaphor for doing something very difficult. For many people, finally getting their weight under control can seem like climbing Mount Kilimanjaro, achieving a difficult goal. So Mounjaro is short for Mount Kilimanjaro, which is a metaphor for success. So thank you for patient hearing, and I'm open to questions.
Thank you, Dr. Ajay, for an excellent lecture. I think, molecule looks very promising, but as you said in the beginning, the cost is going to be a major factor in Indian scenario. Hall is open for discussions. Any questions?
Side effects seem to be a bit more problematic when compared to the benefits. What is the comment?
Sir, we already have I have shared the slide as regards to the side effect profile. So the side effect profile is almost equivalent to what we have with GLP-1 analogs. So if we go slow and gradually build the dose over a 4 weeks period, so the acceptance is good, but that's very true that what you have said, that GI disturbances will definitely there when we are having a GLP-1 analog, GIP co-analog.
Thank you.
The semaglutide itself has some amount of a hypotensive effect, actually. I think many of the people have experienced hypotension, especially when it is used in non-diabetic patients. Does this molecule too has got any effect on the hypertension?
Actually, if you see what I was sharing with you, the 2023 diabetes care paper, so there the A1, the systolic reduction, BP reduction was to the tune of 6 millimeter of mercury. Yeah. So that is always will be there, because if you are reducing the weight, obviously you will be getting pluripotent benefits. You should be careful in those set of patients.
If there are no questions, we'll close the session.
Thank you so much, sir. I now request the chairpersons and the speakers to join for a photo. And I also request the chairpersons and speakers to collect their memento from the faculty lounge. Thank you once again, sir. The next talk is the combination therapy of T4 and T3 in the management of hypothyroidism. The speaker is Dr. Mahesh DM, and to chair the session we have with us Dr. Chandrasekhar N and Dr. Leela Mohan PVR.
Yeah, good morning. So after the diabetes session, I think we moved to the thyroid session. I think this is one of the common problem encountered in diabetes patient. So in spite of adequate therapy, some people still complain with persistent symptoms. So combination of T3, T4 has been one of the way of managing these patients. And here we have Dr. Mahesh DM, consultant endocrinologist, Aster CMI Hospital, Bangalore, to enlighten about this topic. Sir, session is yours.
I thank the organizers for this opportunity. I thank you, chairpersons, for the kind introduction. So today we'll be talking about the combination of T4 and T3. I will start with, this is the agenda: cases, historical context, physiology, the unmet need that was there, T3 evidence in clinical practice, what are the current guidelines, future perspective, and take-home message. So this is a case of a 42-year-old female who came with history of hypothyroidism, taking treatment regularly for 2 years, and she was taking 100 microgram, increased to 150, compliant, taking it regularly. Always the question we always ask is, are you taking correctly? Did you miss the dose? And when you see the biochemical parameters, all are normal. And in fact, the only problem was that the patient's symptoms were still persisting. She was complaining of fatigue, forgetfulness, inability to concentrate, and feeling low, disinterested in everything. So the common thing is to do vitamin levels, and you can see vitamin D and vitamin B12 is also normal. And then most of the time what happens is that we are stuck and telling the patient that, see, you continue the treatment, I'm sure you will feel better, because sometimes it takes time for the biochemistry to become normal before the symptoms. But the patient will say, ಏನಪ್ಪ ಡಾಕ್ಟರ್ ಯಾವಾಗಲೂ ಮಾತ್ರೆ ಕರೆಕ್ಟಾಗಿ ತೊಗೊಳ್ತಾ ಇದೆ ಅಂತಲೇ ಕೇಳ್ತಾರೆ. Useless doctor, I did all the tests. He kept asking me about my complaints and spacing 1 hour gap ಕೊಡ್ತಾ ಇದ್ದೀರಾ ಇಲ್ವಾ. Every time he used to ask, ಸುಮ್ಮನೆ ಇವ್ರ ಹತ್ರ ಬಂದು ವೇಸ್ಟ್ ಆಯ್ತು ನನ್ನ ಟೈಮು ಅಂತ patient will feel and go away. Next is one more patient who has complaints of lethargy, morning stiffness, aches and pains. And you see the patient started on 75 microgram and gradually increased to 212 microgram daily. Blood pressure is normal, BMI is 29. Again, all the lab parameters are normal, but the patient was again complaining that my symptoms are not improving despite increasing the dose, and I am taking this medicine for 3 years. So whatever you told me that it will improve, I have been coming to you, you are only increasing the dose. This doctor doesn't know much except to increase the dose. So I used to always fear whenever I see a normal report, that is the most dangerous patient, whether it is diabetes or something, because the patient's questions are going to be more and our answers will be less, and we will be feeling that what do I have with me in my brain. So for this, I went back to the physiology, went to my favorite book and looked at everything, and then I thought that somewhere T3 should be there. Everybody used to talk about T3 for the last 10-20 years, but I thought that T3, if it is not there, the patient symptoms will not improve, because you look at the specific conversion of T4 to T3 in the liver, brain, muscle, kidney, all the places the deiodinase enzyme is very important, and therefore unless we have the T3 also getting converted and actively forming, we will not be able to see clinical improvement in the patient. But actually we did not have T3 available easily in our clinical practice. So you can see here the biologically active T3 hormone binds to the intracellular thyroid hormone receptor, and thyroid signaling pathway is activated, and this leads to modulation of the target genes and other metabolic pathways. So T3 conversion is very important. Not just the conversion is important, the rate of conversion is also important, and the concentration of T3 is also important. What happens usually is that we are looking at the blood levels. The blood levels are normal, doesn't mean that the intracellular levels are also normal. And further, the secretion ratio of T4 to T3 is 15:1. So in a patient who is normally secreting in the thyroid gland, this concentration is always there, the ratio. But we never look at the ratio when we check the patient, because it's not possible to do any ratio test. Further, the FT3 that is there is also converted to reverse T3. Reverse T3 is a non-active metabolite. So we have a problem of reverse T3, and we don't know what is the exact ratio of T4 to T3 that is actually happening when we give a T4 supplement. So we will have a lot of these symptoms coming to us. Some of the patients will have some symptoms that are improving, some symptoms that are not improving, which means that the conversion to T3 and T4 is variable not just inside the system as a whole, but also varies inside the system from organ to organ. So it may be good in the peripheral organs, but very poor in the liver or very poor in the brain. So you will have symptoms that will vary from patient to patient depending on the conversion of T4 to T3. So if you look at the historical perspective, we had initially the desiccated thyroid tissue extract, then we had standardized amounts of T4 and T3 that were there, then we had synthetic form of levothyroxine and leothyronine. But unfortunately, the problem was that the T4 that was available, the T3 and that was also used, the exact dose that is beneficial for the patient was not very well clear, because it has a very short half-life and it is very active metabolite. So if you give a slightly higher dose, you end up in complications very fast. Unlike T4, if you give a very high dose also, the patient takes time for conversion. So actually, the higher T4 dose is protective for the patient, but a higher T3 dose is harmful for the patient. So as medical personnel, our first rule is that we should not harm the patient. So most of the time it was decided that let us not harm the patient. So let us not do much research on T3 and actually give it to our patients. So today we have availability of T3, and let us see how it is making the difference. So the basis for treatment of hypothyroidism with T4 is that the humans activate T4 to T3. So when TSH is normal, but T3 reservoir may not be adequate. So therefore, we need to look at what is the evidence that T3 will help our patients. I'm sure you have heard that magnesium being normal does not mean that the magnesium is actually normal in the entire system, because it's an intracellular chemical. And when the magnesium is low, it actually takes more time to replace it, because both intra and extracellular magnesium has become low. So most of the time we see 10 to 15% of the patients with hypothyroidism complaining of unresolved symptoms, notwithstanding the TSH level being in the normal range. So what could be one of the reasons, or a few reasons that could be leading to this? One is the peripheral conversion. Second is the actual low levels in peripheral tissues. Second is inadequate therapy leading to normalization of TSH with low T3 levels in all tissues. This usually happens sometimes because when the patient, say for example, patient is taking 50 microgram and complaining of symptoms, you increase it to 75. Patient suddenly tells that after you giving 75, ಕೈ ಕಾಲೆಲ್ಲ ನೋಡ್ಕೋಕ್ಕೆ ಶುರು ಆಯಿತು, ನನಗೆ ಹೊಟ್ಟೆ ತುಂಬ ಹಸಿತಾಯಿತು, ಅರ್ಧ ಗಂಟೆ ತಡ್ಕೊಳ್ಳೋಕ್ಕೆ ಆಗೋದಿಲ್ಲ ನನಗೆ. Or patient will say that, I was not tolerating this at all, I'm having some gastric problem or some other symptom, and patient goes back to 50, and on 50, patient symptoms, these symptoms are not there, but he doesn't feel well. The quality of life is not good, because somewhere the TSH is though in the normal sort of range, it is sort of on the higher side of normal, and slight increase will bring down the TSH. And what we usually do as doctors is either work on the bit pudi, or take T75-50 combination, or take 62.5, or take double dose one day, stop one day, then neither we will remember nor the patient will remember what we told the patient. So most of the time patient will continue to take single dose and think that it is okay. Again, like I told you, the T4-T3 ratio is also altered. There are genetic susceptibility, good data that shows that the polymorphisms of dehydrogenase enzymes are contributing. Then there are chronic medical conditions and autoimmune conditions that contribute to affecting this. And we all know that those who are on steroids, the T4 to T3 conversion is again further hampered in such patients. So this is the genetic polymorphisms in the genes decoding dehydrogenase 1 and 2, which will compromise the conversion of T4 to T3, and therefore you will have symptoms that will develop. So further in future we may have tests to find out whether there are polymorphisms specific to this. So T3 currently is available as Lenormand T3. Half-life is 1 to 2 days. Thyroid hormones do not cross the placenta. The recommended dose is in those patients who have normal TSH, and the ratio should be somewhere in the range of 15:1, that is 13 to 20:1 by weight. And combination of T4 with low T3 once or twice a day is very well tolerated in many of our patients. So ideally we would like to keep this ratio whenever we give the tablet, and at the same time we would like to use it once or twice a day to ensure that it is safe. So data has shown that in this study, 49% of the patients preferred the combination of T4 plus T3, and their scores were much better quality of life as compared to individual therapy, which means that more patients are feeling better when they take combination of T4 and T3. Again, 18 studies have been published in the last 10 years, which have shown that there were no adverse events when it was used once or twice daily, and most patients preferred the combination therapy. Further, when we looked at the combination therapy and the effect on the cognition, again it was seen that the combined therapy clearly improved the cognition, mood, and patients started feeling better as compared to those who were taking only isolated T4. This is again to show that the mood in the T4, T3, if you look at those who were on T3 plus T4, memory was better when they were, in addition of T3 was there. Again, fatigue and energy levels were slightly better when T4, T3 combination. And most people also found out that the weight loss is much clear, that the weight gain that they lose is much more when they were on T3. So today the guidelines talk about using T3, suggests that T3 as an experimental approach and not for routine use in patients receiving T4 and persistently complaining despite normal. TSH ratio should be again 13:1 to 20. Should be ideally given in 2 recommended doses, one during breakfast and the larger dose before sleeping, because the metabolism is the reason. And recommend separate T3 and T4 tablets rather than giving as a single tablet. So regarding T3 should be started with 10 to 20 micrograms, but you can start with 5 because we currently have 5 microgram also available and 20 available with us. So the maximum dose is 60 per day. We should not cross 60 microgram per day. So why is it important and what are the monitoring parameters? Is that monitoring is very challenging. That's why when we give something, if we cannot monitor, then it becomes very difficult for us to actually treat such patients. When we give TSH, when we give T4, we clearly know that TSH is the parameter. So here also TSH is the parameter. The T3 dose should not reduce the TSH to less than normal value. So it should not bring it down to 0.5 or less than that when we start it. So it's always better to start it with the lowest dose, that is 5 microgram, and then increase it to 20 microgram. Though you can, there are certain groups of patients where you can directly start 20 also once a day, and then increase it to maximum twice a day, and rarely twice a day. Rarely it is required twice a day. Most of the time it is required twice, and 3 times is not at all required. So in those patients who need long-term therapy, we are always worried about the cardiac effects because arrhythmias are quite common if the dose is very high. So ECG monitoring is recommended at each office visit along with the 3-year bone densitometry in postmenopausal women to ensure that we are not overdosing the patient. So the only monitoring mainly is to look at the ECG heart rate of the patient and then ensure that the TSH is not increased and it is in the lower half of the reference range rather than the higher half of the reference range. So if you keep 1 to 4 as your goal, it should be somewhere less than 2.5 for most of the patients when you treat them. So hypersensitivity, pregnancy and breastfeeding, patients with angina, cardiovascular diseases or thyrotoxicosis, definitely we will avoid. And a combination therapy is not recommended for anybody with pre-existing cardiac arrhythmias or an history of cardiac arrhythmias. So what is the T3 take-home message or the take T3 home message for us is that T3 is effective in improving the hypothyroid symptoms and quality of life. The combination of T3 is associated with better treatment satisfaction, especially in those with cognitive symptoms and fatigue. Evidence does not show that there is any T3 associated complications, including cardiovascular bone loss, when the dose is 60 or less than that. When the dose is 75 or more, 75 microgram or more, there is enough evidence to show that it will cause harm to the patient. There is an increased risk of cardiac arrhythmias or even osteoporosis. So now coming to practically how can we, you can take a picture of this to calculate what you want to do this is the most important practical slide if you want to calculate how to give the patients and how you should decide. So if you have a patient with monotherapy of T4 and you want to give a 5 microgram dose, then you can give 88 microgram of T4 and 5 microgram of T3 combination. Same thing if the patient is having 125, the dose recommendation is 6.25. Again, you can go back to 5 and give either 100 or give a higher dose here, 112 and give 5. When it is 7.5 or more than that, you can shift over to 10 or you can reduce this dose further. So for example, you can give 75 and 10 for a patient or in the combination of 100 and 20 for patients who require, because we have only 2 strengths. We can give 5 2 tablets, so it is 10, and then we have 20. So if you want to give 10, you can give 5 2 times, And if you want to give 20, you can give directly 1 tablet, or you can give, you have to give 4 tablets. So you can make a rational combination where you can give the practically feasible dose for the patient. Taking in afternoon is going to be very difficult. Most of the patients will forget. So the best time to take it is in the morning after breakfast, and in the evening when they come back, have a snack and take, or even they can take post dinner also. So now coming to the same patient, she was prescribed 100 microgram with 5 microgram of T4, and 4 weeks later the TSH was 2.3. The combination therapy resulted in improvement of the residual neuropsychiatric symptoms. Patient said, "Thanks, doctor, you are indeed a thyroid specialist." So the acknowledgement was received that finally we can call ourselves as specialist. This patient was also a very high dose of 212 microgram. Was started on 175 and 20 microgram of leothyronin. At 6 weeks, patient was asymptomatic, felt better. And patient said, "Thanks, doctor, I was fed up with frequent change in the doses without relief. Now I am much better." So the success of the doctor is always the patient's happiness. And when the patient is happy, you also feel good. So when we have tools that are there with us today which can make a difference, we should try it out. And I think there are goals is not just biochemical euthyroidism, but also clinical euthyroidism in our patients, so that both the doctor and the patient are also happy. This is last slide. So most of the places where this will be more relevant when we practice will be usually the post-thyroidectomy patients where there is no thyroid hormone at all being endogenously produced, especially malignancy. When they receive very high dose iodine ablation, the chances are very high that they will have more residual symptoms. These are futuristic indications. I am not telling they are going to be, it's not a guideline or there is no recommendation, but in future they will be used in waiting period pre-op clearance for surgery, where patients with upper GI malignancy where T4 absorption is an issue, spacing is an issue, they are on continuous feed. You cannot give, sometimes patient is on continuous NG feed or a G feed, gastrojejunostomy feed. Patients who are on immunotherapy not responding to conventional T4 doses, and patients in whom it is very difficult to fix the dose. If you give 50, there is a problem. If you give 75, there is a problem. For them, you can give 50 plus 5 microgram. You can see a huge difference. I tried out in 2 of my friends who were doctors, practicing, and I requested them, if you want, you can try and see. And both of them said that they are very happy with taking a lower dose of T4 and a lower dose of T3 in the morning and evening, and they have seen better. The last indication, there is some controversy here because mixed edema coma, the monograph says that you can use it. Japanese have accepted and they are ready to use it at 60 microgram given by the stomach tube, then 20 microgram every 8 hours in patients with mixed edema coma. But there is enough data to show that more than 500 T4 and T3 more than 75 is associated with increased mortality. So there will be a role where IV thyroxine is not available and you are finding it difficult for the patient to improve from coma. There may be some role in this. So these are the probable indications in which it will come up in the future. For right now, it is only recommended in those with normal TSH and who are not feeling better symptomatically. You can try a lower dose and see how it happens. Main reason is because of the free T3 reverse T3 ratio. That is the most accurate method, and someday we'll get it probably to do in our clinical practice. So what should be done when thyroid function don't make any sense? I used to say you can say thank you and refer, but you can also treat them. Thank you.
Thank you, Dr. Mahesh. It was a great lecture. And then the combination therapy is always, it will be helpful than rather than the single therapy in the patients who are having more fatigue or weight gain, all those things. And what about the main side effects in which we have to look, and what about the cost of the therapy?
So
will it be a burden or like how it is?
So cost of the therapy was high, and now they have actually reduced the rate of the dose. If you look at the symptom profile of the patient and the multivitamin that are available, and most of the patients will be taking some multivitamin or some other drug, actually the cost is not very high. 5 microgram, they will not feel the burden. Once a day is actually not, or the problem cost will come only in those who will need to take more than twice a day, 20 microgram. In them it will become slightly costly, but that will be very, very rare. It will be maybe out of 100 prescriptions that you will give for the combination, maybe 1 or 2 or 3 will require this higher dose, more than 20 microgram twice daily. Most of them will be happy with 5 twice, or maybe 10 and 5, they will be happy with that. So maximum requirement what I have seen the patients is that 25. per day with the combination of thyroxine T4, they will feel very happy. And you will actually see that when the patient feels that the patient will feel that they are feeling better. That is the reason why they will only continue. I have actually started the patient, tell them take for 3 months, you only decide. So till now only one patient said I am happy with T4 only. Rest almost 25 patients are happy with taking it combination. They only decide, sir, I am happy with once daily, I am happy with twice daily. They only decide. I said never take more than 2 times because I don't want side effects. So side effects we have to look at, especially in elderly people, more than 50 years, we need to get an ECG done and just check their pulse whenever you see them. And for postmenopausal women, once BMD will be helpful, and again you can repeat after 1 or 2 years.
Particularly, we have to use this combination therapy in specific populations or something like that?
Most often those who come with residual symptoms are those with long-term autoimmune disease. Like, Hashimoto's thyroiditis is diagnosed at the age of 20, 25, and they are coming to you at 40, 42. They felt better initially, and then now some people have thyroid the thyroid gland actually reduces in size. In autoimmune, we have 2 types. One where the thyroid gland the goiter is there. In other where the actual size of the gland is reduced. What I've noticed is that when they have thyroid shrinkage or the gland size is reducing, after 10 years, they feel that their symptoms are not better. 5 years ago with the same tablet they were doing well, but now they are not doing well. Second group is this post-malignancy where they have been operated. They are given very high dose of T4 initially. After 5 years, they are extreme fatigue will be there for them because of the high dose. They want to reduce the dose. If you reduce the dose, the TSH will go up. Then they feel the fear of malignancy. So there also we can use this combination, reduce the T4, add T3. You'll see the TSH is low, but the patient is not feeling so much of lack of energy, palpitation, all those things will go.
Floor is open for questions.
Quite interesting. Only one question. We generally give thyroid in the morning before breakfast, once a day. But now you say that this L-thyroxine has to be given twice in a day. How do you go about?
T3 can be given any time in the day, so morning, afternoon or night after food. It is not relation to the
Which one?
T3.
T3.
T4 has to be given in the morning, empty stomach only.
And the dose is to split, is it? Suppose if we take about 5 milligrams per day, do you want to split it into 2 halves and then give
No. If you want to give T3 5,
yes,
then you give it always in the evening if you want to give once daily.
Yes, okay.
That is the best way. Morning T4 and night T3.
Can these two be combined together and given
No,
in the morning?
should not give them together in the morning empty stomach.
Any reason?
The chances of side effects are more. They will feel palpitation because they will be in empty stomach. T3 will immediately act.
Right.
And then after that, the T4 will absorb and then it will convert. They will not feel better.
If it is more than 5 milligrams, we want to dissociate.
Yeah.
Thank you.
Even with 5 also better to give in the, if you are giving 1 tablet, give it in the evening T3. If you want to give 2 tablets, you can give it in the morning after breakfast, before they go to their work or whatever, and then in the evening when they come back home or even after dinner they can take.
Thank you, Dr. Mahesh, for the excellent presentation. So, close the session.
Thank you so much, sir. I now request the chairpersons and the speaker to join for a photo. I also request the speaker to collect his memento from the faculty lounge. Thank you once again. Moving on to the next talk, we have generics and innovators, equal or not, and the speaker is Dr. Pramila Kalra. And to chair this session, I would request Dr. Srinath KM and Dr. Praveen Gangadhar on the stage, please.
Hello. Good afternoon, everybody. The topic for the discussion is generics or innovators, equal or not. Quite an interesting topic to explain this typical tricky situation. Probably the madam would be a better option. I think Dr. Pramila Kalra is a better option. Madam definitely is going to do a justice for this topic. Over to you, madam, without much ado.
Yeah, thanks, chairpersons, for the kind introduction. And at the outset, I thank the organizing team of Krssdi to invite me for this talk. And as the chairpersons rightly pointed out, that it is a tricky topic, because we know that on one hand, we want to reduce the burden of the cost for diabetes treatment or for any other disease treatment. And on the other hand, we also want our patients to get the best treatment. So there is a very fine balance. We know that it's not wrong to use generics. It's not always needed to use innovators, but we also know that whatever we are offering to the patient, we should be very sure that the quality of the product which the patient is getting is good for the patient. So that is what we are going to discuss. We're going to just see the evidence and what data we need to know or we need to understand when we talk about generics versus innovators. Are all generics the same? That also we'll discuss. And how do we decide which generic to use and when? So I'll be just going through this flow. Like, I'll be a little bit talking about what is generic, what are the bioequivalence data. See, when the generics are marketed, they don't need to undergo the phase 1, phase 2 and all those studies. They just need, as per our guidelines or Indian guidelines, our bioequivalence data, and we have to see what is the difference in the bioequivalence, what is the difference in the effect, and the salt and the excipients are critical factors. And also what variations happen, if they happen, especially when we are talking about diabetes treatment, and also what are the problems and what waivers can be possible. So whenever we talk about generic drugs, we know that what is a generic actually? So generic is a drug when we say it's a pharmaceutical product that is usually intended to be interchangeable with an innovator. So ideally, a generic should be absolutely interchangeable. So if we have to use a generic, we can use it at any place, and we should be sure that it is absolutely the same, which can be interchanged with the innovator. And it is not needed that the innovator company has to give a license. That's not needed. And it is definitely can be definitely marketed after the expiry of the patent of the innovator, that we all know. Now, if you see for the US FDA, there are little bit stricter guidelines for generics. So it's a drug product that is comparable to the brand or the reference listed product in the dosage form, the strength, the route of administration as well, the quality and the performance as well, and the intended use for sure. The copies of the brand name of the drugs are the same as those brand name drugs in the dosage form, safety, strength, and route of administration. Meaning to say that if something is marketed as 20 mg, it can be marketed in the generic form also as 20. It cannot become 10 if the innovator is not available as 10. And also the intended use and everything should remain the same. So it's almost pretty much the same, but we know that it is definitely very strict with regards to the generic if you go with the FDA guidelines. Now, if you see, this is the gist of that. So it has to be identical regarding the biological activity, not lesser, and made to the same exacting quality as the innovator product. It should be well tolerated, effective, and meet the same requirements for the strength, the purity, and the quality as well, and identical regarding the biological activity, and the pharmaceutical equivalence should be there. Now, why do we switch to generics in India or anywhere in the world? The major reason is cost saving, because we know that innovators, because they undergo so much of research, and when they come into the market, the cost is always higher as compared to what we get with the generics, and they are mostly cheaper, and they can be cheaper to the extent of not only to 20 to 90%. And we know that this is basically more of a cost saving, especially for chronic diseases, because we know that diabetes being a chronic disease, there are so many chronic diseases, including hypertension, and we also know even generics are lots being used in post-transplant, like we know renal transplant. The drugs are so costly, so that's why the generic picture is definitely needed, but we need to be very sure what we are using. So generic drugs are cheaper because they don't have to go through all those studies starting from phase 1. They can be just having a bioequivalence data and the pharmacoequivalence data to come into the market, and also that leads to the reduction in the cost. And it can lead to price reduction, as I told you, from 20 to 90% of the innovator molecule. So what are the requirements or the process requirements for a generic? We know that there are lots of it, but if you understand major things, what we are worried about. We are worried about that The drug should act properly. The drug should be bioequivalence should be there. The safety of the drug is also very important. It should not cause some new set of side effects, especially when we are talking about like biosimilars and insulin and all. We know that we are more worried about immunogenicity. Similarly, with the generics also, we are worried about that it should not cause any new set of side effects or reactions. So that's more important. What is any microbiology or any other changes, the way it is manufactured, the way it is supplied, it's packed, that also is very important. The shelf life, all these are important. And also the testing for the bioavailability and the clinical studies are definitely needed for the bioequivalence data. And if we see the similarities, they must have the same active substance. That's the first prerequisite. Otherwise, it is not a generic. And the amount of the active substance or the strength should be the same. The pharmaceutical form should be the same. The route of administration should not change. The indications should remain the same. It cannot be that the generic comes for some other indication. And the batch requirements need to be there for identity, for strength and purity and quality. And they have to follow the regulations as well. And we know that they can have different colors. It's not necessary that the generic tablet has to have the same color. They can have sizes different. They can have shapes which are different. They can have different inactive compound. Now, here the catch is, because what is the inactive compound which is added, and the packaging can also be different. So we know that when they are coming into the market, we don't need RCTs with the generics. We need only some heterogeneous population data. We can even have the phase 3, phase 4 data, post-marketing surveillance after that. That all works. And also we know that we don't need big safety data studies. We just need the bioequivalence, and from there we see what are the safety data available, or if there are any new set of side effects which are happening. So we know that in India it's a big market, and it's not only in India, it's world over. So we know that generic is the need of the hour. We cannot say that we cannot have generics, but we need to have generics which are safe for the patient and which are equally effective as regards to the pharmacoequivalence and the bioequivalence. So we know that there are a lot of companies and a lot of which are increasingly helping our patients by supplying more generics. But as doctors or as physicians, our duty is to see that this product is matched with the innovator as regards to the quality. That's what we have to see. So we know that most of the patents are expiring, and we have lots and lots of generics now coming up in our country. So we know that when we say bioequivalence, so we say bioequivalence when the average bioavailability of the test formulation is within a range, and that range is 80 to 125%, that of the reference population. So it has to be in that range. It cannot be less than 80, it cannot be more than the 125 range. And we know that the regulatory limit may not be accurate, as this means that drugs could differ about 20%. So it's not that it is exactly 100% or 90 to 100. It can vary from 80 to 125, and it may become an issue when the drug bioavailability is very less. Like even if you talk about levothyroxine or many of these products, we know that sometimes if the little bit of the difference makes the full difference in the TSH values of the patient. So this is very, very important, that though we have this range categorized between the 80 to 125%, but that actually translates that it could be a difference of 20%, which may be important for especially the medications which have a very, very less bioavailability. Also, we know that there are price problems, price changes which happens, the sale volumes, the profitability, all these make the change, and the generics come with a huge number, and we know that the cost comes down drastically. So these are all the factors which make them go much higher in the sales as compared to the innovators. Now, can the bioequivalence studies be the only thing? So we know that if the product is equivalent to the innovator, and the bioavailability is the same in the sense what we are categorizing here, same word is 80 to 125%. We know that these are one of the acceptable things for a generic to come into the market and be available for the patients. Now we know that there are a lot of bioequivalence, and we have these studies, we have the guidelines available, we have these different types of guidelines, but just going into the little bit of it, that we know that the drug has to be therapeutically effective. It has to be absorbed the same way. It is, as per the innovator, it has to work the same way, and it should act in the same way. And if for diabetes we are talking about, it should reduce the glucose values to the similar fashion what the innovator is reducing to. And we know that they may not be exactly therapeutically identical, but they have to be overall identical with regards to the therapeutic effect. So what are the problems with the bioequivalence studies? We know that it is mostly conducted in healthy adult volunteers. We all know how these studies have to be done as per the regulations. So we cannot be very sure of the same effect in the diseased population. We know that when we start off with any innovator, any new product, the same thing has to happen. Healthy volunteers have to be there. But for bioequivalence, we don't have very strict data or very strict guidelines. And we don't measure the ratio of the active compound oblique the metabolite. And this may be very important where the metabolite is active as the parent compound. So this may change there. So we may say that the drug is bioequivalent, but whether the metabolite versus the compound ratio is the same, whether the metabolite which is available is equally effective in some products, and whether it is the same or the ratio is changing is also very important. And it is not regulatory requirement to see the inactive ingredients in a generic version, and that it has to be identical as the innovator drug. And sometimes even the metabolic product or the metabolite may be accumulating more with some, and that all may be causing more side effects. That also needs to be seen, because this doesn't come out of the bioequivalence data sometimes, and we may not be very sure. So we know that most of these studies are small scale as required by the regulatory authorities, and we know that a steady state level maintenance is very important, which is not the thing which is required by the regulatory authorities. They just need the bioequivalence data, and sometimes the steady state requirement or the steady state levels may be higher or it may be lower. That may also be an important thing which may be very, very important for few of the products. Especially there are a lot of studies available with the post-kidney transplantation where we know that generics are the in thing, but they have seen that there may be more rejections in few of the studies they have shown, especially patients who are on generics. So these are all the things, because all generics may not be the same. So it's not that the generic product is not good. The generic is good, but the generic has to have the adequate data, has to have the bioequivalence data, has to have the metabolite data, has to have the pharmaceutical equivalence data to be available for the patient at the same level as it is for the innovator product. So whenever we are talking about the formulations, and it is not a regulatory requirement that an inactive ingredient in the generic version be the same as the innovator molecule. So that's not compulsory. So we know that it may also be different with the shape, the size, what color is used, or what artificial colors are used. That also makes a difference, because whatever, we all know that even if we go and buy food, we buy sometimes branded and we buy sometimes non-branded. So we know that there may be a difference in the quality. There may not, maybe not. It's not always necessary. So that's why we need data for that as well, though it is not the regulatory 100% requirement. And we need to have the expiry dates, how well it is validated. Then we have to see the packaging, the manufacturing process is another very important. So these are the barriers. Sometimes we see the provider preference. Sometimes some people have that we cannot use generics at all. That's also not right, because we know that it is definitely the need of the hour. The cost factor is a major issue, and there may be translating into the compliance part of it. The patient preference. Patients may ask for a lesser cost drug, and it may be helpful for the patient to comply. But as a physician or a doctor, our duty is to see that we give the best to the patient. Past side effects of a generic product, sometimes we see that some of the GI side effects with some of the anti-diabetic agents may be more with the generics, sometimes as compared to the innovator. Perception of treatment failure after switch, the patient may say, or the doctor may see that the effect is not the same what it was when the patient was on the innovator. Market recalls do happen sometimes for generics. We all know the history. And the lack of understanding of the difference. So also, we need to understand what is a generic, what is an innovator, and what is the difference in the two. And also, sometimes the patients, once they shift the pill to another color or another type of packaging, may not comply the same as they were doing it. So these all things may happen. Even the vice versa may happen. The costly product patient may be taking alternate days, and a generic product patient may take every day, because the cost factor comes down by 30% to the tune of even up to 80 to 90%. So that also makes a difference. So we can see both can happen. But it's just not the patient preference, it's the actual effect. we may not see the same type of the blood pressure control or the glycemic control, or especially we do see a lot of problems with the levothyroxine whenever we see that the patients buy something which is not the generic branded innovator. We do see a lot of problems, and this is even there in our ITS, Indian Thyroid Society guidelines, that the patient is not supposed to change the brand if they are particularly maintained on a particular brand, because we know that they change and the whole bioavailability changes, and it makes a huge difference with a small change of the brand on the TSH values as well. So we know that they tried to do some surveys, and they found that 441 participants to understand the attitude of the participants towards the use of generics. So patients were more inclined to change to generics for minor problems such as like cold or fever rather than for major issues. Especially I have seen that for cardiac, they are always ready to take whatever you give them. Sometimes for diabetes, they say, okay, give me whatever you want to. But for some things which they feel that they may have problems or life-threatening, because they don't sometimes feel diabetes is life-threatening, and they feel that cardiac issues are more life-threatening. So they may not like to change that, and they may try to go for innovators for that. So this is all patient preference also, and individual preference as well. And also sometimes the patients may not prefer to continue the generics for the reason that they may not get the similar effect with the generic what they were getting with the innovator. The safety outcomes is very important. These studies are not much in anti-diabetic drugs, because I reviewed the data, and we have seen a lot of information on coming up with some of the places where there is immediate effect which you see. Like for diabetes, what happens, you may see the effect over a period of time. The HbA1c starts going higher, and it may be attributed to many more things, including the lifestyle and other things, and not to the change of the generic or the brand. But in anti-epileptic medications and other hypothyroidism, there's a lot of data where people have gone fresh epilepsy attacks by changing sometimes to the generics, which are not having the good bioequivalence with the innovator. So these are all the problems which have been there. Impact on the cost and resource use, though, so we know that they have found this, and this is very well there with the meta-analysis also published, where they have found with anti-epileptic drugs more of seizure episodes after shifting to the generics. So antihypertensive also, people have seen data of the systolic and the diastolic pressure going up. So these are all the things which need to be kept in mind when we are thinking about any of the changes. So it doesn't mean that we are not going to use generics. We have to. We have to use it for our patients' benefit, but we have to see that we are giving the right product, see the literature, see the data, what data is available with that particular generic. It cannot be extrapolated to all the other generics. That's how it is. So pharmacokinetic difference also do exist in the generics and the innovator. And sometimes when the therapeutic index is very narrow, this is even more important. So genetic switching can keep the drug levels or bring down the drug levels to the subtherapeutic range, which can be a difference in, as I told you, like epilepsy they have seen, hypertension they have seen. Even for diabetes, it is important, because we know that the change may be actually attributable to the generic, but it may be attributed to many more things. So that's why sometimes it is difficult. So salt and the excipient, just 2 minutes, I'm finishing off. The salt and the excipient is also a critical factor. So whatever the salt formulation is also influences not only the availability, but also the side effects which happen. So it has to be chemically stable, not hygroscopic, and should not cause any processing problems, and has to dissolve as the innovator. So there are a lot of factors which decide the salt selection process, and that is also very important, because that may reduce the cost of the drug. So sometimes the cheaper salts may reduce the cost of the drug. So that should not be done. So as the people who are involved in the medical industry should be aware of this, and they are very well aware of this, and they take care that the salts which are used should not be of cheaper quality, because they make a difference on the absorption, the stability, the tolerability, as well as the safety. And also one very important thing is changing the salt formulation may change the drug-drug interaction. So that's also very important, because sometimes you may not see the same interaction with the innovator as compared to the generic, not because of the bioequivalence, but maybe of the difference in the drug-drug interaction. So we know that there are a lot of examples for atorvastatin for this, ritonavir for the antiretroviral drugs. We have example where the interaction, drug-drug interaction may change when the salt is changed. So we know that if there are changes in the product, it may cause public health concerns, it may cause problems to the patients. So also excipients, it can be related with the loss of the response during the treatment, and sometimes excipients can be responsible for allergic reactions. So we know that not only for anti-diabetic drugs, but few other drugs, we are all aware that this particular generic may cause more allergy reactions, and we don't use them. So we get it to know once we start using that generic and we decided. Similar thing is for the variation in the anti-diabetic medications, we know that it can make the quality of the anti-diabetic medications poorer and can have an impact on the long-term complications and the HbA1c control. So we have to see to it that the anti-diabetic drugs which are available should not be substandard and should have the same bioequivalence, the pharmacoequivalence, and the excipient and the salt should be of good quality so that we get the same compliance, same results, and with a lesser cost for the patients. So I'll just end here. So just at the end, my summary. So we should be cautious and careful when we are using generic switching policy. Read the literature, see what salt they have used. Many times as physicians, we don't tend to see the drug label. That is important. We tell our patients to see the food label. We have to see the drug label. So we have to see what excipient is used, what salt is used. That will give you an idea, because then you will know from your practice what is happening with this product to the patient. It should be an individual decision. See the quality. You are the best judge to decide, but see the evidence and then go with it. And it has to have a proven bioequivalence to the innovator and not to the other generics. That is very important. Many times we get misguided. We see the bioequivalence to the other generic. We have to see the bioequivalence to the innovator product and avoid this generic drift. Because what happens, we think that it is equivalent to the other generic, but is that other generic equivalent to the innovator? So see the evidence, read the drug label, and take your call. Thank you.
Thank you, ma'am. Such a balancing talk. You balanced it out really well between the generics and the innovators. Very commonly we come across, I think many of us label metformin intolerance. You see a good quality metformin, generally we can actually restart metformin in many of them. You will be taking all sorts of combinations. So thank you, ma'am. Thank you once again. Yes.
Thank you so much, madam, for introducing the new term.
Doc,
okay.
One question for you, Doc. Yeah. In your experience of having dealt with both, have you ever felt that there was a generic which was better than the innovator molecule?
No. The answer is no, only for the reason, see, generic is equivalent to the innovator, I accept. That answer is yes. Saying it is better than the innovator, I would say no. Why you are asking that question, I know, because the reason is sometimes you feel that this generic causes less side effects, but that generic may be causing less effects also. That's how I put it.
There has been a leading Indian pharmaceutical which has gone ahead with the newer technology that has been talking about, and they talk about this DMF technology which has been there. So that's one of the reasons why I asked this specific question, because it has always been claimed that this technology as such has been superior, and that drug master file is almost equivalent and even better sometimes.
I'll tell you the reason, because see, whenever we get this data, the main thing of this is we don't start from phase 1 for this. So the problem is we see only the phase 3 and the phase 4. So I agree with you with the phase 3 and the phase 4. But as clinicians, we all know, and as clinicians, as researchers, we all know that the data has to start from phase 1, not from phase 3. So you cannot start a product labeling from phase 3. So you have the information from phase 3, but what will happen at phase 1 and phase 2, you don't know. So that is why I will still say we call it equivalent rather than saying it to be superior. That's how it's a better way of putting it. Yes, if we get the phase 1 onwards, then I would be in a better position to say. So I would say let us use the term equivalent rather than saying super equivalent.
The other challenge we face is the third-party manufacturing, even in the branded companies. So it's a big challenge, but as ma'am said, we need to balance it out. Thank you. Thank you.
Thank you so much, ma'am. I would now request the chairperson and the speakers to join for a photograph, please. A nice term, drug label. Thank you, ma'am. Please collect your faculty memento from the faculty launch. Moving on to the next session, Synergy in Diabetes Care, Maximizing Treatment Effectiveness. And the speaker is Dr. Rakesh Parikh. And to chair the session, I would request Dr. Sudhindra D. and Dr. Prashant G. on the stage, please.
Good morning, everybody. After the nice talk, debate on the innovators and the generics, let's move on to the synergy in diabetes care, maximizing treatment effectiveness. We have none other than Dr. Rakesh Parikh, consultant diabetologist, diabesity from Jaipur. I think everybody well known about Rakesh Parikh. So he will throw upon light about synergy in diabetes care, which is very much necessary nowadays practice. So let's move on with the talk, please.
Thank you, sir. Thank you.
All over to you.
Thank you, Dr. Manohar, Dr. Vijay, and the entire team of Krssdi for inviting me here. My flight is little early, so I'll have to rush fast. I'll try to cover as much as possible. I'll start with a case for the presentation. This is a hypothetical case of uncontrolled diabetic, 52 years old male, diabetes for 4 years, has hypertension as well, and comes with a A1C of 8.7%. The fasting is 144, PP is 198, and the patient is already on glimepiride 3 mg and metformin 1.5 grams, which was the maximum tolerated dose for that patient. So this is not an uncommon problem. I'm sure all of you must be seeing such patients who are already on a very high dose of glimepiride and metformin and still uncontrolled. And this is a data, published data, which shows that metformin-glimepiride combination is the most prescribed combination in India. Most of the patients are on this combination, maybe prescribed by a general practitioner or by a pharmacist or anyone. Now, at this stage, in this particular case, what do you do? The patient is already on glimepiride 3 mg. Do you increase the dose of glimepiride, or do you have some other options? The A1C is 8.4. Now, before coming back to the case again, I'll just put some data about ICMR INDIAB study, which was presented yesterday by Dr. Mohan. The current prevalence of diabetes in India is way higher than what it was expected to be by the IDF Atlas. We now have 101 million people with diabetes. And if we talk about the average control in these patients, the average A1C in India is around 8.5 to 8.7%. There are multiple studies showing this, but this data is from ICMR INDIAB study. And the average fasting is 172, average PP is 253. All these patients are already on treatment and still their A1C is not controlled. So what is the reason behind this? We have 2/3 of our population which is having A1Cs beyond the suggested target limits. Now we know from the UKPDS days itself that irrespective of whether the patient is in the intensively treated arm or conventionally treated arm, the A1C rises over the period of years, and that is the natural course of diabetes that we all know. And recently, this study, grade 2022, was published. In this trial, the patients were on metformin at baseline. Their A1C was around 7.5%, and then they were randomized into 4 arms. One arm receiving the glimepiride, other arm receiving the TZD, third arm receiving the GLP-1 receptor agonist, fourth receiving the DPP-4 inhibitor. And in all the 4 arms, it was seen that there was a drop in the first 6 months, but after 1 year of having the second drug, the A1C started rising gradually over a period of next 4 years. The reason is that we know that diabetes is not a single disease. There are multiple pathophysiological defects. We started with only resistance and deficiency. Now we have this ominous octet. People talk about dirty dozen, sweet 16, and so on. So there are so many defects which are identified. Among these, the major ones, that is insulin secret defect in the beta cells and the resistance in the liver as well as the skeletal muscles, is taken care of largely by the combination of metformin plus a sulfonylurea. But what about the other defects? So if you are not addressing the whole pathophysiology of diabetes, then probably that will lead to the failure of the medicines in the future, and that is why we should probably add a drug which can have or which can address the multiple pathophysiological defects. So in this, if you see, DP4 inhibitors is a group of drugs which has action on beta cells, on alpha cells, some role in reducing the resistance at liver as well as skeletal muscles. It corrects the incretin defect also. It also has some effect on the neurotransmitter dysfunction. So that's probably a drug which can be added to all these patients. Now, this has been shown multiple times in various conferences. The conventional approach was a stepwise treatment approach where we allowed the patient to fail. So the patient were earlier given only diet and exercise, then they would come back after 6 months with a high A1C, then we start OAD monotherapy, which will not be able to bring down the A1C to normal. They might come to 7.5, again rise to 8.5, and then add up titration, and so on. So the patient is actually not achieving the target of A1C 7% anytime throughout his life. Now the approach is changing, and now we are going more proactive and earlier intervention. So in this approach, we start with probably a combination of therapy in the early stage, and we do not allow the patient to go to HbA1c of more than 7.5%. As soon as the A1C goes above 7.5%, you either up-titrate the dose or add the second drug. And if we follow this approach, probably we can keep the patients under control of less than 7%, and that is what is now recommended by most of the guidelines. These are the AAC guidelines and ADA guidelines, which all talk about early use of combination therapy in the treatment of diabetes. Coming back to the same question, in that particular patient, do we increase the dose of glimepiride or add another drug? Now, what is the problem with glimepiride? Glimepiride, we all know that it is a very potent drug. It can bring down the A1C, it can bring the sugars under control, but it also comes at a risk of hypoglycemia. And hypoglycemia is a very common problem with glimepiride. And this has been shown in multiple studies. In addition to risk of hypoglycemia, it also can cause weight gain, and it is also suggested that it leads to beta cell failure or exhaustion over a period of time. And that is why probably we need to have some other drug. The other option can be to utilize the synergy between these three different drugs and try to down-titrate the dose of glimepiride and add sitagliptin. So in this particular case, if we reduce the dose of glimepiride from 3 to 2 and add sitagliptin, will that help? To address the same question, there was a study which was done by Sun Pharma, and I'm presenting the data from that study. It was a phase 3 study. So in this study, the objective was to assess the efficacy and safety of a fixed dose combination of glimepiride, metformin, and sitagliptin. They had a population of around 400 patients across India. It was a 30-week study, and it was a randomized study. I'll show the design in the next slide. So in this particular study, at the baseline, they had the patients who are already on the full dose of glimepiride, which is 4 milligram, and the maximum tolerated dose of metformin, which is 1500 milligram or more. So it can be 1500 or 2000 also. And they were on this stable dose for at least 10 weeks, and A1C was more than 8% and below 11%. Now these patients were randomized into two different arms. In one arm, they received a fixed dose combination of Sita 50 plus metformin 1 gram plus glimepiride 1 mg twice a day. So here the dose of glimepiride has been reduced. In the other arm, which was a comparator arm, they were given a co-administration of metformin 1 gram BD and glimepiride 2 mg BD with matching placebo. And this randomized period lasted for 16 weeks. At the end of 16 weeks, the study was concluded for the patients who are in the comparator arm. So for the patients who are already on 4 milligram, if they are at the end of 16 weeks, the study was over for them. But for the test arm, in case the patients are unable to achieve the A1C of less than 8%, then they were further up-titrated to glimepiride 2 mg, metformin 1000, and Sita 50 twice a day. And then they were followed for 16 weeks. So for the test arm, there were two phases, phase 1 and phase 2. And for the comparator arm, it was only 16 weeks. So these were the inclusion criteria: diabetic patients 18 to 65 years of age, type 2 diabetics, A1C between 8 to 11, patients on full dose of glimepiride 4 mg, metformin more than or equal to 15 milligram, and stable for 10 weeks, a body mass index less than 45, and women with childbearing potential were advised to follow the contraception. The study endpoints were, the primary endpoint was the mean change in A1C from baseline at the end of 16 weeks. And there were secondary endpoints like the mean change in A1C at the end of 28 weeks, the drop in fasting and postprandials at the end of 12 weeks, 16 weeks, 24, 28 weeks, proportion of patients achieving the A1C of less than 7, the number of patients requiring hypoglycemia management, the number of patients requiring rescue medications, and then safety assessments were done. So what are the results of this study? These are the baseline characteristics. So at the baseline, both the treatment arm as well as the comparator arm are comparable. They all have a fair distribution of male-female gender, average age is 47 years, the average BMI is 25 years. The average duration of diabetes was 2 years in this study. The results are like this. So after the follow-up of 12 weeks, there was a drop in A1C in both the arms, a little bit more in the test arm, that is the FDC, and at the end of 16 weeks, there was a significant drop in the FDC arm, and the difference between FDC and comparator was significant statistically. So in this particular study, what they have shown is, despite lowering the dose of glimepiride, they were able to have a better A1C reduction in the patients who were receiving the fixed dose combination along with sitagliptin. And this is the drop in A1C from 12 weeks to 28 weeks. As we can see, there is a gradual drop from 1.8%, 1.18% to 2.37%. Overall, a drop of 2.37% at the end of 28 weeks. The reduction in A1C, with this reduction, 71% of the patients were able to achieve the A1C target of less than 7%, and this was in the arm which was receiving only glimepiride 1 mg, Sita 50, and metformin 1 gram BID. So this was after the de-escalation of glimepiride. And this is, in those patients also, you can see the drop in A1C was there, and the overall drop was 2.53. So again, 71% patients could achieve the A1C target of less than 7. And this is the drop change in the fasting plasma glucose, again 32.6 at the 12 weeks, and then it came down to up to 53.6 milligram per deciliter by the end of 28 weeks. Similarly, the drop is seen in postprandial glucose also, up to the tune of 78.6 milligram per deciliter by 28 weeks. And these are the number of patients who could achieve the A1C target of less than 7%, a combined data of phase 1, phase 2 both. So by the end of 12 weeks, 32% patients were having an A1C of less than 7% in the test arm compared to 12% in the comparator arm. And by the end of 28 weeks, 53% patients were able to achieve the A1C of less than 7%. So these are the efficacy conclusion. The fixed dose combination of Sita plus glimepiride plus metformin was significantly superior in comparison to co-administration of metformin and glimepiride in terms of A1C reduction at the end of 16 weeks. And now the safety results. So these are the adverse events or safety profile of both test arm and comparator arm. There were around 31 adverse events in the test arm and 36 in the comparator arms. There were no serious adverse events, and treatment emergent adverse events were also comparable. So there was no significant difference in terms of the safety of both these arms. And these are the adverse events seen in the patients in the phase 2. From week 16 to week 28, there were only 8 adverse events. Nothing was serious in this. So when you look at the number of patients requiring treatment for hypoglycemia, again it was comparable. In the double-blinded phase, 4 patients had a total 7 hypoglycemia events, out of which 3 patients had 5 events. They were on FDC. And then there was 1 patient having 2 events in the co-administration of metformin plus glimepiride arm. In open label phase, which was the next phase, there was 1 more event of hypoglycemia which was observed in the FDC arm. All events were level 1 asymptomatic. There was no significant difference between both the arms, and no patient required any management for hypoglycemia during the study period. So the safety summary was that all the treatment emergent adverse events were either of mild or moderate severity in the test arm. There was no serious adverse event. The 28 drug-related TAEs were reported in the study. Out of 28 events, 12 events reported in the test arm and 16 events reported in the comparator arm. The causality assessment of all were probable or likely possible. TAEs leading to drug withdrawal were not reported in the study, and hence the FDC sitagliptin plus glimepiride plus metformin is considered to be safe and well tolerated. So the study concluded that FDC of this Sita plus metformin plus glimepiride was superior in comparison to the co-administration of metformin and glimepiride at the end of 16 weeks. The study drug was well tolerated and it was safe. Now, basically in this FDC, they are exploiting the synergy between different molecules. So as we know that glimepiride increases the beta cell function, metformin addresses the resistance, so both of them in combine address the key core defects. Then there is a synergy between DP4 inhibitors and glimepiride also, because both of them act on the beta cells, but by different mechanisms. One is glucose dependent, another one is not glucose dependent. Metformin also potentiates the DP4 inhibitor effect by increasing the active GLP-1 levels in the body. Then glimepiride increases the glucagon levels, but DP4 inhibitor takes care of that. So that way there is a synergy. Metformin and sitagliptin, they both act on the hepatic insulin resistance and reduce the hepatic glucose output. Sitagliptin increases the HUMA beta when administered along with glimepiride. And when these two drugs are combined together with a lower dose of glimepiride, they have shown to have better glycemic control with no risk of increasing the risk of hypoglycemia. So we can utilize this synergistic action to reduce the risk of, to reduce the hyperglycemia, as well as to reduce the risk of hypoglycemia and reduce the burden on the beta cells. So to come back to the same question, when we have patient like this, it is probably better not to increase the dose of glimepiride, but rather go for a step-down approach, bring down the dose of glimepiride, and add the third drug. And this is what is offered by this synergy between the three drugs. So these are the probable candidates where we can go for this particular combination. In patients who are already taking a sulfonylurea, metformin, and TP4 inhibitor, we might probably use this combination to reduce the pill burden. In patients who are uncontrolled, having a A1C of more than 8% on dual therapy, again, you can use this triple drug therapy. In patients who are uncontrolled with the risk factor for ASCVD or CKD and who have a eGFR of more than 30, because that is required for sitagliptin, you can use this drug. And in patients where the where the patient is already on sita plus already on glimepiride plus metformin, you want to reduce the risk of hypoglycemia, you can de-escalate the dose of glimepiride, add sitagliptin there. Also in patients who are recently diagnosed but they have a very high A1C of more than 8 to 9%, you don't expect only mild drugs to work there, so maybe you can use a triple drug combination there also. So I end my presentation here. Thank you very much. If there are any questions, I'll be happy to.
Thank you very much for the lucid presentation, sir. All of us know that the diabetes is a progressive disease where there's a combination work, where we have to balance both hyperglycemia as well as hypoglycemia. You wonderfully demonstrated in reducing the dosage of sulfonylurea and in a synergistic combination. It's very well taken, and now the floor is open for the question.
Before we will open the question, Rakesh, in the phase 3 trial, was there any criteria for body mass index? Because metformin you have taken 1000 milligrams. So is there any body mass index was the inclusion criteria? Also, is there any metformin intolerance in all those patients?
Yeah, so the criteria for body mass index was that all patients had a BMI of less than 45. They were not morbidly obese, but otherwise obese patients were included in the trial. Patients might have metformin intolerance, but the maximum tolerated dose was at least 1.5 grams. So all the patients who were in the trial, they were already on at least 1.5 or more than that.
So this is making news now. This combination is making very good synergistic action, and we can good use of this sita, metformin, and glimepiride.
Probably
so
for
very well.
At least reducing the pill burden, because patients psychologically feel that I am only on one tablet.
Very well. So open for discussion. Any questions from the audience? So thank you, Dr. Parekh.
Thank you. Thank you very much.
Wonderful.
Thank you so much, sir. Now I request the chairpersons and the speakers to join for a photograph. Thank you so much, sir. I request the chairpersons and the faculty to collect their memento from the faculty lounge. Thank you so much, sir. Moving on to the next session, we have a talk on heart failure and diabetes. To address this, we have with us Dr. Sirish Navagundi, and also to chair the session, I would request Dr. K.P. Balraj and Dr. Nutan Kumar on the stage, please.
Thank you. I'm Dr. Girish Navasundi, and I thank my chairpersons and august audience and the organizers of RSDI. It's always been a pleasure. I think you're one of the most progressive scientific forums that exists in the country, and I was very glad to know that you've been chosen the best state RSDI. Congratulations, and I'm very proud to be part of this today's discussion. Coming to, I think, the paradigm shift that has happened in diabetes management is not just glycemic management, but prevention of end organ damage. I think with that perspective, I would be discussing on diabetes and heart failure. Just to give you the magnitude of problem, when you look at the heart failure, 1 year mortality approximately 45%, survival ranges from 80% at 2 years for patients who are rendered free of congestion to mortality of less than 50%, I mean survival of less than 50% at 6 months for patients with a refractory heart failure. You know, this is how worse heart failure can be. Oh, I'm sorry. Why are my slides not moving? Can somebody help me? Okay, thank you. Right. So 1 year mortality of approximately 45% and survival ranges from 80% at 2 years to less than 50% at 6 months for those who have refractory heart failure symptoms. That sinistric is this disease. Heart failure admission rates are rising, and the prognosis of heart failure has been compared with that of malignancy, with a 6-year mortality rate of 84% in men and 77% in women. So heart failure kills people much more surely than most cancers. Coronary artery disease is the cause of 2/3 of the left ventricular systolic dysfunction cases. Now look at the projections. In 1991, if the prevalence was about 3.5, in 2000 it's 4.7, and by 2037 it's going to be 10%. So it requires all your understanding and prevention of this disease. Now look at the association of diabetes and heart failure. When you look at the prevalence of diabetes, it's increased 30% globally, and India estimated 77 million people above the age of 18, and nearly 25 million are pre-diabetics, apart from the 77. Type 2 diabetes mellitus is a risk factor for an incident heart failure and increase the risk of morbidity and mortality in patients with established heart failure. Diabetes and heart failure often occur concomitantly, and each disease independently increases the risk for the onset of the other disease. In heart failure patients, heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, the prevalence of diabetes ranges from 10 to 47%. So that is how closely they coexist. The prevalence of diabetes is higher in patients with hospitalized heart failure patient, with some reports stating more than 40% or those who are admitted in hospital for heart failure have diabetes. In patients with diabetes, prevalence of heart failure is between 9% to 22%, which is 4 times higher than those without the diabetes. In studies of 18,000 people without diabetes, at high risk for cardiovascular disease, 1 millimole per liter higher fasting plasma glucose was associated with 25% increased risk of heart failure hospitalization. 1 millimole, 25% higher risk of heart failure. The risk of heart failure associated with diabetes might be even higher in younger adults and women, and diabetes is also an important predictor of the development of symptomatic heart failure in patients with asymptomatic left ventricular systolic dysfunction. Why am I talking so much epidemiology? Because that is the magnitude that you must go back with understanding today. Furthermore, poor glycemic control is associated with greater risk of development of heart failure. For 1% increase in HbA1c, heart failure incidence increases by 8 to 36%. Just 1% increase in HbA1c. The association with mortality and HbA1c in diabetes patients with heart failure appears to be U-shaped, with the lowest risk of death in patients with HbA1c around 7. So if you can maintain an HbA1c at around 7, that's when you have the least morbidity and mortality. Hypoglycemia increases death in heart failure, hyperglycemia increases death in heart failure. The risk of incident heart failure among patients with diabetes increases with older age, existence of coronary artery disease, presence of peripheral arterial disease, nephropathy, retinopathy. Longer the duration of diabetes, higher the chance of heart failure, obesity, hypertension, and higher NT-proBNP level. The risk of heart failure increased even with milder abnormalities in glucose regulation. They didn't even have to be diabetic. If the HbA1c moved from 5.5 to 6.5, there's increased incidence of heart failure. So what does studies say? In the Framingham study, for the people with between 45 to 75 years of age, 5,000 patients, incidence of heart failure in diabetic men was about 7.6 per 1,000 patients, but who did not have diabetes, it was half of that, just 3.5 per 1,000. Among women who had diabetes, higher prevalence of heart failure of 11%, and women who did not have diabetes, 2.2%. Women are again very neglected population among heart failure. So adjusted risk for heart failure with or without diabetes is about 1.82 for men versus 3.75 for women. In the NANES study, you realize people between 25 to 75, the cumulative incidence at age 85, diabetes men, 65% had diabetes. Those who did not have diabetes, only 36%. Now, coming to the subclinical cardiac abnormalities that exist with diabetes. Patients with diabetes without symptomatic heart failure nevertheless often have subclinical abnormalities of cardiac structure and function corresponding to ACC and AHA classification of stage B. You know, heart failure is categorized into stage A, B, C, D. A means those who are at risk of heart failure but do not have any structural abnormality, don't have symptoms. Stage B, they have a structural abnormality such as either a myocardial infarction or a left ventricular hypertrophy secondary to hypertension or diabetes, but no symptoms, no abnormality. Third, those who have structural abnormality and symptoms. Fourth, refractory. So people with diabetes most often have structural abnormality without symptoms. What are the structural abnormality that you normally see? Either a systolic dysfunction where you see that the left ventricle dilates, or a diastolic dysfunction where you see that wall thickness has increased, left ventricular hypertrophy. The contractile myocytes are replaced with interstitial fibrosis, so it becomes stiff. The left ventricle compliance, ability to expand and accept the blood without increasing the pressure, is lost. That's what we call diastolic heart failure, where the pressure from the left ventricle is transmitted back to left atrium and pulmonary veins. So that's heart failure with preserved ejection fraction. So there is increased LV mass, relative wall thickness, and left atrial sizes increase. There's diastolic dysfunction and increased extracellular volume fraction. So when you look at the non-diabetic patients with heart failure, in charm and emphasis, you realize that incidence of diabetes was 28 and 21% per 1,000 patients. That is, non-diabetic patients who have heart failure, the incidence of diabetes was 28% versus those who did not have heart failure, incidence was only 9.4 to 10.9%. So heart failure increases the probability of diabetes development. So how do you predict these people? Predictors of incident diabetes among heart failure patients are those who have elevated body mass index, waist circumference, smoking, elevated HbA1c, higher systolic blood pressure, longer duration of heart failure, diuretic therapy, and higher functional class NYHA. And why does it happen? Why diabetic people have this preponderance? Diabetes is associated with, as you all very well know, hyperglycemia, insulin resistance, and hyperinsulinemia. This causes two abnormality, one eventually leading to ischemic cardiomyopathy, other one diabetic cardiomyopathy. Because of these abnormality, there's inflammation, abnormal cholesterol, endothelial dysfunction leading to coronary artery disease and ischemic cardiomyopathy. And the other side, without coronary arteries being involved, the hyperglycemia, insulin resistance, and hyperinsulinemia directly cause cardiomyocyte hypertrophy or left ventricular hypertrophy, renin-angiotensin-aldosterone system activation leading to fibrosis, abnormal calcium handling, fatty acid utilization leading to advanced glycated end products, autonomic dysfunction eventually leading to cardiomyopathy and heart failure. So both these coexist in quite a few patients. And the dyslipidemia is quite abnormal in diabetic. All of you know that there is atherogenic dyslipidemia, that is LDL, which particles are more atherogenic. There's an associated endothelial dysfunction, promotes leukocyte and platelet adhesion, thrombosis, inflammation, and plaque ulcerations. And when you look at the diabetic cardiomyopathy, we all know that there is mitochondrial dysfunction, inflammation, and autonomic neuropathy, eventually leading to cardiac stiffness, hypertrophy, and fibrosis, leading to heart failure. So what studies have shown? Diabetic heart is energy starved because of the impaired glucose utilization, accordingly relies more heavily on free fatty acid utilization. This excessively high fatty acid oxidation contributes to abnormalities in energy metabolism of the myocytes, leading to cardiac dysfunction observed in diabetic cardiomyopathy. There is also elevated levels of free fatty acids called lipid accumulation in the cardiac myocytes, leading to lipotoxicity and cardiac myocyte apoptosis. These are the mechanisms. What is the impact of diabetes and heart failure outcome? Diabetes is an independent risk factor for death due to cardiac cause. Risk of hospitalization is 50% higher in patients with diabetes and heart failure than those of heart failure without diabetes. Hospital readmission is modestly increased in patients with diabetic. Although intensive glycemic control does not appear to reduce the risk of all-cause mortality and cardiovascular mortality, studies have shown an HbA1c of around 7.1 is associated with least hospitalization and least deaths due to heart failure. When you look at the HbA1c goals in patients with diabetes, mellitus, and heart failure, you must consider these factors before deciding on what HbA1c you should target. Patients' clinical and functional class means those who are very sick, class 3 and 4, you can be lenient up to between 8 and 8.5. Self-management capacity, whether patient is able to take, social support, medication side effects and cost means causing hypertension, hyperkalemia, creatinine increase, then hypoglycemic risk and treatment burden. You need to consider all this. You need to target an HbA1c of close to 6.5 in those where you expect young heart failure, long life expectancy, in early heart failure stage A, B, no serious comorbidities, no serious diabetes complication, and no medication side effects and hypoglycemia on treatment burden. Such people be very aggressive, but as the problems increase, stage C heart failure, or microvascular or macrovascular complications, severe hypoglycemic episodes, target between 7 and 8. Coming to the drugs, we all know, how do you treat them? I think today the guidelines are very clear. Don't start a diabetic treatment for glucose management. You start a diabetes treatment for morbidity and mortality reduction. So first you need to ask yourself whether patient has heart failure or multiple risk for atherosclerosis or an established atherosclerosis. If yes, SGLT2 inhibitors and GLP-1 RAs are the first line of drugs along with metformin, and then you add other drugs. If there is no high risk for atherosclerotic cardiovascular disease, no established atherosclerotic cardiovascular disease, no heart failure, then you can choose other class of drugs. So mandate is very clear. Cardiovascular outcomes is the determinant factor for choosing diabetic drug. So coming to the metformin associated with better short-term and long-term prognosis, associated reduced mortality in heart failure, reduced cardiovascular hypertrophy, and metformin can stimulate cardiac glucose uptake. So better glucose utilization and too much dependence on fatty acid is not there. Coming to sulfonylureas, originally thought to increase mortality, but not with the newer generation, no definitive CV outcome trials to evaluate cardiovascular safety of sulfonylureas versus placebo. Meta-analysis have showed no increased cardiovascular risk, so they are cardiovascular neutral at this point of time. And retrospective cohort study reported an increased CV risk patients on sulfonylurea versus metformin or DPP-4 inhibitors. So for a cardiologist, I think this is a third class of drug, not the first. It's SGLT2 inhibitors, GLP-1 RAs, DPP-4 inhibitor, then come sulfonylureas. Thiazolidinediones, we know that reported to be very effective, although showing beneficial effects on BP control, inflammatory biomarkers, good glycemic control, triglyceride, but there was increased cardiovascular outcomes mainly for fluid accumulation and heart failure rehospitalization. So the fluid retention and weight gain is a reproducible side effect with thiazolidinediones, which preclude its use in NYHA class 2, 3, 4 heart failure patients. Coming to GLP-1 agonist, I think these are the drugs for atherosclerotic dominant diabetic patients. Meta-analysis reports no increase in risk of heart failure or hospitalization for heart failure, and revealed a modest improvement in ejection fraction in heart failure patients, and trials with GLP-1 agonists advanced heart failure revealed trend towards increased hospitalization in diabetes. DPP-4 inhibitors, Saver-Timi, as well as Examine and TCOS, do not reveal increased heart failure risks. They're all cardiac safe. They're definitely not harmful. Experimental studies in humans and animals show improvement in cardiac function when GLP-1 was activated by DPP-4. Now, the great class of drugs today when you diagnose a heart failure, these foundational 4 is very, very important. SGLT2 inhibitors, beta blockers, MRA, and ARNI. These 4 class of drugs have to be there for all your patients, and you need to initiate them within a span of 1 week and then keep up titrating to the most tolerable doses. SGLT2 inhibitor has been a wonderful molecule for glycemia, weight, diabetes, heart failure, nephroprotection. Beta blockers, maximum reduction in sudden cardiac death and better remodeling. Mineralocorticoid receptor antagonists such as spironolactone, eplerenone have been greatly reducing fibrosis, arrhythmic deaths, and heart failure readmissions. ARNI, phenomenal 30 to 35% reduction in heart failure readmissions and risk of sudden cardiac death. Thank you. Lastly, I think a word on SGLT2 inhibitors. We all know that there is about 26% relative risk reduction for cardiovascular death and worsening heart failure. CV death reduction is about 18%, worsening heart failure 30% relative risk reduction. Patients needed to treat is just 7. Similarly with dapagliflozin. So I would not waste much time. Thank you for your patient hearing. Any?
And heart failure, and also stressing on the importance of the epidemiology and also the management, where the earlier and strict control of the diabetes is very important to prevent the further hospitalizations and preventing further complications of the diabetes. As you pointed out, it's very important to prevent the complications of the diabetes, also along with treating the diabetes and preventing the heart failures and hospitalizations and cardiovascular deaths. So thank you so much.
Thank you. Yeah. Thank you. If there are no questions, it's just a continuum. Diabetes, heart failure, coronary artery disease, renal failure is a continuum. I think we'll have more and more drugs which would have protective effect across. Thank you.
Thank you so much, sir. I now request you to join with the chairpersons for a photo. And I also request the faculty to receive their faculty memento from the faculty lounge, please. Thank you so much once again. Moving on to the next session, this is a big debate, and the topic is, this is the end of era of evidence-based medicine. And to speak for and against, we have with us Dr. Anil Kumar Virmani and Dr. Basangoda Pasar. And to chair the session, I request Dr. Sanjeev Rao and Dr. Pradeep Kumar, please. Oh, Dr. Manohar is here. Dr. Manohar and Dr. Sanjeev Rao.
Can join. Please join. Well, debate, usually we see youngsters fighting each other sometimes, but it is a topic in contention. And debate, nobody wins or loses. All of us will learn. So, era of evidence-based medicine now. There is an era where our senior teachers like BG sir and Virmani sir were practicing more of eminence-based medicine. Sometimes people used to say it as eminence-biased medicine. So welcome to this big debate. I welcome Dr. Anil Kumar Virmani, consultant physician and diabetologist from Jamshedpur, EC member of Central RSSDI. So what are you going to say, sir?
Whatever you want me to say.
You are for it or against evidence-based medicine, to make it simplified?
Well, I will be speaking for the topic that it is the end of era of evidence-based medicine.
So, sir is speaking for the topic that is against evidence-based medicine. So he's saying evidence-based medicine is not correct.
First slide.
So we will over to Dr. Anil Kumar Virmani.
Thank you. Good afternoon, friends, honorable chairpersons, Dr. Basavan Godappa, my good friend. He is a very respected man in Karnataka, a very passionate teacher and a master researcher. Greetings from the Hausala dynasty which I am supposed to represent today. The topic for today is this the end of the era of evidence-based medicine? So when I decided to say yes, and this was the reaction of my friend BG, I'll call him BG, he thought that people who don't think like me also exist in this world. So I was wondering, why is having so soft corner for evidence-based medicine? And then I realized it was in 1990 that he rescued evidence-based medicine from the experience-based medicine. Of course, when I heard this, I also fell in love with evidence-based medicine. So what is evidence-based medicine? It has been the cornerstone of medical practice for decades, based basically on randomized controlled trials, studies of both prospective and retrospective, non-randomized trials, clinical experience. And if you be surprised to know, this was started by a group of epidemiologists, not clinicians, from McMaster University. And they claim to have initiated a new paradigm of medical practice with greater reliance on published data in clinical practice, proposed a hierarchy of evidence with clinical trials trumping mechanistic reasoning and clinical judgment. I followed this evidence medicine for the last 3 decades. And gradually I realized that rapid advancements in technology, personalized medicine, and a growing emphasis on patient-centered care heralds the end of the era of EBM, mainly because relying predominantly on RCTs and systemic reviews, it has failed to encompass the complexities of individual patients, their unique genetic makeup, and diverse cultural backgrounds. So we must also, besides giving it credit, also realize its drawbacks. And the biggest drawback of evidence-based medicine is relegation of clinical judgment and mechanistic reasoning and over-reliance on the reliability of clinical trials and systematic reviews. And we also know the limitations of clinical trials, unrepresentative of trial patients in terms of age, elderly often excluded, therapy and comorbidity. Patients with comorbidity are not included in the trials, over-reliance on statistical as opposed to clinical significance. The magic figure of less than 0.05, everybody is looking for that. So they will say the results were clinically significant but did not reach statistically significance. Misleading results due to reporting bias, inappropriate pooling of small trials, effect of changes in disease mortality and prognosis over time. Moreover, there are adverse effects on clinical practice, bias of the easy measurable risk. This bias of commissioned research can reduce independence of topics selected for study and distort the evidence base. And you very well know which topics are selected for research and which are not. An exclusive focus on drugs and devices, because there is conflict of interest, has left large aspects of health in an evident vacuum. So what data is being measured? What can be measured and how is the data being used? When you are talking about outcome measures such as mortality, morbidity, and cost effectiveness, they are effective methods for this purpose and relatively simple to assess. However, other less tangible but very important elements of medicine are more difficult to quantify, such as the quality of care, patients' experience of illnesses, respect for human dignity, and contributions to knowledge base. We all rely on guidelines, but remember, friends, guidelines inform practice. It does not dictate it. They do not replace the knowledge and skills of clinicians. When you are seeing a patient, critical patient in emergency, you are not going to open the book of guidelines and see how to treat the patient. Doctors are expected to be familiar with guidelines, but this does not mean that they cannot depart from the guidance when in the best interest of the patients. They must be prepared to explain and justify, however, their decisions and actions in such cases. That is also important. There's a huge list of problems which I'll discuss one by one, but the biggest problem today is the publish or perish culture. And that has fueled and enhanced the growth of predatory journals, which is a major threat to academic research. And these predatory publishers prioritize profit over academic integrity, and they charge exorbitantly for a non-existent peer review. And that is why even a person like Professor Anup Mishra, who is one of the master researchers and the editor of the most prestigious journal, Diabetes and Obesity, remarked, hyperproductive authors, questionable research practices, India is third after Saudi Arabia and Italy. What a shame. Publications, selective publications. Look at the amount of unpublished data that is not going into your meta-analysis. Negative trials are going to be suppressed. If you look at antidepressants, 36 out of 37 studies that were favorable were published. But 3 out of 36, only 3 out of 36 where it was not favorable. In 2008, Sanofi completed 92 studies, but only 14 were published. The rest were not favorable to them. So it's obviously idiotic to publish data which is not favorable to you. It is financial suicide. So this is going to happen. But if I tell this in academic circles, you're going to say that I am a quack who does not believe in evidence-based medicine. Suppose you know that your stockbroker publishes all his winning trades but suppresses his losing trades. Would you trust him with your money? No, but yet we trust EBM with our lives. And all the non-significant results are shelved, and you don't know, and they don't come in the meta-analysis giving a wrong picture. There is rigging of outcomes. Before 2000, you could decide anything, do a trial, see which is the best outcome and publish it, and say my trial is a success. But in 2000, the government moved to stop this shenanigans. They said, you must decide what will be your primary and secondary outcomes. Prior to 2000, 57 of the trials, 57% trials showed a positive result. After 2000, only 8% showed. What was the data that was being fed? Evidence base was being completely corrupted by commercial interest, and the academic physicians who were getting rich on it tacitly allowed it because they know you cannot bite the hand that feeds you. Advertorials. A review paper in NEHM said that biphosphonates do not cause fracture, or the fracture risk is very low. Now this was as an advertorial, an advertisement in an editorial published in one of the most prestigious scientific journals, that is NEHM. And this is the very pinnacle of evidence-based medicine. Is it correct? Is it justified? Money from reprints. Every journal wants to be read. So they have impact factor, which means that how many times it has been cited. Now, nothing boosts rating like a blockbuster produced by a big pharma. They have the contacts and sales force. They will, if they publish something in NEHM, they'll make hundreds and hundreds of copies, sell it to the doctors down the line, and you know how much money they are giving? The NEHM publisher, Massachusetts, gets 23% of the income from reprints, the Lancet 41%, the American Medical Association, a gut-busting 53%. And who is being fooled? The ordinary physician sitting in the clinic who is told that this is the best drug for you. It pays. Who needs journalistic ethics when you have a Mercedes in your backyard? More money, baby, more money. That is the thing that they want. Bribery of journal editors. My God, look at this. This was a study in BMJ, and they looked at the open database. And what did they find? Conferences are held in beautiful European cities like Barcelona, but very few in the cold Quebec City. And do you know how many editors were on the take? More than 50% editors were on the take. And the average payment in 2014 was more than $27,000 for each, plus more than $37,000 for research. Look at this diabetes care, how much money has been paid. JAMA internal medicine, what are we talking about? Then we know the financial conflict of interest that the pharma industry and doctors have. Medical students with more exposure to pharmaceutical reps develop a more positive attitude. The higher your seniority, the more published your papers, the more money you get from the pharma industry. There is a clear and a strong link between taking industry money and minimizing the risk of side effects of medications. What do you think people are taught in the prestigious institutions? They came for science, but they stayed back for money. The corruption of evidence-based medicine, killing for profit. Look, NEGM editor in 2002, Dr. Relman said, the medical profession is being bought by the pharmaceutical industry, not only in terms of the practice of medicine, but also in the terms of teaching and research. The academic institutions of the country are allowing themselves to be paid agents of the pharmaceutical industry. It is disgraceful. Dr. Marcia Angel in 2008, again from NEM, wrote that I have reached slowly and reluctantly with the 2 decades as an editor, the judgment that these guidelines cannot be trusted. Richard Horton from the Lancet in 2015 said, the case against science is straightforward. Much of the scientific literature, perhaps half, may simply be untrue. And these are top editors who have learned in their lives. So it is very difficult to believe what is true and what is not true. It is like building a wooden house knowing that the wood is termite infested. You have got corrupt evidence base by which you are developing evidence-based medicine. So what if there is no evidence at all? Then you have what Dr. Manu was saying, eminence-based, vehemence-based, eloquence-based. It all depends upon your seniority, sartorial elegance, and eloquence that counts. So my dear friend BG, evidence medicine गर्लफ्रेंड और सरकार यूं ही नहीं बनती, तरह तरह के झूठे वादे और कस्में खाने पड़ते हैं. So to counteract that, in 2015, Barack Obama, then the President of the United States, said, tonight I'm launching a new precision medicine initiative to bring us closer to curing diseases like cancer. And this is, we need personalized information. So changing supremacy of evidence-based medicine through artificial intelligence, the time has come for a change in paradigm. In 2016 Davos Summit, Klaus Schwab said, we stand on the brink of a technological revolution that will fundamentally alter the way we live, work, and relate to one another. In its scale, scope, and complexity, the transformation will be unlike anything humankind has experienced before. Things which we thought were unreal, like nanotechnology, artificial intelligence, deep learning algorithms, internet, 3D things, are now reality. So from traditional, we were in evidence, and now we must shift to precision medicine. Evidence-based medicine has been a failure approach. You treat, fail, treat again. This will give you a personalized treatment, and it will be absolutely providing the right medicine to the right patient at the right dose at the right time, based on the various factors. It will revolutionize how medicine is practiced. No longer will we focus on symptomatic disease management and empirical drug prescribing, but will move forward to a new era of individualized medicine. Evidence-based medicine is group recommendations based on RCTs, patient preferences, and clinicians giving us guidelines. We must now shift to deep medicine, true individualization based on artificial intelligence, patient preferences, clinicians, and that is deep learning. So one size fits all to stratified medicine and basically to precision medicine, where we'll be treating the individual very nicely. So either we can offer them genetic therapy or repair the defective gene, or pharmacotherapy to compensate for it, and we might even be talking of complication-preventing drugs. It is basically nothing but VIP therapeutics, that is, virtual image of the patient is created and he is treated. So yesterday we were treating symptoms, that was intuition medicine or experience medicine. Today we are in the pattern-based, evidence-based medicine. tomorrow we must shift to algorithm-based precision medicine. From traditional to precision, you know your genome sequence contains 3 billion DNAs. You wouldn't wear just any pair of glasses. Your prescription is tailored to your vision. It is more important to know what sort of a person has a disease than to know what sort of a disease a person has. And this is an innovative approach. So the paradigm shift to bright future, after almost 30 years of EBM supremacy, I am not against EBM, but there is something better than EBM now. We have realized EBM does not give us all the answers. And many RCTs cannot be done. Process of medical diagnostic or therapeutic decision making could and would be possible thanks to the use of specific machine learning or algorithms. So scientific interest is now going to shift.
Sir, we need to wind
from,
up.
just 1 minute, from providing evidence to developing self-learning and pattern detecting AI solutions. This very step is what is called the transition from EBM paradigm to deep medicine concept coined by Eric Topol. So let's pay a tribute to evidence-based medicine. Trust me, I'm a doctor, takes a backseat, show me the data, let's make sure it's proper. In a world of snake oils and miracle cures, yes, you have been the reliable compass guiding us through the fog of medical myths. I salute evidence-based medicine, but the time has come for a change. Welcome to the era of precision medicine, the forefront of healthcare's evolution, where individual uniqueness isn't just celebrated, is the cornerstone. Treatments are tailored, diseases are dissected with personal precision, and your genetic code becomes the roadmap to your well-being. So friends, is nothing but innovation and individualization. Like this you will find in a place which has got prohibition. So cheers to a future where one size fits all will be a relic of the past. Thank you.
Wow. We thought the battle is already done and dusted, and you have just opened the Pandora's box, and this is a huge evidence on what you have presented, on what is the alternative that is available, and why that's going to be something future. A fantastic job. And I'll pass it on to my co-chairperson to comment.
Though evidence-based medicine, the intent was laudable, but somewhere along the line, the whole thing has got corrupted. And the fundamental idiom here was publish or perish. Then came the thing of paid publications. Then the journals came impact. All of these have got commercial implications. So the fourth and last one, most importantly, is suppression of data. So you have to be very careful and shifting the data. In any publication, if you see, first you do two things. One is you read the heading, next the conclusion. Third, you flip to the end of the article and see who the authors are and what is their financial disclosures. Once you have financial disclosures, the article loses its impact.
So how does Professor Basavanagoudappa, the Dean from Mysuru, from the Vadiyar's family, the patron of KRSSDI, is going to counter it? Over to you, sir.
Good afternoon to all. I am very thankful to the organizing committee of KRSDI and scientific chairman for giving me opportunity to fight on a particular issue with my close friend Dr. Virmani. Last year when we had KRSDI, we were sharing a joke, and then over a spirited issues were discussed. He said, I want to fight with you on a particular topic. Last month when we were in Mumbai, he proposed this topic. And he showed the reaction of my picture also. That was true reaction. I was also confused under the spirited influence whether he spoke like that or really he is going to oppose EBM. So next day morning I called him up. Are you sure are you going to oppose EBM? He said, I am very certain. I confirm my participation as an opponent to the evidence-based medicine. Dear friends, my friend Virmani just now confessed for last 3 decades he has been following evidence-based medicine. I'll ask him only 3 questions. 1, is he practicing till today? I visited his website. I saw he is the most popular physician, most popular orator. I want to ask him every drug that he prescribes, with what confidence he prescribes, what dose to be given, at what rate to be given, at what time to be given, how has he got that knowledge? It's all outcome of RCTs, and if you degrade one RCT, pray for systematic meta-analysis. Though you said shift to precision medicine, how do you shift? For that, the basic basement has to be evidence-based medicine. You cannot synthesize precision medicine without evidence. So my good friend, I want to oppose to say this is not the end of the era of evidence-based medicine. It is the beginning of improving the evidence-based medicine. How do you analyze? How do you put it? So for your clarification, I want to redefine what is evidence-based medicine. Friends, greetings from JSS Medical College. My friend Dr. Varmani has mistaken concepts of realities of evidence-based medicine. He is only looking at the lowest level of evidence in the hierarchy of evidence. I want to take you what should be the way you interpret evidence-based medicine. Friends, this is what has made him to get aversion from evidence-based medicine. Okay? With this, he proposed this topic because he has to believe in himself that he is practicing evidence-based medicine, but he is lying today. The real definition of evidence-based medicine is conscientious, explicit, and judicious use of current best evidence. I am not telling you take all evidence that is there in the literature. It is impossible. Can you read 300 papers that come out in a day? You can't. So what is the definition of current best evidence? That has to be looked into. Not every evidence that is there. If you take every evidence that is there, every paper is published, you will never be able to practice medicine. You will be ending up only reading. So best way to practice, translate from bench to bedside is through the critical appraisals, systematic meta-analysis, not single RCT based therapy. I don't want you to use that one RCT which publishes only, suppresses the side effect and promotes and publishes the, I know, publication errors are there. Simple, true outcome of a core component of evidence-based medicine is 1, research evidence of the top quality, not every evidence. 2nd, clinical expertise, eminence. He wants to only shift to eminence, not evidence. 3rd, patient values and preferences are taken. Because this is the era where you make your patient to be a partner with you in decision making. After telling him this is the meta-analysis outcome, I want to treat you, you have to take it. If he can understand that, we have to convince. Dear friends, evidence-based therapy has plenty of domains and opportunities. It is not just looking at one single evidence and based on that I cannot give a prescription for a particular disease. So a lot of things are there. Adaptive strategies from evidence, he wants to take it to precision medicine, AI to be incorporated. How does it happen? There has to be a background basement of evidence to make you evolve the precision medicine. It cannot happen overnight just like that. EBM considers evidence. Traditional does not. EBM demands better evidence than the traditional this thing. So EBM considers the collective evidence, not a single RCT, from various studies to come to a consensus on the utility of a drug or a vaccine or a diagnostic technique or a procedure. It is not just based on you are interpreting one RCT published in one NEJM or Lancet. I am not asking you to believe that. Friends, this is what has happened to Varmaniji. This is a systematic review, the relationship between clinical experience and quality of healthcare. They looked at how, as your duration of experience, so-called eminence, is increasing, if you are not accompanied by updating knowledge on the current systematic review or current critical appraisals, your therapeutic outcome will be bad. So longer you practice, don't think you are getting more experience and eminence. Things are changing every day. We have to keep updated. Because there are so many Google doctors now. Every patient who walks in who has smartphone has access to the very same medical literature that you have access. But they don't have access to systematic reviews or critical appraisals, which you have. We have to use that as evidence, not just based on one RCT published in fantastic journal of NEJM. There is a limited time overall. This is what has happened. Now, this slide will summarize why evidence-based medicine is required today, tomorrow, and forever. Improves the quality and safety as it uses the best available scientific information, not on a single RCT. Enhances the health outcomes as the interventions are based on solid evidences. Reduces the variations in care because standard protocol-driven management is there. He also said we have to use the better algorithm. How does algorithm comes? How does guidelines come? All of them come through the several information that is there as an evidence. And cost effective because you cannot go on doing trial and error. Oh, this is not working, so let me go to the next. How do you fix a precision medicine to an individual? It has to have so informed decision making. Lastly, my dear friend Varmaniji, if you have to talk ethics, if you want to protect yourself from legal pursuits, you have to say I am doing a standard protocol-driven evidence-based medicinal practice. Otherwise, you are ethically and legally questioned. So, my advice to you is please stick on. 3 decades you have been sticking on to evidence-based medicine. Please continue. Improve on that and convince us that how we transform this to this thing. So, this is what has happened. He doesn't have time to read all that evidence. I don't want him to read 5,000 papers in a day, 2,000 medline information per day, 75 clinical trials coming out in a day. That is an enormous thing to do. So don't go on reading all those one NEJM you quoted, another statement you quoted. Please don't do that. You go to systematic review. Time is the factor which is making poor clinicians suffering from information overload. How information is taken, what information is taken as an evidence is up to you. So, the step of evidence-based medicine is ask, acquire, appraise, apply, and assess. Ask a structured question in a patient in front of you. That is what precision medicine. Acquire a relevant evidence, appraise the evidence, apply the findings to the patient care. Generalizability is there in therapeutic algorithm. It doesn't mean it is applicable to a patient in front of you. Then it comes to precision medicine. It is developed over evidence-based medicine. Act involving the patient in the decision-making process. This is the best way to go about. All these are hierarchies in evidence-based medicine. My friend spoke all about the baseline ones, background information, expert opinion, case control studies, cohort studies, RCTs. Even up to that level, it is unfiltered information. So don't base your opinion as a strong evidence to say, this RCT has come out with fantastic result, I would use this drug. Don't believe that because it's unfiltered information. Go to filtered information. The top in the pinnacle of pyramid of evidence-based medicine is systematic reviews, critical appraisals of the topic. I'll take 2 minutes. So I am not going to dwell with all the strengths and weaknesses of all the level of evidence. These are all the strengths and weaknesses. Every component of evidence has its own positives and negatives. RCTs, my friend said, they are true experimental designs, ethically approved for safety and efficacy, can be generalized. But as he rightly said, I agree with him, clinical trials are conducted in a controlled setting. You cannot use pregnant women in the trial, you cannot use elderly beyond particular age, and so on. But that apart, you have to practice ethics with the permission of ethical committee and go ahead. That has to be done. And studies are expensive, time taken, and there can be publication bias. That's why don't believe single RCT and base your treatment as an evidence, taking that. The pinnacle of strength of evidence is systematic reviews, meta-analysis, and critical appraisals. Believe this, they are the pinnacle of evidence. Strength is the process is critically reviewed with the various standard studies, not on a single study, and with a forest plot specially, and hence provide the strongest and the highest quality of evidence. Based on this, you develop your precision medicine. And weaknesses, of course, publication bias could be there, but I agree with you. So if evidence-based medicine was not there, what would have happened? Clinical practice would have been relied upon expert or eminence practice. Significant gap would have been there between the available evidence and clinical practice. Prescription without evidence-based medicine is promoting quackery, promoting Baba Ramdev's pharmacy. And preconceptions and low-quality evidence from individual studies is one. This is what would happen. We keep promising people without evidence that I will cure your diabetes. Cure diabetes, 3 leaves drink a day. Cure diabetes permanently. And Baba Ramdev is waiting for welcoming Varmani because he stopped believing evidence-based medicine, and he won't convince him, I can cure all your diabetic patients, please use my pharma products, which doesn't require evidence. Okay, there is some statement there, diabetes permanent treatment with proof. So all these things will become promoted when you forget evidence-based medicine. My friends, I will not take on, so many evidences are there. One example of thrombolytic therapy. It took decade of time, not just overnight evidence came. First 30 clinical trials with 6,000 patients showed 25% mortality reduction in acute STEMI when they were thrombolized. That was the first attempt. The evidence was not satisfactory, so Varmani did not prescribe that. Then they recruited 40,000 patients. Still, the experts' disagreement was there, but ultimately it took a decade's time before convincing evidence was there when it was generalized. So that is evidence. It is not just overnight prescription, and these are the wrong evidences which are promoted and still practiced against evidence. Okay? So changes in clinical practice should not be like what Varmani said, bright, bursting, lasting for 2 minutes. We want evidence which gives you a sustainable information, soothing information, effective information like this. Friends, EBM means appropriately using the best available evidence to care for patients. Clinical judgment must be used in deciding how to apply the evidence. EBM is not numbers in vacuum. Friends, to summarize, EBM is essential, inevitable requirement in current day practice. Every drug you prescribe has come from evidence and will continue to evolve in helping clinicians. It is an unquestionable entity to keep guiding to the understanding of and understand the scientific basis and predictable outcome of therapies, and that is not the end of the era of evidence-based medicine. EBM, apart from this, helps you, protects you ethically and legally. So, my friend, please stay with EBM and improve on that. You can promote precision medicine. Thank you for agreeing to debate with me. I'm sorry if I have used some harsh words on you. Thank you. He wanted only 30 minutes of enmity with me.
Quick rebuttal, quick. We are already running very late.
Thank you, BG. Before we started practice, before 90, there was no evidence-based medicine there. We learned medicine from our professors who taught us from their clinical experience. We were happy at that time. Now, in 90s, evidence-based medicine came. All of us shifted to evidence-based medicine. And you are mistaken if you think that I am not practicing evidence-based. I never said that. I told you, yes, it is very good, but the time has come for it to retire because something newer is coming. There was a time when we used to drive Ambassador and we used to think that is the only car we have. Then came the Hyundais and the Hondas and now the Mercedes and the Jaguars. So you must learn to change. Change is inevitable, and my dear friend, please become more flexible in life and adapt to change. Thank you.
No, I never said you stop practicing evidence-based medicine, but your opposing evidence-based medicine was my objection, number one. Number two, take my evidence-based medicine, improve your precision-based medicine.
I am not opposing your evidence. I am saying the time has come for a change. Something better is available now. Did you not go for a better car when you were driving the Ambassador of Fear? Why you still driving? Why you not driving Ambassador still?
Thank you for your arguments.
I think if chairpersons are not going to add anything, I must add this, that this is the best way to have the session, and the senior most people debating or rather discussing the way forward. I think this is the greatest eye-opener for all youngsters. Thank you so much for both of you for having enlightened us this way. Beautiful, sir. Beautiful. I think everybody standing tells us all the beauty of this session.
So in this debate, the winners are all the audience.
Yes, absolutely.
Thank you.
Now I request the chairpersons and the speakers to join for a photo moment. I think both Dr. Basungaudappa sir and Dr. Virani has started another trend now. There was a time when debate used to be avoided. No, we don't want a bitter moment, but I think today begins a new era where the seniors need to discuss and debate. We move on to the last session and probably an important session because this is an oration. This oration is dedicated to Dr. Munichudappa C. sir. And we all need not talk about Dr. Munichudappa sir because we know he is one of the first diabetologists of Karnataka. He has been credited to be the first person to introduce the super specialty concept in diabetes care at Karnataka state. He is our Bhishma Pitama of diabetes care, holding medical qualifications from India, Canada, and USA. He has worked on several research projects and published newer findings related to diabetes, held several positions in many professional bodies such as API, IMA, RSSDI, and Diabetes Club. In his honor, Dr. C. Munichudappa Oration has been established. And to present this oration, we have with us Dr. Anil Kumar sir. And to chair this session, I call upon two senior most here, Dr. Sidney D'Souza and Dr. Ravi Kumar Y.S. I request the chairpersons and GC members to honor Dr. Anil Kumar sir. I request the GC members to join on the stage, please. while Dr. Anil Kumar sir is being honored, it is my privilege to read his life story. He is currently the professor and head Department of Diabetes and Endocrinology at Karnataka Institute of Endocrinology and Research, Bangalore. He has more than 35 years of experience in clinical practice. He completed his MBBS in 1987, MD Internal Medicine in 1998. He has completed WHO Fellowship in Diabetology at MV Diabetes Hospital, Chennai, and has been awarded Fellowship by Royal College of Physicians, Edinburgh, UK, Fellowship of Indian College of Physicians, Fellowship of Research Society of Diabetes of India, and he has also received USV RSSDA Award for Best Innovation in Diabetes Care in Challenging Situations in 2021. He has been scope certified in obesity management by World Obesity Federation, and he has been felicitated at 86th All India Kannada Sahitya Sammelana at Haveri. He has also been past chairman RSSDA Karnataka Chapter 2017 and 18, past secretary RSSDA Karnataka Chapter, president for Diabetes Club, and is also the governing council member RSSDI 2008, 2009 and 2011 and 12. He is also scientific committee member of Epicon 2018 Bangalore and National RSSDA 2014. He has delivered presidential oration at KRSSDA 2018 Mysore, delivered Diacon Annual Oration 2020 at Bijapur, and has delivered Dr. Basava Rajavendra Memorial Oration at Manipal, Capicon 2023. He is a co-guide for NIMHANS and ICMR project. He is also the principal investigator for RGHS MODI project. He has 36 original research publications at national and international journals and 11 papers presented at national conferences, delivered more than 160 seminars in national, state, and various CVME programs. So dedicating this talk and delivering Munistudappa oration is Dr. Anil Kumar.
I think you all know about this great man, Dr. C. Munichudappa. I request all the youngsters, young doctors, to come to the hall because I'm speaking on diabetes in young. So they are the ones I think they will manage diabetes in young in future. So I have some interesting studies and interesting cases. As already Dr. Sureka had already explained about the achievements of Dr. Munichudappa. Dr. Munichudappa is the father of diabetology in Karnataka. He was the first diabetologist in Karnataka. And he is known as the Bhishma Pitamaha of diabetology in Karnataka. I think without him, diabetology would not have started so early in Karnataka. So before, of course, when we were probably students, whenever diabetes means, they used to say Dr. Munichudappa. So that we all know. And because of that, so many youngsters are practicing diabetology now in Karnataka and flourishing well. Of course. Now I am talking on precision in clinical care of diabetes in young. Of course, we had a lot of discussion on evidence-based medicine, going to precision medicine. Now I'm talking on precision medicine. Of course, I don't have any bias, no pharmaceutical bias in this talk. So I am happy to present this prestigious Dr. Munichudappa oration. I will try my best to make this oration clinically interesting. I request all the delegates to think as if they are in their diabetic clinic treating young diabetes persons. So I think when I was a secretary, most of the audience, they were complaining that orations were not interesting. So I thought it should be clinically interesting. So I tried my level best to make this clinically interesting. I want to present 4 cases or 4 diabetes, young diabetes patients referred to me in our institute. This patient, age 22 years, BMI 28.5, diabetes duration 1 year, family history positive. She was on regular insulin, of course, basal regular insulin, 30 in the morning, 30 in the afternoon, and premix 30. HbA1c 11%, FPG 292, PPG 447, treated as type 1 diabetes. Of course, when we see a young patient like this, definitely we have to treat as type 1 diabetes. And again, one more patient, aged 15 years, again, family history positive, BMI very low, 15, again treated as type 1 diabetes. HbA1c was 13.8%. And again, this patient, age 20 years, with BMI 19.49 and HbA1c 16.5%, again treated as type 1 diabetes. And this is a female patient, age 27 years, BMI 20, HbA1c 8.5%, again treated as type 1 diabetes. All these patients treated as type 1 diabetes referred to our institute. And now, when we treat or examine diabetes in young, I think we have to address these questions. What's the type of diabetes we are treating? Which type is more aggressive? Whether remission is possible in young diabetics. This is the era of remission. I don't want to use the term reversal. Whether antibody tests to be done in all young diabetics. How to manage diabetes in young. Which are the rare types of diabetes in young? Once diagnosis is made, is there a possibility to change the diagnosis subsequently after 1 year or 2 years? Finally, what is the flow chart for the diagnosis of diabetes in young? So what's the type of diabetes? So to decide about the type of diabetes, you should have the clinical features. Age. Younger the age, more in favor of type 1 diabetes. BMI, leaner, less BMI, more in favor of type 1. Overweight and obesity, again, more in favor of type 2. Family history is positive, more in favor of type 2 diabetes. Negative, more in favor of type 1 diabetes. History of ketoacidosis. If the patient comes with ketoacidosis, I think we have to think type 1 diabetes. Of course, very rarely some patients type 2 also have ketoacidosis. And then fasting and stimulated C-peptide levels, if they are very low, you should say it is type 1 diabetes. If it is on the higher side, it is type 2 diabetes. And antibodies, I think antibodies will not decide about the diagnosis. It will just add on to your diagnosis. And then presence of markers of insulin resistance. If insulin resistance or markers are there, definitely it is type 2 diabetes. And we did a study in our institute, just I think Dr. Sureka is here. So I decided to start this study, and I was discussing with her, and I told her there may be many studies in literature. So when we searched in the literature, we could not get much studies. That is utility of fasting C-peptide levels in the classification of young diabetics between 15 and 35 years. So here we studied 426 subjects with the age of onset between 15 and 35 over a period of 5 years. You can see here, we took 3 points, that is fasting C-peptide less than 0.6 type 1 diabetes, 0.6 to 1.5 type 1 or type 2 diabetes, more than 1.5 type 2 diabetes. By taking these criteria, we analyzed our patients. The results were 15 to 35 years, type 1 was only 2.8%, type 1 or type 2 was 11.5%, and type 2 was 85.7%. But 15 to 20 years, younger the age, type 1 was more, 5.5, and type 1 or type 2 was 28%, and about 67% is type 2. So here, type 1, type 2, and between less than 0.6, more than 1.5, no problem. But between 0.6 to 1.5, again, we have to see the age, BMI, family history, diabetic ketoacidosis, all those things we should see and then decide about whether it is type 1 or type 2. This is the algorithm we have used for the analysis in our study. Which type of diabetes is more aggressive? That also we should remember, because in young, type 1 and early onset type 2 diabetes, which is more aggressive? In this study by Maria et al., they showed that the mortality, especially cardiovascular deaths, are more in early onset type 2 diabetes when compared to type 1 diabetes. And again, in one more study by Healer et al., they studied about 7,844 patients, and they showed that the microalbuminuria or microvascular complications was 2 times more in early onset type 2 when compared to type 1 diabetes. And cardiovascular, especially the myocardial infarction, was 14-fold higher in early onset type 2 diabetes when compared to the usual onset type 2 diabetes. And of course, these are the findings of that study. And we did a study in our institute. So we studied the younger population, and we studied about 373 subjects. Microalbuminuria was present in 23.6% of the patients. So if you can have microalbuminuria detected early, definitely now by using ACE inhibitors, ARB and SGLT2 inhibitors, definitely we can retard the progression of renal damage. And then only 18.4% of the patients had their HbA1c less than 7%. And 55.5% of the patients had HbA1c more than 9%. Now, important thing is glycemic control. Glycemic control is very important. In addition to that, blood pressure control and use of proper drugs like probably now SGLT2 inhibitors, ACE inhibitors, or ARBs can definitely retard the progression of renal damage in these young patients. And then we recently, about a few months back, we had a post-MD fellowship candidate. We did a study, and it showed that prevalence of retinopathy was 21%, nephropathy 22%, and neuropathy 22%, almost equal. So we can remember that 20 to 30% complications in young onset type 2 diabetes patients. Of course, this is one of the studies in Hong Kong. They said the hospitalizations is more in young onset type 2 diabetes when compared to the usual onset. And again, the psychosocial and emotional problems, as we see in our practice, it's definitely more. When a young patient develops diabetes, he comes directly with depression. Why I have developed diabetes at this early age? What is my future? All those things, definitely he will be under severe stress. So the high level of diabetes distress, 24%, depression, 46%, stress also about 41%. Whether remission is possible in young. Now it's, as I said, a patient comes to me with HbA1c 10, 11%. Sir, I want to reverse my diabetes. I don't want to take any medicine. When he comes, first of all, most of our patients, they don't want to take any medicine. And now because of this reversal business, they come and ask us that we don't want to take medicine. 10 and 11% HbA1c, if we don't give medicine, and if this level of HbA1c stays for about 6 months to 1 year, he develops all complications. I have seen one of my patients who is the brother of a doctor. He has not taken medicine for 10 years. Now he comes with proliferative diabetic retinopathy and CKD stage 4. So what to do for these patients? Again, reversal. I don't know when this will end. So if you see here, remission, young diabetics, we have severe insulin deficient diabetes, insulin resistant obese diabetic, combined insulin resistant and deficient diabetes. These are the 3 clusters. Of course, mild age related we cannot take. When we take these 3 clusters, severe insulin deficient we cannot reverse or remit, because severe insulin beta cell dysfunction we cannot reverse. And again, one more, autoimmune also we cannot remit. But insulin resistant and combined insulin resistant, probably some % of the patients may go in for remission, but that we have to see the individual patient and then decide. So that I think it should go to the young minds. I don't know, many young doctors are outside. I don't know whether my message will reach them or not. Whether antibody tests to be done in all young diabetics. So again here some of doctors say, sir, antibodies, GAD antibodies are too costly, all those things. I don't think you require to do antibodies in all our patients. It is mostly for, if you take type 1 diabetes, it will differentiate whether it is an antibody positive type 1 or antibody negative type 1 and research purpose. So you can see the list of cases. Type 1A diabetes, fasting C-peptide was very low. With that only we can decide that it is type 1. And in addition, GAD antibody positivity says that it is type 1A diabetes. And again, 20% of them can have what is known as type 1B or idiopathic. Here also fasting C-peptide is low, but the antibodies, GAD antibodies, were negative. So type 1 diabetes, almost 80% will have antibody positive, but 20% can have antibody negativity also. When it comes to the in-between what is known as the LADA, that is, we call it as type 1.5 diabetes, that also we can diagnose by doing antibody levels. Here to clinically suspect, we should have what is known as the LADA clinical risk score. That is age of onset less than 50 years, presence of acute symptoms of hyperglycemia, BMI less than 25, and personal or family history of autoimmune disease. Either two criteria, more than two criteria if present, then we can subject them for antibodies. If it is positive, we can take it as LADA. So actually we did a study in our institute. So 17 of our patients were positive for antibodies, and all patients had more than two clinical criteria of LADA clinical risk score. And of course, this is the Immunology Diabetes Society, which has given 3 specific criteria for diagnosis of LADA. That is age greater than 30 years, positive autoantibodies to islet beta cells, insulin independence for at least initial 6 months after diagnosis. And one more study, this is actually a RGHS funded study because it's very difficult to do antibodies for 381 patients. They have funded this study. Out of 381 patients, only 29 of the patients were positive for GAD or IA2, out of which only 6 were positive for IA2, 22 were positive for GAD antibodies. That means if you do GAD antibodies in practice, that is more than enough. But doing IA2 antibodies is just for research purposes. And actually, we compared this with several international studies. The famous UKPDS study, which said that 11.6% were antibody positive. Botnia study, 9.3% antibody positive. Another Norway study, 10%. Action LADA Europe study, 9.7. They were all European studies. Usually Europeans have more antibodies because they develop type 1 diabetes, the percentage is more there. And then if you see the Japan, China, UAE, Korea, they all have 3 to 5% of antibodies. And of course, our study showed about 7.61% of antibody positivity. So how to manage diabetes in young? Again, while managing diabetes in young, we have to divide between less than 18 years and more than 18 years. If it is less than 18 years, you can use only metformin and insulin. More than 18 years, metformin, DPP-4, sulfonylurea, SGLT2, and insulin can be used. Recently, if you all know, US FDA has approved empagliflozin in children more than 10 years for usage, but we have to use very carefully in young patients. And this is the algorithm by ADA. If the HbA1c is less than 8.45%, we can use metformin is sufficient. If it is more than 8.5%, we can use metformin and insulin, probably basal insulin or basal bolus, and of course, acute situations by low-dose insulin infusion. And insulin requirement is quite high in type 2 diabetes in youth. About almost 52% of the patients require insulin. What are the rare types of diabetes in young? I think even these rare types we have to remember. It is quite rare, but as a precision medicine when you practice, we have to remember rare cases also. What is monogenic diabetes? Monogenic diabetes, either if you could have a neonatal diabetes or maturity onset diabetes in young, MODY. And MODY actually in 1975 itself, Tattersall and Fajans had made this criteria. And even now it is applicable. We can use this criteria, that is early onset of early onset of diabetes less than 25 years, and early onset of diabetes in at least 2 or 3 successive family members, autosomal dominant mode of inheritance, non-insulin dependence, absence of ketosis and beta cell autoimmunity, usually no obesity or insulin resistance. These factors we can use for diagnosis of MODY. And the US Search for Diabetes in Youth study reported that most MODY cases were misclassified as either type 1 or type 2 diabetes. Of course, this is because of lack of knowledge, and if they don't do genetic analysis, definitely they misclassify. And again, in MODY, they have to remember 4 MODYs, that is enough. That is MODY 3, HNF1 alpha, glucokinase MODY 2, and then HNF4 alpha MODY 1, and HNF1 beta MODY 5. If they remember these 4, I think for clinical diagnosis, it's more than sufficient because they account for more than 90% of MODY cases. And we have up to 14 MODYs. But if you remember 4 and others, you can refer literature whenever you get a result of genetic analysis. So again, just to note, MODY 3 is responsive to sulfonylurea. That is very important because if you are using insulin, you can change it to sulfonylureas. And glucokinase, usually they do not come to the doctor because they have mild persistent fasting hyperglycemia that does not need any treatment. They may not come to you. And HNF4 alpha, that is MODY 1, again, response to sulfonylureas is good, but they have reduced HDL levels. They behave almost like type 2 diabetes. And of course, MODY 5, HNF1 beta. Here, important thing is they are associated with renal cysts, dysplasia, and renal tract malformations, and they are known as renal cysts and diabetes syndrome. And usually they respond to insulin, they don't respond to OHS. And one more, flatbush diabetes. This is also one of the rarer diabetes, ketosis-prone diabetes. Actually, this was diagnosed first in a place called Flatbush in US. Usually they present with very high blood glucose levels, very high with varying degrees of ketosis, and they respond very well to insulin. And afterwards, we have to taper, and then maybe probably you have to stop the insulin, and they respond well to diet and OHS afterwards. And one of the important studies, they have studied 103 ketosis-prone diabetic patients, and they have classified them into 4 groups. I think you all know about this, A minus beta plus, depending upon the antibody positivity, and then the beta cell functional reserve. This A minus beta plus 50%, A plus beta minus 17%, A minus beta minus 22%, A plus beta plus 11%. So the important thing to diagnose this KPD is no precipitating factor for diabetic ketoacidosis. There won't be any precipitating factor like infection. For type 1, you have infection. Here, there won't be any precipitating factor. Early recovery of insulin secretion following treatment with insulin. Insulin dosage reduces progressively, and typically these subtypes may go in for remission. Again, remission here, Babas may come into, they may say we have cured diabetes. And lot of ketosis-prone diabetes have been reported across the world. I think Swaraj is sitting in front of me. So he has published one study with 6 ketosis-prone diabetes from Gulbarga. And again, one more study, Gupta et al. He has also published about 11 ketosis-prone diabetes. I think we should, many of us see such patients. Probably we would not have published. So maybe with a multi-center approach, we can publish studies, ketosis-prone diabetes in, of course, in future. Because if you don't publish, because he has published, I think I can just see these cases. And then FCPD. FCPD, we all know the criteria. It should come for, the patient should be from a tropical country, diabetes should be present, evidence of chronic pancreatitis or calculi, and absence of other causes of chronic pancreatitis, and the most dreaded complication is pancreatic carcinoma. And this is the X-ray of an FCPD patient with calculi, and usually 80% of them require insulin, and others can be managed with diet and OHS. Once diagnosis is made, is there a possibility to change the diagnosis during follow-up in subsequent years? This is true. Actually, this study by Sahu et al., 23% of the patients' diagnosis have been changed after 1 year because they have diagnosed initially as type 1 diabetes, and subsequently when they did C-peptide and other tests, they could change the diagnosis because of the clinical features and investigations. What is the flow chart for diagnosis of diabetes in young? Here, the precision medicine, evidence-based medicine, everything we have to use here. Now, diabetes in young, you should take family history. If family history is positive, Again, go see if it is positive in 3 generations, MODI. If it is positive only in father or mother, it is early onset type 2 diabetes. Family history is negative, ketonuria positive, and very low C-peptide, it is type 1 diabetes. And family history negative, ketonuria negative, and pancreatic calculi, it is FCPD. It's very easy. If you have an algorithm like this, if you are sitting in a clinic, in your diabetic clinic, and if you see the algorithm, you should know all these things and then decide about the diagnosis. Because blindly, we cannot treat them as type 1 diabetes. Now coming back to the 4 cases, what I discussed initially. See, this patient, age 22 years, treated as type 1 diabetes almost for 1.5 years, with HbA1c 11%, 12%, not coming down. Family history was positive. Both parents were positive. BMI is 28.57. Probably it was missed. So she was on this regular insulin and premix. So we did C-peptide, fasting C-peptide, 2.37. So without doubt, we can say it is type 2 diabetes. So then metformin was added, and subsequently even glimepiride. We could get the HbA1c to 6.8%. And of course, insulin was tapered, but low dose we have to continue. So this is actually proper diagnosis was not made. If we had left this patient like that, all lifelong she would have been on insulin without proper control of HbA1c. Of course, this is the reports. And then this patient, again, very interesting, a male 15 years old, diagnosed as type 1, BMI was 15, but family history was again positive. Father was diabetic. And initially when we did C-peptide, actually when the HbA1c was very high, we are not supposed to do C-peptide. But see, when we do C-peptide, if it is very low, even with higher HbA1c, we will get the low C-peptide levels. So initially we did, it was 1.81. And of course, a basal bolus aspart and Traceba was used. After 1 month, its control was very good, 92 FPG, PPG 119. But C-peptide was done because of the glucotoxicity being out. C-peptide was 4.75, stimulated was 5.08. So definitely type 2. It cannot be type 1. Type 1 cannot have such very good C-peptide levels. So again, this patient was treated as type 2. Now he is not on drugs. Glimepiride was given. Now everything was stopped. So all 2 type 1 became type 2. Now this patient, very interesting, 20 years old, but family history, father had diabetes, father's mother had diabetes, then successive generations having early onset type 2 diabetes, we have to think of MODI. And BMI was very, very less, 19.49. C-peptide was almost normal. So when the C-peptide normal with family history positive in successive generations, we have to think of MODI. And this was sent for Dr. Mohan's Diabetes Center for genetic analysis, where we got the result as ABCC8 gene heterozygous mutation, MODI 12, again responsive to sulfonylurea. So his insulin was gradually tapered and stopped, and glimepiride was given, of course, 0.5 mg to start with. With 0.5 mg only, he got very good control from HbA1c, 11 or 12%, it came to 6.4%. So this, again, type 1 has become MODI. And finally, this patient, 27 years, female, family history negative, BMI was 20, and this patient's fasting C-peptide was 0.010. It was negligible. So 100% type 1 diabetes. We cannot say anything. It is like proof diagnosis that fasting C-peptide, when it is very low, we have to take it as type 1 diabetes. And of course, some statistics, 3,370 patients were screened in our center. Type 2 diabetes was 72%, type 1 25%, LADA 0.9, MODI 1, FCPD 1. What we have to remember is FCPD, LADA, MODI only 1%. But in practice, we should remember, when you practice diabetology, you can't say that I don't know about MODI, LADA, or FCPD. Of course, the take-home message, type 2 diabetes in young is rising, differential diagnosis is wide, and remember that early onset type 2 diabetes is quite aggressive. We have to treat them and to prevent complications, not to reverse diabetes. Just reversing diabetes is not our criteria. Preventing complication, I think in the discussion of the debate it was there. We have to prevent complications, that's more important. Unfortunately, the diagnosis of diabetes in young is often delayed because they do not come to the doctors, and doctors also have some negligence or whatever. If they don't have knowledge, they may not give much interest and treat these patients. And timely and accurate diagnosis combined with regular follow-up is very important to maintain their glycemic control to prevent complications. And finally, diabetes in young is under-screened, under-supported, under-treated, and under-reported also. So long live KRSDI, thank you. And maybe I think I have to just show the KER blue lighting on World Diabetes Day. This is the institute where we have done all the studies. And of course, KER, KRSDI both have K in common. And we have KR Narsim Shetty. We have to remember him because for both he was the founder. Without probably, if he had not founded this institute or even KRSDI, all these conferences and treatment for diabetic patients would not have been there. I don't know, probably we are missing him because we lost him maybe 1.5 years back. We are missing him, so we have to remember him. Thank you. Thank you once again for this opportunity. I think Dr. Ravi Kumar and Dr. Sidney sir both are research-oriented people because as we know, they are very interested in research, and whenever I raise anything about research, they will help and they will coordinate. Thank you, sir.
Dr. Anil Kumar really deserves one more applause.
Thank you.
And he has given respect to his mentor, Dr. Narsim Shetty. I think we are missing him today, but whatever, right from day one, he has been mentoring Dr. Anil, and today he is standing in front of us, giving a oration of Dr. Munichudappa is the greatest testimony to say how nicely it's brought up. And his today research on young diabetes, his own data it is. It's not somebody else's data which is borrowed from others. Just says how keeping the data in a correct, proper way helps you to produce papers, and beautiful papers. I compliment you for all these things.
Thank
you have
you.
done extremely well.
Thank
And
you.
probably you have been mentoring most of the students now in Karnataka
No,
Institute of Endocrinology.
as you said, if they do research, they will get a lot of knowledge.
Exactly.
If they don't do the research or they have to see patients. They should not sit in the library and keep on reading. Seeing patients, clinical medicine is very important, and of course, evidence-based medicine is also important. Both these things can go into precision medicine. Without that, probably we cannot. Clinical evidence going into precision medicine.
That precision medicine has really gone deep into everybody's mind today. And as it is an oration, there are no questions. One or two comments from Dr. Ravi.
It was a wonderful oration. Yeah. Thank you, Dr. Anil Kumar. Thank you.
Thank you. Thank you.
Thank you, sir. We close the session here, but I would request Dr. Anil Kumar, sir, and
Anil has done a wonderful oration and wonderful work done, and original data presented as a part of oration is appreciated. I agree with you, remembering Narsim Shetty because of his contribution to finding KRSDI and your institution. Both he is responsible, and I thank the organizers for naming one symposium in his name. The moment it was suggested, it was corrected and done. Thank you so much, Manohar, and entire scientific committee also for recognizing Narsim Shetty and naming a symposium in his name. Thank you so much. Well done, Anil Kumar.
thank you so much, sir. As we end this session, I would request Dr. Manohar to make an important announcement.
It has been wonderful throughout. Quite a lot of audience. I know it is a lunch break. People are in the dining area. Most important announcement to all KRSDI members. We will have AGM sharp 2:30, Hall B, ground floor.
kindly attend, kindly participate. It is our KRSSDI. More people to participate, more people to guide us and give us information. Remember, it is only for the KRSSDI members, not just the GC members, all the members. We request you to assemble exactly 2:30, Hall B, which is the Nandi Hall, ground floor. Thank you.
Yeah, arrangement ಗೆಸ್ ಸರ್. Yes, yes. ಸರ್ ನಿಮ್ಗೆ ಆಯ್ತಾ? ನೀವು ಬೇಗ ಬನ್ನಿ. ಸರ್ ನೀವು ಕ್ವಿಜ್ಗೆ ಹೋಗ್ತೀರಾ AGMಗೆ ಹೋಗ್ತೀರಾ? ಹೋಗ್ಬೇಕು. Okay. Thank you so much. I think everybody is hungry and want to have a lunch, but we have one more interesting session, which is a postgraduate final quiz. And I'm sure all the postgraduates are ready. I hope you all had your lunch. And to encourage them, motivate them, I request all the delegates to quickly finish your lunch and come back to the hall, please. These youngsters are our future, and they will need rounds of applause. And all the postgraduates who are the finalists, I request them to come forward and be seated. Yes. Chairs ಹಾಕ್ತಾರೆ sir, ಹಾಕ್ತಾರೆ. And just to make the list of finalists, it is Dr. Deepak and Dr. Amen from MMC, Dr. Surjit and Dr. Venkatramana from JSS, Dr. Praveen and Kushal from Vaidehi College, Dr. Vinduja and Gayatri from Sakra Hospital, Dr. Preeti and Dr. Kripa from JSS Medical College. We have 10 minutes time to arrange the hall. Before that, the postgraduates kindly make your way into the hall. All the delegates in the dining hall, if you can hear me, please have your lunch quickly and proceed to Hall A for the postgraduate finals. Are the finalists for the postgraduate quiz here? Please raise your hands. All the 5 teams? Okay, let me just call out your names. You guys can come forward, please. Dr. Deepak and Dr. Amen from MMC, Dr. Surjit and Dr. Venkatramana from JSS. I'll need you here so that we can write down your names also correctly. Dr. Praveen and Dr. Kushal from Vaidehi, Dr. Vinduja and Gayatri from Sakra, Dr. Preeti and Dr. Kripa from JSS. All the students, where are your friends? Nobody to cheer you, nobody to motivate you, and nobody to prompt answers. I don't see anybody. I hope you're all getting the adrenal rush. This is a quiz, and the questions will be asked faster. You have to think faster and answer faster. So be ready for the adrenal rush for the next 1 hour, okay? So the last question by me, where is the Josh? Where is the Josh, guys? All of you are tensed.
They are visible. Everybody is visible. Should do skipping.
teams will go in this order. 1, 2, 3, 4.
ಬನ್ನಿ ಸರ್, ವಿಶ್ವನಾಥ್ ಸರ್ ಬನ್ನಿ. ಇದು ಆನಲ್ಲಿ ಇದೆಯಾ?
Good afternoon, everyone. Good afternoon, everyone. As we culminate this program, we are going to end with an interesting session, which is state-level inter-college postgraduate diabetes quiz. And we have been having this for the last 2 days. Yesterday's was preliminaries. And now we have the time for the final session. Here we are, Dr. Vishwanath, who will be your quiz master, Dr. Hem, who will keep the score, and me, Dr. Sureka, who will be the coordinator for this quiz. All the best to all of you. Enjoy the session. Be relaxed, think, and answer. May the best team win.
Okay. So, good afternoon all. I think as Madam has already introduced, we'll be starting the quiz. So, it will, team 1, 2, 3, 4, 5, that's how it will go. Okay. And each round I will be explaining to you the rules, how we are going to, probably about 6 to 7 rounds, one round depending on the time, whether we are allowed by Dr. Manohar, I will go through that. Okay. So fairly simple, straightforward questions, most of them. Probably to just think a bit and answer. At the outset, I thank Dr. Manohar and the whole KRSDA team for giving me this opportunity. And special thanks to Dr. Hem Kumar and Dr. Sureka Shetty ma'am, probably helped me a lot in all these questions and also coordinating this whole thing. So let me begin the quiz. So what are these? First question. It's all your team names. Huh? Hampi, Badami, Vijaypura or Mysore. Okay. Anyway, just joking. So, of course, in front of my teachers when I do, sir is there and Dr. Ravi Kumar, they're all our inspiration. I think first we should, get inspired from teachers and probably next we can go ahead with any program. Anyway, so first round, a warm-up. Simple one. I'll start with your team. So it is There is a MCQ type pattern. I'll go back again 1 to 5 and again 5 to 1. So 2 questions each you will get. First question to Humpty. Pick the wrong combination depending on peak of action and duration of action. It's not the onset, I'm giving you a clue. Peak of action and duration of action. So you'll get 30 seconds.
Option A.
Option?
A.
Option A. No, it's a wrong answer. It's, if you see the rapid regular, it is not 10 minutes to 1 hour or 8 to 10 hours. Okay, it's just 3 to 4 hours. Anyway, the answer was option B. Okay, anyway. Next question to Team Badami. The true statement about classification of hypoglycemia as per the recent ADA is, you call it as level 1 hypoglycemia when it is between 54 to 70. Level 2 if it is less than 54. Or level 3, you know, it's severe where there is altered mental status. Or all these correct? Which one is the correct? So basically, sorry? Option? D, all of the above, yes, correct. That is a straight pick from the ADA where 54 to 70, less than 54, and grade 3 is, they get 5 marks. Team Belur, of all the drugs which have been studied, this stands out among the rest of having a clear demonstrable CVD benefits, whether it is SGLT2 inhibitor, GLP-1 agonist, or both A and B, or only saxagliptin.
SGLT2 inhibitors.
SGLT2 inhibitors is correct, but the answer is both A and B, because even GLP-1 agonists have demonstrated very clear demonstrable CVD effect. So they don't get points. So answer is both A and B. Okay. Next, Mysore. A newly diagnosed type 2 diabetes patient asks for clarification about dietary management. Which of the following is most suitable when you talk to them? Stop carbohydrates, eat only high protein and high fat diet. Avoid sucrose completely. Your calories should be less than 10% of calorie intake should be less saturated fat, or caloric intake should be very consistent from day 1 to another.
Option C.
Option?
C.
C. Yes, that's the right answer. So it cannot be a consistent from day 1 onwards because it depends on the weight loss and how we are going to progress further. You cannot stop carbohydrates, not the main source. And of course, avoiding sucrose completely is not possible. Okay, option C is the right answer. So which of the following outcomes are not associated with semaglutide therapy? Reduced HbA1c level, reduced risk of major adverse cardiovascular events, improved diabetic retinopathy, and none of the above. Is not associated with semaglutide. Semaglutide is something which is coming up a lot, so I thought just put a question on that. Yeah, you can just tell its time is over.
B, reduced risk of MIS.
B? B. No, that's not the right answer. The semaglutide therapy showed a good reduction in all these, but there was worsening of diabetic. So that was the thing about semaglutide. Cholesterol, it had very good reduction, but somehow C, that's a wrong answer. Anyway, now we will again come back from your side only, same, the next question. So 30 seconds will start from the time I start asking questions. Okay. So in the DCCT trial, it provided a definitive proof in the reduction of chronic hyperglycemia. So which among these is correct for the DCCT trial? So whether it reduced the microvascular in type 1, microvascular in type 1 and type 2, it's only DCCT, not DCCT addict, I'm giving you a clue. Reduced microvascular in type 2, reduced macrovascular in type 2. ನಿಮ್ಗೆ ಹೇಳ್ಬೇಕಾ?
Reduces microvascular complication with type 1 and type 2.
This I'm telling you, it's not DCCT addict, DCCT trial per se on type 1 microvascular complications. Anyway, wrong answer, they did not get point. So that's why I gave you a clue. Next, Team Mysore. Time starts. Which of the following HLA types have been commonly associated with type 1 diabetes? Commonly. Of course, HLAs have a wide variety of presentation, may not be accurate, but more common.
A.
HLA DR3. Yes, that's the right answer. They get 5 marks. So DR3 is supposed to be associated with type 1 diabetes. Next. When you do an ABA in a metabolic syndrome or a diabetic patient, you give certain values. You say it is severe, moderate, mild. When do you say the value as moderate? Answer is C. That's correct. 0.4 to 0.69 or 0.5 to 0.7. When the value of that is considered as moderate. That's the right answer. Good. Take it. Team Badami. A typical total water deficits in DKA in liters. Of course, extreme conditions, that's okay, but a typical case, what you say is the deficit. Sorry. Option C. That's the right answer. 5 to 7 liters or 5 to 6 liters is considered as the typical total deficits. They get points. Last question. All of the following statements regarding hypoglycemia and diabetes are true, except individuals with type 2 experience less hypoglycemia than those of type 1. From 2 to 4% of the deaths in type 1 diabetes are directly attributed to hypoglycemia. The average person with type 1 diabetes can have up to 2 episodes of symptomatic hypoglycemia weekly can have. Fourth, thiazolidines as a drug cause hypoglycemia more frequently than sulfonylureas. So, which is the choice? So, all are true except. Time is running out, you can answer.
Answer A.
Option? A. No. Thiazolidines, wrong. Thiazolidines cause hypoglycemia more frequently, less frequently than sulfonylureas. So that is the right answer. Except. So that brings us to the end of round 1, fairly MCQ type. We will move on to the next round again, another simple round. We'll start with team 1. So fill in the blanks. I'll just give certain statements where you have to tell the answers. Okay. So 10 marks for the correct answer. Yeah. The enzyme DASH is responsible for overloading of acetyl-CoA in a patient of diabetic ketoacidosis.
CPT2.
Okay. I'll still give it to you, CPT1 and 2. That is, CPT is the enzyme which causes overloading of acetyl-CoA. I think, sir, I'll give marks to them. 10 marks. That's right. Okay. Next question. Read it properly. The dash of food is the number of estimate how much the food will raise. You read the question. Person's glucose after eating it. 1 unit of it approximates the effect of consuming 1 gram of glucose. Read it again and answer. Glycemic? X, no. That's why I said. This is the last part. 1 unit of approximates the effect of consuming 1 gram of glucose is glycemic load. That's why I told you many times, you read the question. Glycemic index is different. This is the glycemic load of a particular drug. Okay, anyway. They don't. Next, team G. Can answer the first one, that should be enough. most studies recommend in a monofilament test when you do a 10 gram monofits, at how many sites? I think the next one is fairly okay. So when you do a monofilament test in diabetic neuropathy patient, how many sites you have to test? In your 10 gram monofilament test, most of the diabetics, we tell postgraduates to do a neuropathy test. How many sites do you check? You can answer the question.
12 sites and 3 sites.
10 sites, 9 plus 1. So 9 dots. Totally it is 10 sites. 10 sites you check. And 3 times at even one site, if it is soon, so they don't get the marks. So next question. This class of drug induce their activity through glucose-dependent stimulation of insulin secretion, inhibition of glucagon secretion, slowing of gastric emptying, and reduction in appetite.
GLP-1 receptor agonist.
GLP-1 agonist, very good, that's the right answer. So they have all these 4 set of actions, yes. Pioglitazone selectively stimulates the nuclear receptor dash to a lesser extent PPR alpha, but it's more selective to which of the nuclear receptor when it acts? Time is, you answer. Yeah, you answer. It's okay, no negative. Okay. Next round there is negative. Yeah. Sorry? No, PPR gamma. So it is the right answer. Anyway, so we'll go to this will be the end of round 2. We'll announce the score next, yeah. We'll go to round 3. Before that, I thought, anyway, time is lacking, so I'll just go through this. So you will get a picture, and of course related to diabetes, some illustration. You have to tell what that illustration means to you. How do you understand that illustration? Yeah? I'll. So here, 10 points if you answer it right, minus 5 if it is wrong. Okay, so that there is some sort of a this thing. So team Humpy, what is this I am showing? Of course, with respect to diabetes. Probably if you had heard Dr. Anil Kumar's lecture, you would have got this. You have to answer. If it is wrong, minus 5. Sorry? Huh? No. What does this illustration represent?
It is like autoimmune destruction of islet cell. It is showing like that.
Autoimmune destruction of islet cells. I think we can give still is the immunopathogenesis of type 1 diabetes where there is destruction. I think, sir, we can give. So 10 marks, good. That's the right answer. Team Badam. Pathophysiology of? No, diabetic foot, you should be more specific. What is this exactly it shows? You have an X-ray, you have a plantar pressure graph, you have an X-ray. Diabetic foot is a very broad terminology. I want its specific answer. Flat foot is not the right answer, wrong answer. Fortunately, minus 5. What is one of the dreaded complication? Charcot's arthroneuropathy, isn't it? So that was type 3. Anyway, Charcot's I would have given you, but it's not flat foot definitely. Okay. team 3, Vellore. So you have the cardia, the kidneys, the vascular, the brain. -5 if you get it wrong. Yeah, you can tell the answer if you're telling. Fast.
Pathogenesis of SGLT2 inhibitors.
Not pathogenesis.
Mechanism.
You have to tell
the way it
mechanism of
helps.
action. I think I shall give it to you. That's the right answer. So it is mechanism of SGLT2 and how it protects the cardia. I think they get points. Very good. Next. All with respect to diabetes.
Diabetic vasculopathy.
Diabetic?
Vasculopathy.
Vasculopathy, you can be more specific? Yes, of course. I think it's definitely not cut
Macrovascular
points.
complication of diabetes.
Okay, so the arterial wall in diabetes, how it is going to cause atherosclerosis, I think can give points. That's fair enough. Okay, so that's how the various things act. The last team. So you see the clue is there are some plus, some minus. So that means somewhere it is acting more, somewhere it is inhibiting. So that you have to keenly see. Plus, minus, plus, minus. So just observe those and try to get an idea. The liver, the gut, the muscles, at the fat, so there is something being stimulated plus something being inhibited. Action of? Yes, I think that's the review. So major metabolic pathways of metabolism of insulin. So I think they can get points. That's the right answer. Okay. So this is the end of round 3.
So
all of you finished now? Yeah.
At the end of round 3, team Hampi has scored 20, Badami has scored 5, Belur has scored 15, Mysore has scored 30, and Vijayapura has scored 10.
So I'll skip all this. Yeah. Next is round 4. So here again, it's a straightforward yes or no answers. We'll start with team 1 again, go back 5 to 1. Okay. So first, team Hampi. So here we have introduced negative. So if you tell the right answer, it is, no, don't see that, probably we had a discussion now. 5 points for the correct answer, -3 for the wrong answer. -3, remember that, 5 -3, correct? Yeah, okay. So first question, you have to tell whether it's true or false. Aspirin therapy should be used as a primary preventive strategies in all diabetics, and even if there is no history of ASCVD, true or false? As a primary prophylaxis should be started, whether it is true or false. In a dose of say 75 to 150.
False.
False, of course. It's not compulsory that you have to start with all the primary prophylaxis. Yes, next. They get 5. Given that ADA recommends weight loss for a disease-modifying effect, a dual GLP-1 receptor agonist has been approved. as a glucose lowering agent with even a potential for weight loss. The drug I'm talking about is tirzepatide.
True.
Is it correct or not?
True.
Sorry?
Correct.
Oh, you're an answer. Okay, correct, true. I wanted to go to the next. It's okay. Now I will start with two each. Yeah, both they're right. Next question to you. Among the patients with ASCVD at higher risk of heart failure or in whom heart failure coexists, SGLT2 inhibitors must be used. Sorry? True. So it's slightly difficult. So it's not that it must be used. It forms one of the pillars of therapy, I do agree, in heart failure, but it is not must still. Okay, so it is a wrong answer. Next, you only answer. New onset of atypical diabetes in a middle-aged or older patient may precede the diagnosis of pancreatic adenocarcinoma. Hence, even in the absence of other symptoms, routine screening of all such patients is currently recommended. So, screening for such, when this set of diabetics comes, so you should compulsory screen for pancreatic adenocarcinoma. So, routine screening. Routine screening is not recommended. That's the correct answer. So they get 5 points. 2 questions over for you. Yes. Next. For people with non-dialysis dependent CKD, dietary protein intake should be approximately 0.8 gram per kg per day. Whether this value is correct or not, that you have to, so based on that, yes or no. True. Yes, it's 0.8 gram per kg body weight. That's the correct answer. Next, for you only, we have to optimize the blood pressure and serum lipid control to reduce the risk or slower progression of diabetic retinopathy. So whether it is necessary to control the lipids and blood pressure apart from good sugar control to reduce the progression of diabetic retinopathy. It's true. You have to control for -3. Yes. Next question. Patients with diabetes should be encouraged to undergo recommended age and sex appropriate cancer screening to reduce their modifiable cancer risk factors. So, do you want to recommend, it's not must, I'm telling, can you recommend cancer screening? And to reduce their modifiable risk factors.
True.
Okay. So they get the point. So it is not must, but you can recommend. Times 2 trial was regarding testosterone replacement in type 2 diabetes. Anyway, they don't, it's not testosterone replacement therapy. Last question. In the ACCORD trial, they said it was specifically designed to see whether reduction of glycated hemoglobin will reduce the rate of cardiovascular events. The ACCORD trial. What was it for? That's the main thing. True. So -3 for them. Last question for you. Glipizide as a drug does not require dose modification in renal failure. True, it does not require. Anyway, so -3 again, so they didn't get. So I think that's the end of round 4. Scores.
So at the end of
So how much time do I have?
round 4,
Still.
Hampi has scored 30, Badami 7, Belur 17,
Sir?
Mysore 32, and Vijaypura 4.
Well, 3, I have 2 more rounds. Sorry? Huh? Second one they didn't answer. Okay. So round 5, I'll finish this. It is faster, and then we'll go to the last round because, of course, time is not there. So just sort of not quite different from normal boring lipid drugs. So here you have a picture or a statement given by some scientist. Yeah. So if they get in the first time, it is 10 marks. If they answer the second clue, 5 marks. I'll tell. 30 seconds. Because so we'll start with them. 5th team, team 5. Okay. So who said this? If you tell this, 10 marks. Just slightly different from the routine drug, so I thought one round I will push like this. Okay, you want the second clue? No, I think you should identify this great person. Identify. So as physicians, all of us should know about him, read about him. Okay. Okay. Anyway, one of the greatest physicians, probably all of us. Next. What am I talking about? Taylor or Tom Hawk, the Queen Square. The other types include Buck, Berliner or Stuckey. Next clue. Used extensively in central nervous system examination. One of the variety was designed by Joseph Babinski in 1912.
Knee hammer.
Yeah, so we were talking of the knee hammer. First, it was all, these are the different types of knee hammer which I showed. I think they will get 5 points. Yes. So I can give you a clue for this. 2019, not the present one. Even I don't want to, if you tell the, don't tell the names also, I don't mind. But what was this, why this became famous probably 3-4 years back, used extensively now in all
Autophagy.
Huh?
Autophagy.
Autophagy, yeah. Can you go a bit more?
Sir, it won the Nobel Prize in
Yes, very good.
2019.
So this was, these were the 3 gentlemen.
scientists.
Of course, if you are not able to recognize. So basically it's on the hypoxia and that was, I think I can give them 5 points. So these were the 3 people, wonderful people who just paved for the all the whatever therapies, cancer therapies we are going through. Next question. So Dr. MacLeod, he was a son of minister, received a request from a person to do research in his lab. And he was so unimpressed with him, but probably being skeptical, he still gave him a lab space to do his work, and also for dogs for 2 months at the end of his academic year. Rest, they say, is history. So Dr. MacLeod got a request from a particular person to do some research. He was, I just abridged this, he was totally reluctant, but still he has given later. Huh? Sorry? No, who is that person I want? Identify now, yeah. So, Dr. Frederick Banting. So, he was the first person to apply for a, that's it. Yeah. Their field experiments, this is also with regard to Nobel Prize, but they are not from the field of health. They received Nobel Prize, he's an Indian, I'll give you a clue, for economics. But this is something he had done, what is called this micromanagement, where he distributed these free deworming tablets and reduce the burden of health economics. So they, he somehow helped the health economy, that's what they say. Can you identify? Probably next clue I think will be easier. Name one of them, I'll give you. Two people. Of course, he's an Indian, not Indian per se, but Indian origin.
Narayan Murthy, someone, no.
Economics Nobel. So Abhijit Banerjee, isn't it? So he was the one who got Nobel in economics, but his work has helped, a lot in health related. Of course, wife is Duflo, she's a French. So this will be the last round. So solve the queries. Okay, we'll start with your team. So patient comes to you with this sticker in his hand. Nowadays, they are all quite this one. Ask him or ask you how to do a carb count. So what is the carb count here? Now, of course, many senior diabetologists are there. I don't know whether they will accept the carb count, but still questions are asked in the OPD, whether we like or not. These are the things they will ask. Scientifically, how much is it helpful? We don't know. No idea? Okay. So generally, when you are doing a carb count, take the total carbohydrate in that and subtract the fibers. That will give you the carb count. Anyway, they didn't answer. So next question. Team Mysuru. So you always tell a patient, eat food less in potassium. Okay. So now he brings you this soup, ask whether I can take this or not. So how do you suggest when they look at the food packet, what should be the potassium level? Now, for example, he has got you this. So he's asking, you have asked me to cut down on potassium, can I take this or not? What do you mean by the low potassium diet when you say? Okay, time is up. So generally you say that as low when your whatever is there, that food containing less than 250 mg. So if it is more than for that concentration, it has to be avoided or eaten in very small portions. That's how when they ask you whether this particular food can be taken, you have to mention. So generally again you say less salt. Less salt, how much salt can I eat? And most professional societies suggest that sodium intake should be less than 2.3 grams per day. How will you tell this patient? How will you explain the patient what is the amount of salt he can take? So this 2.3 grams of sodium is what recommended. So what will you tell the patient to take? How much less salt he should take? General advice. It's not specific.
We can tell them to. Sir,
what will be the quantity you will tell? Salt, generally. That should be less than that particular salt. The best advice is not to add any extra salt that you can give. But if you give a specific advice, how will you give?
2 pinches.
No, how much does it come to? Approximately. So approximately it comes to around 6 grams of, that's how you can explain to the patient, they don't get it. Yeah, next.
So you prescribe lifestyle modification for some. So what is the minimum recommended amount of weekly target exercise? You would tell them. Spread over at least dash for diabetics as per the guidelines. So you have to, there are two answers here. You are going to give them a weekly target. This is what you have to do exercise of moderate to severe intensity. I am giving you a clue. And spread over at least how many days? Spread over?
5 days. 5 days.
At least. No, you be clear. You take the mic and tell. First one. What is the recommended weekly? 150 minutes, I agree. Okay, I give you. Spread over? 3 days. Okay, so that is what you have to recommend. The total recommendation is, unless you are as fit as him, I don't know where he is. So 150 minutes per week of moderate intensity exercise, at least spread over 3 days. So that's how you should be taken. So last question. So you have a lot of obesity pharmacotherapy. They come to you, whether I fit in or not, first you have to tell. And at what BMI level do you start considering it? One question. And second, once you start, when do you say it is responding? That means you want to continue or change, or depends upon that. So obesity pharmacotherapy. At what level you would like to consider? Second, when do you consider that as responding?
(28 to 30 BMI will start with.
How much? What is the BMI?
28 to 30.
Be specific. Like
30.
There is a cutoff, means standard as per the guidelines. Of course, you can change a bit here and there. As per the guidelines, what is the cutoff?
30 is the BMI for
So
medical.
no. When do you consider it as responding? The second part you can answer, I'll give you 5 points.
5 to 10% weight loss over 2 to 3 months will consider as significant.
I think 5 points we can give. So it is typically, they say, responding as 5% of weight loss over 3 months. 5 points can be given, but the cutoff is 27. It's not, of course, this is a guideline. You can 28 also, 26. There are other conditions considered. So thank you very much. Lack of time, just rushing through. So I request Dr. Hem and Dr. Surek to come.
We'll announce it during the valedictory function. We have to cross-verify and announce during the valedictory function. Photograph session, press giving, and the announcement.
Winner ಹೇಳ್ಬಿಡಿ 3 ಜನ 3 ಟೀಮ್ ಪ್ರೈಸ್ ಕೊಡೋಣ ಅದೊಂಥರ ಇಂಟ್ರೆಸ್ಟ್ ತಗೋತೀವಿ.
ಓಕೆ
4 ಜನ ಇರೋದು ಪ್ರೈಸ್ ವ್ಯಾಲಿಡಿಟಿ ಕೊಡಿ, ವಿನ್ನರ್ಸ್ ಹೇಳ್ಬಿಡಿ ಅಂದೆ. I request Dr. Hem Kumar and Dr. Sureka Madam to please come and announce the winners.
So the winner of the quiz is from JSS Medical College. The Mysuru team, Dr. Sujit Chunduri and Dr. Venkatramana Rao. Congratulations. And the runner-up is Dr. Kushal Achyut, Dr. Praveen Kumar from Hampi team They are from Vaidehi Medical College. And congratulations for the winners and runner-up. And the photograph, group photo participation certificates and the winner and trophy giving will be done during the valedictory ceremony. Okay? Yeah.
Well, congratulations to the winners and appreciation for all the participants of the quiz. I need to see little more smile on your faces. I see that all the participants are very serious and very stressed. Well, this was just to motivate your interest in diabetology and to stimulate your gray cells. I hope, yes, possibly that may be true. Having the HOD behind is making them little more. So keep participating, keep learning, and enjoy your journey of knowledge. Congratulations once again, and please wait for the valedictory function for the prize distribution. And at this, I would like to thank Dr. Vishwanath and Dr. Haim for coordinating and conducting the final quiz so well. Thank you, both of you. And now I hand over the stage to Dr. Vijay Kumar.
Yeah. Thank you everyone for participating the whole day, sitting here and finishing these events. Well, we'll be having the valedictory function in a while. Once we have a annual general body meeting. Once we finish that, we'll have this valedictory function. And giving away the prizes and certificates will be done during that time. We'll just take a break now and come back now. We'll call you back. ಹೌದು. Yeah. Hello everyone. For convenience, we are shifting valedictory quickly so that those people who take award and who are not members can leave the hall and then we can continue the AGM. I hope it is okay with everyone. Okay, Ndelapa. So I would request our office bearers to be on the stage. Suman Ba. Some of the office bearers and organizing committee in charges to be on the stage. Ravi Kumar, sir. Him. Oral poster. Shekhar, come on the stage. Sir, banne. So, at the end of it, it is a Thanksgiving occasion. Here, I think we used to give opportunity for one of the delegates, one of the pharma person, one of the speakers or chairpersons to share their views. If someone is interested in talking about the conference, how it was, what are the deficiencies, where do we correct them, you are welcome to come onto the stage and have a word. Karthik. So any takers for feedback from the delegate side, from the student side, from the pharma side? So if nobody is volunteering, okay, we have one volunteer. It will give me some time to think what to do next.
Good evening, everybody. At the outset, I'm first of all congratulates Krssdi 2023. They have done excellent program. Scientific session was all are excellent, and food was very good. And they have taken a lot of pain to conduct this 2023, and all the office bearers of Krssdi, they have done wonderful event, wonderful conference, and also I am surprised. I got the award. They didn't tell me. I'm thankful to all the office bearers giving me that award. And also, yesterday banquet was also excellent. All the things went on smooth. Everybody is They have taken good scientific session. Thank you one and all.
Yeah, we are appreciable to Dr. Basavaraj Patil. He always be there in the last and definitely gives a good comments to us. Thank you, Dr. Basavaraj. Also, we have another person who wants to give a feedback about the conference. So, one of the students, please come.
Good afternoon, everyone. I'm Srijan Soni. I'm a postgraduate medical student from JSS Medical College, and just want to thank you, the organizing committee, for such an eye-opening and enlightening conference, especially for us postgraduates. It's really a wealth of knowledge on display here. And I just wanted to ask one question, especially from BG sir, regarding the debate. It falls slightly away from the realm of the topic of the debate, but I was genuinely interested in knowing something such as the opioid crisis in America, which was fueled not only by falsified data by Purdue Pharma, but also with the help of bribery to doctors. And it brought down the whole country to their knees. And the problem is, even at the individual level, when patients were being prescribed opioids for mild to moderate chronic pain, there were good results, and that sort of prompted the doctors to keep on prescribing. And today we know what the situation is. So I just wanted to know what we can do, what lessons we can take from it as a country, and what we can do to prevent such a thing happening in India.
What is your suggestion? What do you think can be done to prevent?
Of course, what you said, sir, about meta-analysis and systematic review.
So, building your impression based on one RCT, which is showing a fantastic result, is wrong. There should be solid evidence, means it should be a critical appraisal of a particular entity or meta-analysis or Cochrane review. Such kind of things will take every study into account, pluses and minuses of that, and those kind of data are the one which should be emphatically taken to impose or create guidelines. Based on one HOPE trial, what kind of recommendation came. And UKPDS gave rebirth to metformin, and that remained as a first-line drug in the therapeutic algorithm. So those kind of solid evidence should be there. Otherwise, these kind of crises will happen. So they should have a very, very cautious approach in especially those areas of opioid usage and prescription. But also keeping in mind the utility point in pain management, terminal illness management, those kind of things, it is emphatically required. But it should not be allowed to be misused. So the structured regulation should be such that it should be stringent to not allow misuse.
And sir, what would be your suggestion to sort of reduce the impact of the pharmaceutical industry on doctors and...
Again, biased outcomes should be viewed. Again, if you pray for critical appraisal, this will not happen. If you go based on one large-scale trial, however good is the study design, that will get into trouble. That will prevent a snub down, a single pharma-driven research to be implemented as a guideline promoter.
Thank you, sir.
This intensity of science in this conference is so much that even in valedictory, we are clearing. And I think that calls for appreciation.
Very, very critical questions, and thank you for thinking about. So I have done my job of igniting some mind in debate.
Sydney, sir.
Yeah, I see all the black hair in the dais. No gray hair there.
Some of them are modified.
And what I wish to tell them is the youngsters, the enthusiasm in them has taken KRSSD to a greater height. I've been seeing this right from the inception till today. Today, when I looked at the audience, all the time this venue was full. Hall A plus Hall B. In fact, Hall B was more crowded than Hall A. That was something which tells that there is some science going on in this. So this is what our KRSSD was meant for, and these people have taken it to a greater height. The next part will be involving more and more people within Karnataka to be in the speaker's desk. Not too many from outside. You have one or two, it's okay. But give a chance for these people to start. Including a good postgraduate, if we can deliver something. that would be a much better thing. And it was not extravagant, it was just nice. I think they are going in a proper direction, not much of restriction from the seniors. I think let alone and let them free. I think they have done very well. I congratulate all of them under able leadership of Manohar and his team members. All the best to you. Thank you.
Thank you.
Not forgetting Sureka, who was anchoring here right from day one morning till even now. Very good. Congratulations.
She deserves a special appreciation. Thank you, Sydney, for encouraging the young team, excluding the grey hair.
Including you. Including you. Thank you, Sydney, sir, for your kind words. Now, I think we should be moving on to giving away the awards. To start with the oral presentation, I think we have given the award yesterday. So I'll be, the participants will all be getting the certificates, e-certificates. We'll give you a number, they can contact if any other information is required. Coming to the poster presentation, we'll be giving away one prize, the best poster. Best poster goes to the topic correlation of SpO2 measurement by pulse oximetry with arterial blood gas analysis in patients with uncontrolled type 2 diabetes and oxygen therapy or mechanical ventilation. Poster by Dr. Tanmay Kulkarni. JSS Medical College, Mysore.
There was no match fixing, there was no bias. It was a true evidence on which he has been evaluated.
Maybe it would have been better I didn't announce the college. Rest of the participants will be getting their...
One more.
Rest of the participants will be getting their certificates. Certificates are all e-certificates. Any physical certificates required, please mail us. We'll send you by courier. Now coming to the case reports. The best case is insulin autoimmune syndrome, presented by Gautami V. Kohir from Mahadevappa Rampur Medical College, Kalburgi. Again, certificates will be certificates sent to their mails. So coming to the quiz competition, most eagerly, we had some 16, I think 16, Dr. Haim, 16 teams had participated in the preliminary rounds and 5 teams selected. Out of the 5, we just witnessed the quiz competition. The first prize, as already announced, Dr. Sujim Chaudhary and Dr. Venkatramana Rao from JSS Medical College. So as it's a custom, we have a rolling shield for the quiz competition winners. The rolling shield would be going to the institution and will be taken and rolled next conference as well. Second prize. The runner-ups, Dr. Kushal Achyut and Dr. Praveen Kumar from Vaidehi Medical College, Bangalore. I'm glad at least one from Bangalore. At the same time, I would like to congratulate the other three teams as well, because coming to the final rounds is not easy and doesn't mean bad. So participation certificates will be given to their respective emails, and maybe even the physical certificates can be posted to their address. Moving forward, I request Chairman Dr. K. Manohar. He's got some other awards to give away. Dr. Chairman Manohar, please. Yeah, we always see the tip of the iceberg. Chairman and secretary gets all the credit, but there are a lot of people who continue to work. So year after year, especially during the Suman's tenure, Mr. Pankaj Srivastava, I would like to invite him onto the dais. He's been doing the dog skills program very efficiently, and Dr. Shekhar calls him Dr. Pankaj Srivastava. So one. I call upon Vimala and Nausheen, who have been guiding us a lot through this conference with so many backstage activities, and they were managing the faculty launch very well. We have been seeing all our communications of KRSSDI so beautifully done. And I think a strong lot of applause should go to Banu Kaladhar Reddy and his team. Fantastic job. Working at my speed itself is very difficult. In the last few days, it became so difficult that he stopped taking my calls also. That was the intensity of the work. He has done a fabulous job. Thank you very much, Banu. It wouldn't have been possible to reach people without your support. And the Lava and Kusha of KRSSDI, the Mahesh and Ramesh. So they have been very, very helpful. They have been running, I run for an hour. They were running 24 hours for the last 2 days at least. Come. Thank you very much. Thank you. Delegate case discussion was done wonderfully well by Praveen Gangadhar. I don't think he is around, so we'll get it reached to him. Vote of thanks by Secretary. Or anything else before I hand over to our chairman-elect. This heavy chain is already feeling very light.
So thank you, Dr. Manohar and team, Dr. Vijay, Dr. Javaz, all the members of Krssdi who took part and did this conference extremely well. I have no words to say. It was a wonderful event. From the inaugural session to the valedictory, it's really colorful and it's brightening. So you have made me carry a heavy load, which I don't know whether I can really feel or make it happen in Mysore, but definitely we'll try our best to see that the conference in Mysore comes out very well. So next year, we will have our conference, the 20th conference in Mysore. So we welcome you all for a splendid extravaganza, both scientific as well as cultural in Mysore. So welcome you all for the conference. Thank you, Manohar, again for giving us the
I once again appreciate the entire team of Krssdi led by Manohar, Vijay Kumar, and all the team have done a wonderful job. And in every area, as Ravi Kumar was telling, they have made his job tough for the next year. Congratulations to the success of this conference in a different way. And everybody need to be appreciated. I cannot take name. Right. First Krssdi was done in Mysore, in Lalit Mahal Palace. It received the blessings of our Swamiji who came as a guest to bless us, and that's how the story started. The 19th one is happening today. 20th, though after 20 years and 21st year, it will be happening again in Mysore. So we invite all of you, and all of you keep guiding Ravi Kumar and his team. Yes, yes. Yeah, he was the organizing secretary at that time. I was the state chairman. So Narsim Shetty was the state secretary who saw the meticulous way in which it has to be organized. He taught them the meticulousness of organization. This is freedom given to the team. They excelled in all directions. Thank you all.
Yeah, before I conclude, there are small mementos which are kept as decoration for the last 2 days. So recently I was thinking that we spend a lot of money on this decoration and it goes waste. So they're all stickered and small pots. All are free to take them home as mementos. So it saved us the cost and it will carry good memories home. Thank you very much, everyone. So please carry your good memories here. And then in 5 minutes, we'll start the AGM. Vijay?
Yeah. So yes, the 2 days of extreme scientific discussions and extravaganza, everything, and even the debates, everything made us learn a lot, and we are taking home many things to do, in fact, with a pledge by Dr. V. Mohan. So I would like to thank everyone, all the delegates who attended this conference, made it a big success, and all the faculty who really gave their time, took their time, came all over and gave their excellent inputs. And also, finally, I'd like to thank all the organizing committee who has done an extreme job to uphold this 19th annual conference at the 20 years of KRSSDI. In the end, I would not to forget the pharma companies, all the companies who have sponsored and helped us to come to this big success. I'd like to thank the venue, the Capital Hotel management team, who have been very kind enough to serve us all through the 2 days. And not to forget the audiovisual Skyline, who have done a great job and without any glitches in technology. Well, if I had forgotten anybody more, I would be sorry for that. And then definitely we are thankful to everyone here who have been here all these 2 days. So with this note, I would like to end this conference, and we'll see you all back at Mysore. Thank you. So now we are going to start the annual general body meeting. I request non-members can leave the hall. You can please take the pots. Please take the pots.
With respect to the cultural activities and a twist to the lunch and dinner, Srihari requires a special recognition. Very good job with Kiran. And I would like him to present a token of appreciation to people who are supporting him.
I thank my staff, Suma and Usha, for helping me out to conduct this conference. Thank you very much. As a token of appreciation from all of us, please kindly accept our token.
So I request only the members of KRSSDI to be here and the attendance need to be signed. So the fag end of 2 days, 2 very satisfying days, 2 very enjoyable days is what I would like to say. So I would like to call upon all of our main people sitting here. Karthik, Suman, ye je mata. No. To be on the dais, and I welcome everyone. I hope all members only are there. So we presume that we adjourned the meeting 10 minutes back and we restarted it. So you can note that as a point. So, as I said, the fag end of 2 academically exciting days, and also there are a lot of cultural events, great speech by many speakers, orators, patrons, delegates. Thank you for being there. So, welcome all of you to the AGM. The minutes of the meeting of the last AGM has been distributed. By the time you finish reading it, I will welcome the secretary to take over. Sorry for the delay, just 2 minutes, just loading the pen drive. Okay, I'll read it out. So welcome all, welcome done by Chairman. The last 1 year, the 1 year what happened is what we are going to brush through this report. The year 2022 to 23 or 24 is what is the question. That was the confusion from it started with. So new chairman, Dr. Manohar KN, took over at the AGM last year, 2020, in October 2022 at the conference 2022. But there was a confusion when the term would start because the central RSSDI came up with a new
amendment of doing an online election, and the term would start from April and end to March. So the term will be at that question. So still Suman and Manohar both together was there. So officially he took over to be the chairman from April 2023. And election for the past chairman-elect was done in February 23. That was an online election again, and the winner was Dr. Y.S. Ravi Kumar. He was elected as the new chairman-elect. So we had done quite a few good activities in the last 1 year. Firstly, once Dr. Manohar took on, he had a vision to try and do as many activities and with all innovative ideas. The first one was the newsletter, which was actually made to release by Dr. C. Munichudappa, and the newsletter is a quarterly newsletter called Madhuvani. And now at that juncture, and now also, I would like to call upon all the members to just please contribute to this quarterly newsletter, and more interaction and more appreciation to KRSSDA. And for this, the GC had appointed the editor-in-chief as Dr. Hem Kumar TR. And today, the second edition of the newsletter is already in circulation now. Well, at the same time, then in the beginning, Dr. Manohar had to form task groups for all the activities for this year. For Madhuvani, Dr. Ravikirti, Dr. Suresh was asked to support Dr. M. Kumar in collecting this one, and similarly many task groups were formed. The another activities were Madhumeha Samvada, Madhumeha Patashala, Tingala Belaku, Village Adoption Program, Dog Skill Programs, and also activities to participate with the Central RSSDI. A brief description of each of these would be like this. Madhumeha Samvada, basically Dr. Surekha Shetty and Dr. Srinath KM were the main stakeholders for this activity, and definitely Dr. Surekha had done a great job in this activity. It's basically a public outreach to educate and impart knowledge in the general public. Basically a Facebook live program. It's a series of program, monthly program. Highlight is it is in a local Kannada language. Dr. Surekha showed exemplary work in conducting the program, starting from basics to myths of the treatment to reversal. And this will be continued in the coming months as well. Next is Madhumeha Patashala. This is the main stakeholders were Dr. Karthik M, Dr. Sridhar K, and Dr. Swaraj Vadankeri. And the program definitely took away in a very good mood. It was a unique program by our chairman, so reaching out to the school children and educating them and creating awareness, and also educate their home through the children. Homework given to the children and to help them screen at their homes also. So under this activity, around 20 schools were covered in the last few months. And a big support was coming from Mysore as well. Dr. Y.S. Ravi Kumar contributing in a major way along with Dr. B.G. Godappa sir. So I would also like to appeal to other members to please continue, do their best as nearby any whatever possible schools you can approach, please try to do this program. Tingala Belaku is the monthly CME program, which is nothing new to KRSSDI, earlier started by our past chairman, Dr. Arvinda. Well, we had to continue in the same term as well initially. And in the last 2 months, definitely we were busy with the conference. We will be definitely continuing it in the coming days. And the aim of this activity is to take the same monthly CMEs across the state in all different districts of Karnataka. And dog skill programs, again, this was a unique program started by Dr. Suman, which we continued in a greater zeal, and Suman showed the same interest and is conducting this the whole year, main topics covered was the communication skills in cyber safety and also insurance, and again, many of the other topics that was taken. This to mainly empower the physicians, and it was mainly a virtual program. Rural outreach program, it's a planned program because the confusion of the terms. We had to finish the conference, annual conference, and then get back to the other things. So we have planned for a rural program, will be executed in the coming days. Any suggestions and volunteers are really welcome, and please approach me and mail me for that. And it's not just this, we had several other activities also. Firstly, the improvement and updation of the website, krssdi.in. So please everybody log into this website for regular informations about the newsletters, all the activities that is happening. So getting to the website and communicating to the public was a very difficult task earlier days. Now that we have a proper website, updating this would definitely reach KRSSDI to the larger people, and more members can be added. Again, we also use the social media like Facebook for promotion of KRSSDI, promotion of all the activities, and lot of information. Lot of people are getting onto it. We reach several thousands of likes for this, and basically we are also aiming to do a public info and public education through this social media. Next, coming to the memberships. Last 2 days we have been thinking about the number of memberships that has been happened. Now we are happy to say that we are almost reaching 1,000 memberships. Then Central RSSDI has got 12,000 memberships as of now, and we have around nearly 1,000, more than 950. So again, we had done 2 Central RSSDI, National RSSDI programs in Bangalore in the last 20 years, and our aim was to bring the Central RSSDI program again to Bangalore, but we have been proposing them. I think we will be successful in at least next year or the coming year, but definitely we'll have a bigger chance in the coming year. The participating in this National RSSD conference was not new. Like yesterday and today, we have been knowing, we have been receiving a lot of accolades, and we have also been received the Best Chapter Award for this year. Not only so, basically it was a stall to display. It's called the RSS Day Village, and it was based on points and activities and achievements that was done in the year. And it's a stall display of all the efforts of the team, and the team really worked, and it was showing up there with keeping the Karnataka flag high. We had to display our cultural display also was there, using our peta and shawl, and that was very appreciable for all the delegates who had come there. And this stall definitely showed the display of intentions there. All the people of KRSSDI, what their intentions was towards working and in KRSSDI. This was visited by many veterans, both state and nationals, and that was the reason it was well noticed in the conference. Also, the participation in other activities, we had participated in the research retreat program that is conducted by the National RSSDI. This program basically calls for those who want to propose any research topic, or those who have already done a research and want to present it in some platform. So several opportunities was there, which was conducted in Hyderabad, and we promoted, and we had 2 people participating from Karnataka, 3 in fact. One of them was Dr. Swaraj Vadankeri, is not here. So he's here, Swaraj. So yeah. So that shows our participation in every place in the national places. So there was not only activities, there is more news from the Central RSSD in the last 1 year. There was again passing of the Constitution Amendment, too much of changes in the website and upgradation, a lot of communication upgradation happened. The funds, coming to the funds from the National RSSDI, and they give 5 lakhs of for research and academic activity from the National RSSDI. And they, anybody can apply for a grant in the website, RSSDI, main RSSDI website, and they select the topics coming from Karnataka, and those topics will have a jury. We have a scientific jury in KRSSDI who would be assessing and then accepting which papers are eligible for the grants based on some points. So those people, higher amount will be sponsored by the National RSSDI, lower amounts will be by the, can be sponsored by the KRSSDI itself. Coming to the election process, there was more clarity that they were giving. It is again e-voting, and across, it happens same time across all the states and in the same year, across all the posts, except for the chairman-elect, which happens every year. It is generally an centralized. Online, they have tied up with some company who are very legitimate, and this is there is more emphasis that I have given for, and they say there is emphasis on the opportunity for new candidates and enthusiasts. That should be promoted is what they're promoting. The chapters excellence awards for states has been also discussed. The number of research papers by the state, the number of activities and membership numbers. These are the points they would be thinking about giving out the chapters excellence awards. And also, not but the last, least, but the last, sorry.
He's tired.
We have a good news for this. Dr. K.M. Prasanna Kumar was appointed as the new patron for the National RSSDI. He's again coming from Karnataka. So we best wishes for him. So nothing more to say.
Yeah, one thing I would like to add here is World Diabetes Day, the November, the Diabetes Month. A lot of us have participated in good activities. Sri Hari Kulkarni, Dr. Syed Jawaz, and Baswaraj Patil have done phenomenal works and camps. Of course, there are many more. I'm sorry if I've forgotten anyone. So I think even the drive during that month, and of course it was coinciding with the 3D award, so maybe I didn't mention it as a separate thing. So that is also one important thing which has to be mentioned here.
Yeah, thank you. With this, I end my report here. Now to the treasurer's report.
I'm getting requests for checking out. So treasurer, hurry up.
Everyone has the audit report in hand, and I'll keep it very simple. Thank you RSSDI and its members. It gives me immense pleasure to present before you the financial statement for the financial year 22-23 of RSSDI Karnataka chapter, and the last annual conference which was held here at the same venue under the chairmanship of Dr. Suman was a grand success which we all have witnessed, and we could generate fairly a good amount of revenue in spite of it being a pandemic year. Post-pandemic, many of the pharma companies were not willing, they were not ready to come forward with as much as how much they used to contribute earlier, but still we could generate good amount of revenue, all thanks to Dr. Suman and Dr. Manohar and Dr. Vijay for that, and this has definitely helped us to run the show better. And the total receipt for the last year was 43,04,610 rupees, and the total interest that was earned from the bank, we have an account with Canara Bank because RSSDI, Central RSSDI mandates that we should have an account with Canara Bank, and fortunately we had our account earlier with Syndicate Bank, which is now merged with Canara Bank. So we didn't have to make any changes for that. and the total interest earned for the same amount was around 36,732. The total expenses that incurred were 39,98,305. So we could save approximately 3,03,000 rupees during the last financial year. Thank you. Any questions? 3,03,000. Because we couldn't generate much, and the other thing was all the expenses also went up. Like how it was initially, the pre-pandemic, when you used to book a hotel for any conference, we used to, suppose I take this grand ballroom, they tell me that, okay, if you are taking grand ballroom, you should give me minimum 400 packs. Now it is not like that. They say you pay me 400 packs, plus you pay me rental for this room. So if you are taking for 1.5 days, they charge you for 2 days, which counts to approximately 2 lakhs. So you are spending more than what you used to spend earlier. Yes. Thank you. As on date, sir. As on date, we have an FD that is around 5 lakhs. What was proposed earlier, that FD has been running for the past 4 years. We have not taken even 1 rupee from that. It's lying like that only. And as on date, because we had to withdraw money for the current event, so we are left with around 60,000 rupees in the account. But yes, because no pharma has come forward with their contribution to this conference, so we'll slowly build up the account again. You have to pay advance money and all to run this conference.
Yeah.
So we had good amount, lump sum was there, but we had to give it as an advance amount to most of the events that were organized. So we are not left with much.